Good morning. I'd like to call this roundtable to order. Today is Wednesday, June 28th, 2023. The time is 10:30 a.m. I am at-large Councilmember Christina Henderson, Chair of the Committee on Health. We are partly in person today and also on the Zoom internet platform. This roundtable is also being broadcast live on Channel 13 and on my YouTube page at CMC Henderson. Today, we are holding this joint roundtable with the Committee on Hospital and Health Equity, chaired by Ward 7 Councilmember Vincent Gray, to hear from experts, district agencies, and public witnesses to address the urgent and multifaceted challenges posed by the opioid and fentanyl crisis here in the District of Columbia. At today's hearing, we aim to explore the barriers faced by individuals seeking support and treatment for opioid and fentanyl addiction. Our ultimate goal is to save lives, prevent addiction, and alleviate the devastating impact that this crisis has had on individuals, families, and communities across the district. It is a public health emergency that demands our immediate attention, and its repercussions are felt in our neighborhoods, our schools, and of course, our families. The opioid fentanyl crisis has taken a devastating toll on communities throughout the nation. But here in the district, according to the CDC, the district currently ranks first in all drug overdoses and second in opioid overdoses, deaths per capita. In 2021, the district experienced a heartbreaking total of 426 opioid overdose deaths. This translates to an average of 34 fatal overdoses per month. 57 prescription opioids contributed to these overdoses, including codeine, oxycodone, hydrocodone, buprenorphine, and methadone. Sorry, I'm still working on all of our drug names here. 95% of the fatal opioid overdoses contain fentanyl or fentanyl analog. In 2022, there were 448 opioid overdoses, with 96% involving fentanyl or fentanyl analog. Fentanyl is a powerful synthetic drug that is about 50 to 100 times more potent than morphine, which means that even a small amount can cause respiratory depression and potentially a fatal overdose. A fentanyl analog, also known as a fentanyl derivative, refers to a chemical compound that is structurally like fentanyl, but may have slight modifications to its chemical structure. It is important to note that fentanyl analogs also pose significant health risks. Even small differences in chemical structure can affect the potency and pharmacological properties of these substances, making them potentially more dangerous and unpredictable compared to fentanyl. The Opioid Fatality Review Board completed a study based on 228 cases of individuals who died from opioid overdoses in 2019. Their study found that 75% of the descendants were male, 84% were Black, and between the ages of 50 to 69. I'll say that again, between the ages of 50 to 69. Most were at home at the time of their fatal overdose, and a majority lived in wards 5 and 8. As part of our government response, the Department of Behavioral Health has increased the availability of naloxone. Naloxone is available in many pharmacies and locations across the district at no cost to residents. Various agencies and contractors distribute fentanyl testing strips to district residents. The distribution of more than 150,000 naloxone kits has resulted in a reversal of more than 2,600 overdoses in 2022 alone. Again, 2,600 overdoses in 2022 alone. I'm delighted that this roundtable coincides with the launch of DBH's Office of Opioid Abatement and the establishment of the Opioid Abatement Advisory Commission. These two entities will play a vital role in overseeing the allocation of approximately 50 to 80 million received by the district through opioid litigation settlements over the next 15 to 18 years. The establishment of these entities signifies a step forward in our ongoing effort to combat the opioid crisis, and it's crucial that we work collaboratively across the sectors to make lasting impact. Throughout the course of our discussions, we'll be examining the complex nature of the opioid and fentanyl crisis here in the district. We'll look at root causes, explore societal factors that perpetuate it, and identify gaps in our current response strategies. Moreover, we hope to develop comprehensive solutions that address prevention, treatment, recovery, harm reduction, and support affected individuals, their communities, and their families. Our roundtable will also include discussions of Xyloxine, also known as xylazine, also known as trank. Gonna make myself a little bit, because it is traditionally used as an animal tranquilizer, but combined with opioids such as heroin or fentanyl, individuals used to encounter that individuals use to enhance or alter the effects of those substances. It also heightens the risk of fatal overdoses. I'd like to acknowledge Councilmember Gray for an opening statement. Following that, we'll extend a welcome to any of our colleagues who join us, and then we'll proceed to our witnesses. Councilmember Gray.
Good morning, Councilmember Henderson. This is Malcolm, his committee staff. He just needs a few moments, if you will. Appreciate it.
Okay. While he is waiting, I'll talk a little bit through our ground rules for today. So this hearing will proceed as follows. We will hear from four panels of expert witnesses. The committee intentionally invited experts with a broad range of expertise and perspectives. Each witness will have 5 minutes for their opening remarks before we have time for discussion. Then we will hear from Dr. Barbara Bazaran, Director of the Department of Behavioral Health, Keenan Zamore, who is the Senior Research Epidemiologist for the Center for Policy Planning and Evaluation at DC Health, Dr. Francisco Diaz, who is our Chief Medical Examiner, and then each of the government witnesses will have 10 minutes for their remarks, and then we'll do some questions. We will hear then from the public witness testimony who signed up to testify today. So we'll just pause for a minute. Malcolm, just let us know.
Okay, thank you for your patience. I appreciate it. All right, Councilmember, just so that we don't belabor the roundtable, maybe you can move on, and then when we come on camera, the Councilmember will be happy to read his opening statement.
That works for us. Okay, so we will move. We'll ask the first panel to join us. Ambrose Lane, who is the founder of the Health Alliance Network. Jaren Hill-Lockridge, the Ward 8 Health Council. She is joining us virtually. LJ Sislin, from HIPS board member of Decrim Poverty DC, and Rosalind Parker from Bridging Resources and Communities and the Ward 7-8 DC Prevention Center. Good morning. All right, Mr. Lane, when you're ready. Oh, just remember to turn your mic on. You're first on the list.
Thank you, Councilmember Henderson, for having this important roundtable discussion on the issue of opioids and the crisis in the District of Columbia. Let me also state that I am very happy that you have mentioned this as a public health emergency. The Health Alliance Network, in particular through the Opioid Solutions Working Group, have claimed that this is a public health emergency. In your papers, it describes why we need a public health emergency to be called for by the executive office. And there are bullet point facts on the opioid crisis. And let me just state a few of them for the record. The CME's updated numbers for 2022 are not 448 deaths, but 458 deaths. And let me point out just a number of things. Opioid deaths over the last 6 years have more than doubled. Last 6 years between 2017 and 2022 have more than doubled homicides. 903 homicides versus 2,071 opioid deaths. 2022 saw an average of 38 deaths per month, as opposed to 2021, which is 34 deaths per month, for a total of 458 deaths. By August 2023, there will be more opioid deaths than COVID deaths. Now, COVID has subsided certainly over the last 6 months, but it only took 6 months for the number of opioid deaths to catch up to the number of COVID deaths since March of 2020. You mentioned that DC ranks number 2 in the opioid overdose deaths per capita. DC has no 24-hour opioid use disorder residential treatment facility that treats co-occurring disorders, which is addiction and mental health. DC has no 24-hour youth opioid use disorder residential treatment facility that treats co-occurring disorders. DC has no harm reduction centers for safe consumption. There is one sobering center, and I just met with the executive director yesterday, and I have some things that I'll share in my testimony. DC has no unified registry to track overdoses, treatment, ER visits, demographics, et cetera. Fentanyl and fentanyl analogs have now penetrated, according to the CME's report, 99% of DC opioid deaths, despite 66 to 70% nationally. The heat maps of gun violence and opioid use deaths are virtually the same. So these are just some of the things that I'm going to point out that is in your documentation. In May of 2021, the Health Alliance Network formed what's called the Opioid Solutions Working Group. The Opioid Solutions Working Group is made up of recovery coaches, peer recovery specialists, community groups, recovery training organizations, treating OUD, SUD physicians, faith organizations, family-run organizations, residents, educators, pharmacists, and others. It was created to seek opioid solutions from a community perspective, solutions that may not be included in the Live Long DC program. It is made up of over 26 organizations and 87 individuals. And you have the list in front of you of the organizations that are a part of it. And that does include Live Long DC. We prefer to work in collaboration with the district government. We prefer to work in collaboration with DBH. So they are a part of our meetings, and they play an active role, not only in sharing information with us, but they play an active role in thinking of solutions. So I want to thank Live Long DC and DBH for being a part of the Opioid Solutions Working Group. So I'm gonna not go into too much testimony except to talk about what's important. In our view, there are 3 pillars that have to be dealt with to tackle the opioid problem. The first pillar is government investment and policy. The second is infrastructure, which includes workforce. And the third, which is treatment and recovery. All 3 of those pillars need to be acted on simultaneously, whether or not we're building bit by bit, or whether or not we're providing enough investment to build all of them together out to their logical conclusion. Government investment in policy, there has been some government investment. There has been some policy changes. But the question is whether or not it is enough investment. And I say that there is not enough investment. When we declared that there should be a public health emergency, we immediately said that the mayor and the council should allocate between $35 and $50 million just to be able to stand up some infrastructure within a 6-month basis. And that leads me to the infrastructure question. The infrastructure question, there is some infrastructure. There is what I would call an atmosphere. Oh, I have a wrap up. That was 5 minutes with that fast. Okay, I'm so sorry. I'm so used to talking longer. It's all right.
Well, I'll have some questions for you, but I'm trying to be respectful of.
Absolutely, it's no problem. But we need the absolute infrastructure more than we have now. We do have pieces of it, but we need much more, and we need much more in an immediate sense. The same with workforce, same with treatment and recovery. So I'll stop there, and we can go into questions.
All right, Jaren. Jaren, if you are speaking, you are on mute.
I'm so sorry. I was having some technical difficulties, and you would think after years on Zoom, we'd have this figured out. And let me turn my camera on as well. Where am I? Hey, y'all. I'm Jaren Hill Lockridge, the chair of the Ward 8 Health Council, and I thank you so much Councilmember Christina Henderson, for making this space and inviting me to come and speak today. As you all know, I've been the chair for about 1.5 years, and I say often that I stand on the shoulders of giants. It is because of the leadership of Mr. Calvin Smith and Dr. Walter Frigette that I'm able to stand here and be here with you all today in this capacity. As we all know, when people talk about the Great Ward 8, it's often the last, the least, and the forgotten. But I like to think that our greatest resource is our people, which is why I like to say the Great Ward 8. As my brother Ambrose mentioned, you guys making this a public health emergency is I don't even have the words. When we talk about death here in Ward 8, whether it's the gun violence epidemic, the global pandemic of COVID and all the things that have happened, and now when we hear about the overdoses and how that's impacting our community, there are no words. There are no words. We need all the resources, all the support, all the education that we can have. It's hitting everybody. It's hitting every lane. It's hitting everybody in every community, every moment. And I know that here east of the river, we really need all of the support that we can get between the Ward 8 Health Council, the Health Alliance Network, and the amazing work of Dr. Green. Again, thank you all so much for bringing all of the attention and the support. And we stand ready and with you all to do all the things that we need to do to combat this crisis in our community. So again, thank you all for the time and the space. And I look forward to deploying whatever resources you have available to help us support and strengthen ourselves.
Thank you, Jaren. If you could stay with us for a little bit, I'll have some questions for you.
I'm here.
Great. LJ?
Good morning. Hello. Thank you so much for inviting me to be here today. My name is LJ Sislin. I use they, them pronouns. And I come here today with a background in medical anthropology in which I studied the social, political, and structural determinants of drug use, drug addictions, recovery, and health, and specifically how community groups come around all of those different features in specific localities. I also currently serve as an outreach volunteer and member of the board with HIPS, which is one of the local harm reduction organizations. I'm also an organizer with Decrim Poverty DC, the coalition of 50+ organizations advocating for the expansion of harm reduction services and harm reduction endorsed strategies like supervised consumption, supervised safe consumption, also safer consumption sometimes we say, and drug decriminalization. I feel compelled to also note that the reason that I do all of those things is because I sit here having had faced the darkness of chaotic drug use, of drug addictions, and co-occurring mental illnesses. I've been to rehabs, I've been to sober living houses, and I was an active 12-step member for over 6 years. And I will actually say that all of those things did work for me in my very personal experience. But as it was working for me, I realized that that does not work for everybody. And some of the narrative from the inside from those places was that, they're not working it. It works if you work it. Like if they just brought all of their back into it. And that's just not true. And the state of the drug crisis and the drug supply is just so different from some of the narratives that started when abstinence-based treatment was starting in the US. So it's just a completely different landscape. So I say all that to mention that I bring all of these experiences together, my advocacy, my peer network, the other advocates that I know, my academic background, and a lot of my experiences also from abstinence-based drug recovery to all inform each other and to broaden my personal perspective on drugs, recovery, and drug-related wellness. Abstinence only and tough love or a heavy hand does work for some people. Like I said, it worked for me. But the reality is that like I mentioned, the drug supply is just too different to continue to do the same like low reaching tactics. And for the people that does serve, that's why we still need to keep abstinence-based programming. We need to still like support 12-step based groups and different types of treatment, but we just need to broaden it so that we can help everybody and not just the specific low amount of people that does end up serving. Rather than scratching our heads and wondering why individuals just won't get better, we just need to diversify the approach and we need to include the community. In order to save lives and increase the health and well-being of all people who use drugs, including opioid users, but also beyond, we need comprehensive and multifaceted health-centered initiatives, holistic healthcare, and a cultural shift in perspective that redefines our gaze of the drug user. We must understand that the government has the power to change the current trajectory and also correct all of the mistakes that have happened before. I'm grateful to be here. Thank you.
Thank you, LJ. Ms. Parker.
Good morning, and thank you for inviting me to testify today. Committee Chair Henderson and other Health Committee members, my name is Rosalind Parker. I am a DC and Virginia licensed attorney and a national certified drug use prevention specialist. I serve as the founding president and CEO of Bridging Resources and Communities, and as the director of the Ward 5 Drug Free Coalition and the director of the Ward 7 and 8 DC Prevention Center. For close to 20 years, I have been personally dedicated to providing data-driven, evidence-based drug use prevention education and related services to DC residents living primarily in wards 5, 7, and 8. Our motto is linking resources and communities for healthy living. Our primary focus has been and will continue to be on community level, environmental strategies based on youth-led, adult-guided drug use prevention. Simply stated, drug use prevention is what we do and do well, and our current focus is on continuing to successfully operate a sustainable Ward 7 and 8 DC Prevention Center and Ward 5 Drug Free Coalition with an expanded focus on combining prevention education and harm reduction strategies to continue to work with DBH, SAMHSA, CDC, and our partners to address the district's ongoing opioids misuse crisis. Prevention, and thank you for including prevention, because prevention is often the last thought about in terms of resources when it really should be the first, because we are the upstream resource and we are the only universal resource that links all the other parts on the continuum of care. Preventing the problem saves resources, energy, and lives. Preventing drug use reduces chronic illnesses, deaths, loss of productivity in school, work, and it also helps to prevent ACEs, adverse childhood experiences. In addition to the societal costs and benefits from prevention, prevention also saves money, yielding significant future savings. A 2008 SAMHSA study found that for every dollar invested in prevention could save up to $18 in the future. So we are happy to be here, and I'm personally happy to represent the prevention field, and thank you again for the opportunity to testify.
Thank you. Thank you all so much to this panel of witnesses. I believe Councilmember Gray is ready to join us for his opening statement, and then after that, we'll ask some questions. Councilmember Gray?
Madam Chair.
Good morning.
I'm glad to be here this morning, and glad to talk to you and our colleagues also, who are involved with this oversight roundtable along with you. So thank you very much. DBH has been at the forefront of our efforts to fight opioid overdoses and the related deaths to that. The agency has facilitated and the creation of a sobering and enhanced excuse me, Madam Chair.
Okay. So again, DBH is at the forefront of our efforts to fight opioid overdoses and deaths. The agency has facilitated the creation of sobering and stabilization centers and also enhanced emergency psychiatric services for those in need, while MPD maintains a greater focus on crisis response training. In addition, DC Health has made naloxone more available and continues to drive public awareness of opioid abuse. However, I remain very concerned at the surge of opioid-related fatalities we faced over the last several years. This year, DC Health and the Office of the Chief Medical Examiner reported on non-fatal and fatal overdose rates across the district by ward. Overdoses in wards 5, 7, and 8 were more than double, sometimes triple the rates of those on the west end of the district. This is alarming and warrants addressing. I'd like to hear from the community, invited panelists, and our government witnesses on how or if the strategies being deployed by the district are currently working and where improvements must be made. It is my hope that we can begin to see the reversal of this opioid epidemic in the coming years. I'd also like to hear more about the newly created Opioid Abatement Advisory Commission. The district will receive a large one-time infusion of funds due to multi-state opioid litigation to address years of harm. We need to get it right. This concludes my opening statement. Thank you.
Thank you, Madam Chair.
Thank you, Councilmember Gray. So we're gonna do 10-minute rounds. I'm gonna try to keep myself on the clock. I know my staff laughs because I like to ask some questions. So LJ, I want to start with you. One of the things that you said in your remarks that stood out is that the state of this drug supply is very different than when abstinence-based drug recovery started and was at its height. So what would you say we need to be doing differently to address that the drug supply is 50 to 100 times more potent now than when, even 2014 for that matter?
Right. I mean, part of this is like foundationally, it's just accepting that some people are going to use drugs no matter what. And that's a hard thing to address because it's devastating. Like, trust me, I've lost so many people. I'm shocked I haven't lost my own life to some of this. Like, it's a difficult thing to wrap our heads around, but it's been happening since before written history. Like, people have always used drugs. And just because the supply is terrifying right now is not always, it's not always logical, like why we use drugs. And sometimes it is very logical. It might be about pain. I mean, and it's not always just survival. Sometimes it's joy. Sometimes it's just what was around. Sometimes it's community building. Like, I mean, I'm talking broadly about drugs, not necessarily just fentanyl in that moment.
Right.
But there's so many reasons why someone might use drugs. And it's just accepting that that is a reality. That's kind of the foundation. Of course, prevention still sits in there. That is absolutely still part of this. But like when we accept that people will be using drugs for a variety of reasons, then we can efficiently do specific prevention for our specific area also, which is one of my concerns about some of the sobering center stuff is that it is an outside contractor because this is so different for every space. But I'll keep it to where we're at. Outreach, mobile outreach is so important.
So when you say mobile outreach, and Ms. Parker, please feel free to sort of jump in on this because of the work that you all are doing around youth, et cetera. Is it people showing up every day to establish that relationship? Like, what are we not doing that we should be doing better for our prevention efforts to have a bigger impact?
I'll say quickly on harm reduction outreach, when I'm thinking about like the HIPS mobile van or the family medical van, where there are very harm reduction specific strategies like the syringes, wound care, pipes, stuff like that. Having a consistent workforce is very useful because then people will trust you and then there's actual trust. And so much of this is really like, it's going to sound a little woo-woo, but like the compassion and the trust. And then people like want to get better when they see that people actually care about them or see the consistency. That's the literal consistency of being able to see the same van on the same block. And also the makeup of the people that are in the van. And a lot of these programs are run by volunteers or run by people that don't have consistent funding. So then there's a lot of turnover. Thank you. So consistency, and then having any outreach, whether it's like community-based or like supply-based, prevention, education, any outreach, having people that look like you, having people that experience the same things as you. Like end of the day, I think that people do appreciate having anything, but like that, just like one-to-one, when it's like, oh, you get it because you were me. You're just in a different spot now. Like, and then that also creates a different level of mobility, but like just from like the supply is so different, being able to trust the actual outreach workers is huge. It changes everything.
Ms. Parker and Jaren, if you want to jump in, I don't want to miss you on the screen.
Yes, so and we agree with that because when we look at prevention, we definitely look at primary prevention for the non-user, overdose prevention and harm reduction for the current user, and secondary prevention for the former user, and we work for folks in recovery. So we look at the whole continuum of prevention, but in terms of youth, when we think of primary prevention, it's not so much about the drug per se, because the drug of choice is going to change. It's really about making that investment of, again, what was alluded to earlier about why people are using drugs, whether it's to self-medicate, to escape the stress, maybe an undiagnosed mental health challenge, we're so happy that on a national level, that ACEs, the Adverse Childhood Experiences piece, is now being really incorporated by SAMHSA and CDC in a way that it wasn't referenced before. One thing that COVID has shifted, those of us that do drug use prevention are now having to deal with more of that mental health co-occurring component. And it breaks down some of the silos between mental health and drug prevention and drug treatment and mental health treatment that have been existing, to finally starting to really synthesize the whole wraparound concept and really to teach young people not just about the harmful effects of the different drugs, but the coping mechanisms, the different strategies of if they're stressed, what else they can do besides turning to a substance. And really, we find the most effective way is to engage them in fun activities while we're also educating them. So, you know, whether it's taking them bowling, roller skating, or doing a positive, we call it Rock That Mic, where they do like poetry slams, but it has a prevention theme to it. Or we bring out DJs that also talk about, you know, what's going on in the community and in the positive messaging piece. I will say this, doing those kind of activities that have been very successful, of kind of like partying with a purpose, where you can bring people out and then have a discussion with them, has become much harder because of our current funding restrictions. HHS in December, I have to stress this, I know there's not a budget hearing, but HHS in December has prevented us from, through our grants, from doing food, entertainment at all. Like there used to be a cap, now it's totally gone.
Federal funding,
Yes,
not
but-
DC Health.
But the DC money is passed through, so it all comes from HHS. So
Got it.
all of our funding is pass through money,
Okay,
because it's still, the origin of the money is HHS.
right. But I think the question of, there are lots of other programs that we do where there's a federal component and then we have our local money that has completely
Right,
separate rules.
exactly.
And so
but-
are
yeah.
you saying that we don't have enough of local money that
Right,
allows for this type of
exactly,
flexibility? Got it.
Exactly. So
Okay.
right now, our hands are very tied from doing any food, entertainment, or even promotional items. So this has been a very tough summer, because if I hand out just pamphlets and I can't do our water bottles and our bags and other things that may even have prevention messaging on it that people like, we can't do that right now. So that's, I know that's a kind of a separate issue for a different hearing, but it all ties to what we can be doing better. Is we knew those kinds of things worked.
Yeah.
And if we can't bring out, you know, a go-go band with a positive message or a DJ with a positive message to be the draw.
For,
And
you got to bring people in the room if you want them to hear their
Exactly. And
message.
even on social media, we partnered with the Don't Mute DC movement. I'll end on this point, where we got 100,000 views of an opioid focus event where we had a panel discussion of experts like we're doing now. But in between, we had DJs and bands, and even they shared their own adverse childhood experiences, their own experience with opioid deaths and overdoses. So the messaging was very positive. It all stayed on theme, but people also had a good time. We can't even do that right now because of the current funding. We can't even repeat what we know worked. And we got 100,000 views on Facebook for something that had a prevention facts being put up online and stuff that
Right.
would have never gotten those eyeballs had we not. done
One
it
quick
that way.
follow-up, and I see you, Ambrose. What age do you start?
What age do we start? Well, for us, I mean, officially it's age 8 and then up, but I mean, my staff is trained to work, I mean, little kids, and it's not so much about the drugs at that stage, it's about the self-esteem building and just,
Yeah.
you know.
Because I'm
just-
sort of thinking like,
yeah.
if you have a kid who is stressful, et cetera, but is exposed to say like, hey, swimming.
Right.
And then that becomes the moments I get stressed, okay, I'm going to go to the rec center, I'm going to do some laps.
Right.
But we're starting the prevention practice before you're even introducing drugs to the piece. Sharon or
Like breathing
Amber?
exercises, meditation, we get into arts therapy with them where they can draw if they like to draw. Some people like to write. We meet the kids where they are and then utilize that to help our prevention messaging and campaigning.
Sharon or Ambrose?
Jaren, if you wanted to go.
I absolutely did. I want to follow up on the outreach piece and the importance of having people that look like you provide the messaging. You know, I think especially here in DC, we see so many students come through with their classes and their surveys from all across the world wanting to like message and research on us. That's not I don't think that's the most effective way to do things. I think it's really important that we have people that look like us who have lived experience in these places, you know, and in this really doing the outreach and the education pieces. I think the each one teach one method works really well. So I'm really excited to see ways that we can make sure that we have folks that look like us with our lived experience or similar experiences coming into our community to do and get in the contracts with the prevention and the education and outreach.
Yes, let me just point out, because I know Roz will not point this out. There has not been an increase in the local dollars in the prevention center since 2017. And let me just highlight as well, the prevention centers, and there are 4 of them, they're required to cover 2 wards. So they have to do prevention education to cover 2 wards with a very small staff. And with no increase in their budget, it is literally difficult, almost impossible to do the type of education and outreach that is necessary on substance use and drug use prevention. And prevention is upstream. We all talk about moving upstream. Prevention and education is upstream. So the more prevention education there is, the more you're going to have an effect on those would-be users, those who are thinking about it. You have prevention education that reaches communities, but you can't do it with a small staff and no budget.
How many staff do you have, Ms. Parker?
Well, we have 2 different funding sources. We have the block grant, same as the block grant, and then we have the D-Course. So the bottom line is, because I also have part-time staff, but it's about 4 to 5 FTEs total. I mean, it's not
4 to 5 FTEs covering.
2 wards. Right.
Okay.
Yeah, it's not a lot.
Mhm. All right. I'm over my time. Councilmember Gray, do you have any questions for this panel?
Very much. I'm glad to hear the feedback that we've gotten from the panel thus far, and if they can continue to talk about how we can react or involve others around the city, I want to feel comfortable that we're doing that. So. Can the folks who already testified talk about what they believe we can do more effectively than we've done thus far?
Yes, there are several things, and thank you, Chairman Gray, for your question. First of all, let me just state that opioids and addiction, mainly at its core, is a mental health condition. Addiction is a disease, and it's not a lifestyle choice. And there are several things that need to be done. First, let's talk about in the immediate. In the immediate, I have suggested both to the mayor and to Dr. Bazran and to Director Turnage that within 6 months, the district, through funding, can stand up a harm reduction and safe consumption site at the St. Eastman's shelter. There's already opioid overdoses going on there. There's already overdose deaths going on there. St. E's, as a neighborhood, is actually ranked #1 in terms of the non-fatal overdoses. So we know that it's going on. To stand up a harm reduction and safe consumption site there is easy. What's going to be difficult in the future is the fact that the budget is now going to call for the closing of the hotels where they are housing those that are homeless, and they're trying to put them back into the shelters, and that's just not going to happen. Most of those people are going to go right back out on the street, and we're going to have an explosion of a problem come next spring. I can tell you that right now. The second idea was there are a couple of ideas. So the second idea was to create at United Medical Center.
How can we stop those things you just pointed out, Ambrose, if you don't mind?
I'm sorry, what was that?
How can we stop the issues that you just raised?
About the hotels that are going to be closed.
Yes. Yes.
Now I'm going to scratch my head on that one. I do think that, again, when we talk about funding, we need to find emergency funding to keep those doors open. Even when we talk about recovery, the most important aspects of recovery are either a job or housing. Those are the 2 most important aspects of it. We do not have any kind of job pipeline for those that are in recovery to maintain their recovery through having work. We are making headway in terms of housing, but it's not housing alone that will keep people in recovery. So when we're talking about the hotels that are housing the current unhoused people, and putting them into the shelters, you're going to find a significant number of them that don't want to go back into the shelter. Otherwise, it would have already been in the shelter. So what are we going to do? We're going to create another scenario where there are tent cities. We're going to create another scenario where addiction is exacerbated, because we know that amongst those that are unhoused, there, and LJ can certainly speak to this, there is a significant portion of the unhoused that have both mental health conditions and have addiction. And so that's going to exacerbate the problem. So we need to really think about how we're going to keep those persons safe and off the streets. That's going to be absolutely critical in this whole addiction cycle. The second idea, though, is at United Medical Center. At United Medical Center, like the model that's in North Carolina, United Medical Center can become what we call a urgent care center for behavioral health and substance use disorder and opioids. They have a model in North Carolina. It is a diversion from the emergency room. And as you know, Councilmember Gray, the emergency room, when people go that have opioid overdoses, it drives up the cost exponentially. Each time that a person overdoses and goes to United Medical Center or any hospital, it drives up the cost for the District of Columbia by the millions of dollars. And so by diverting that through an urgent care center that's specifically for behavioral health and specifically for substance use disorder can go a long way towards driving down those costs and reinvesting that money in the infrastructure that we need. As I mentioned earlier, there is no youth residential treatment facility east of the river that's 24 hours. There's not even one in the city that's 24 hours that treats co-occurring disorders. We do have an adult residential in PIW, but PIW is all the way up in Tinleytown. The problem is not in Tinleytown. The problem is in 5, 7, and 8 mainly. And so we need to have that infrastructure in place in east of the river. I've even identified a location in Ward 7, but there are other locations that we can work with DGS, we can work with DBH, we can work with the mayor in identifying a location where this makes sense. So these are the things that we're talking about, and we haven't even gotten to the workforce. As I mentioned, I met with the executive director of Community Bridges, who is who has the contract to do the sobering center in the district. And we had a wonderful discussion about what is happening in Arizona. Arizona is using DC has an 1115 waiver. Arizona has an 1115 waiver. Arizona's 1115 waiver is being used specifically for workforce, specifically to pay peers. They're even beginning to train peers as community health workers, which enhances the ability of peers to provide services for those that are addicted. There are so many, this is such a big onion that we have to unpack, sir. And there are so many layers to it. The District of Columbia, I propose, needs a second 1115 waiver, or at the least an expanded current 1115 waiver, which is up for discussion very soon and is going to be renewed in 2024. So we really need to have these discussions. I think that the Opioid Abatement Commission is the location to have these discussions. I had a great conversation with Dr. Bazron and Wayne Turnage about two and a half weeks ago. And it was a great discussion. So we are moving in sync. Now, as far as the public health emergency is concerned, Dr. Bazron, and she's here, she can speak for herself, but she said, let's see where the Opioid Abatement Commission is going to go. And I thought that that was reasonable. And if the Abatement Commission pushes that we need a public health emergency, then she will move in that direction. And I thought that that was, as an advocate, I thought that that was reasonable. And so I'm being patient and going to see where the Abatement Commission goes. But some of these things can be stood up in the 6-month time period. They don't have to wait 2-3 years to put a harm reduction center. There's a second harm reduction center that HIPS is talking about. And then there is the urgent care for opioid use.
What do you think, Ambrose, what do you think needs to be done to address some of the issues you just raised already in your testimony?
I think that I had mentioned, Councilmember, I had mentioned 3 pillars. The first is government investment and policy. I think that we're working, that area is working. It not completely, but it is working. There is movement in that area. The ecosystem that we're talking about is being brought together. But the question for me, as an advocate is that, is it being brought together fast enough to curtail the growing explosion of opioids? Last year, we
Yeah.
had a record amount of
Yeah.
opioid deaths.
Mhm.
And this year's numbers look on par with last year. We just had the report meeting, and this year's numbers look like they are on par for the numbers that we had last year, which was a record number. So we have to move a little bit faster. It's not a question of whether or not DBH is doing anything, because I don't take that view. It's not a question of whether or not government is doing anything, because I don't take that view. I take the view that we have to move faster, or else we're going to reach a tipping point. And I'll give you one last example. This year, and we are only in June, there are just as many opioid deaths of people under 16 years of age than there were in all of last year.
Mhm.
So we know that younger and younger people are being exposed to this. We know that the 20 to 59, but 20 to 59 age group, all of those age groups are growing in the number of deaths, every single last one of them. So it is growing among younger people. It is growing in the 16 and under age group. So we have to get around it before we get to a tipping point, and we won't have anything to arrest this problem.
Do you believe that we are focusing effectively enough on this issue at this point?
No, I don't believe that we're focusing effectively enough. In those three pillars, there's work in each of those three pillars, but those three pillars are disjointed. They are not coordinating between those three pillars. There's no real coordination between development of infrastructure, development of workforce, government investment, and treatment. Right now, I had someone approach me about trying to help them push a treatment for substance use addiction with a patch similar to an insulin patch that you can put on the back of your arm, or you can put, on your shoulder. They have something that you can put a patch that distributes Suboxone, or it can distribute buprenorphine that will help with addiction.
That would distribute naloxone?
It can, yes, exactly. It can actually distribute naloxone as well. Yes. So these are new technologies. We need to be looking at new technologies. There's a new technology in Tampa. We're trying to see whether or not it actually works, which is neuroregulation, advanced neuroregulation. I just found it.
Neuroregulation?
It's called advanced neuroregulation. And so I don't know if that works, but it's something that we need to take a look at. We need to take a look at all the best practices that are happening from the region and around the country. Both Florida.
Are there additional issues?
Councilmember Gray.
Are there additional issues that are being focused on by your colleagues that we can focus on as well, Ambrose?
Yes, there are additional. So I listen to the physicians that treat. That's who I get my information from. I'm not a doctor, but I do listen, and I listen to as many physicians as I can. I don't listen to just one. We have at least 6 to 7 physicians in our opioid solutions working group, and they all are treating people right now. And so they are giving me the expertise that I can then use to advocate for new treatment methods, new best practices. I have several people that are in recovery, that are recovery specialists. As a matter of fact, I was offered to be trained as a recovery specialist, which I'm going to take Mark up on.
Thank you.
And
appreciate that.
Councilmember Gray, we
Yes.
have some physicians who are coming up in the other
Yes.
panels. We're also over time. I'm
sorry.
trying to be very respectful. If you have a second round of questions, we can ask for that, but we've been joined by Councilmember Louis George, the Ward 4 Councilmember. Councilmember Louis George.
Thank you so much, Chairwoman Henderson, for hosting this important hearing about this very real crisis in our city. And I want to thank this panel. Lane, I spoke to you before, but JR, I really appreciated your testimony as well. I want to talk about these harm reduction and safe consumption sites, particularly. I did make a budget request in my initial budget letter for us to stand up one of the harm reduction and safe consumption site. And I went to New York actually to visit On Point, New York City, which they have 2 safe consumption sites in New York City. and harm reduction centers. And I have to admit, I was very apprehensive initially about what that was going to look like and whether it was going to be effective. And I was blown away by the effectiveness of those. And it goes to what you all were saying about some of the reasons why. One, it was a safe space. It treated individuals as if this was a mental health crisis, that this was a health condition, and they were not stigmatized. They had spaces and places to be able to be there. They had wellness centers. They could get sleep safely, get massages, get mental health support. They had spaces where they could wash clothes, take a shower, and feel safe. And they had safe spaces for safe consumption. And in the safe consumption space, particularly, there were EMTs who were trained specifically on overdoses. And that meant that they didn't have to use a full-fledged naloxone to sort of if they did have an instance of an overdose happening, they could use a measured amount to ensure that person was okay. And at their consumption sites, they haven't seen there have been 0 deaths since they've opened these 2 safe consumption site and harm reduction centers in New York City. And not only has there been 0 overdoses there, the community initially the community was apprehensive about it, but the community saw the benefit. So in New York, across the street from one of them is a park. Historically, they would collect about, I think they said like 13,000 syringes and needles in the park. The park became unusable to New York City. When they put the harm reduction center and safe consumption site across the street from there, everyone went to the harm reduction safe consumption center. That park is now usable. Syringes aren't found, things aren't found there, and that community is using that park. Families are playing there. It has become a whole new thing and a game changer, which has sort of changed the community's sort of fear about it. And thoughts about it. And I think we're going to have to think out of the box and be bold in this moment to address this crisis. So I wanted to ask you sort of about, in the district, I know, Lane, you've been talking about this for a while. What has been the response to a harm reduction center and safe consumption site when you as a community member have talked to our community and our government workers about this as a solution?
So is there an echo? Okay. So let me first say that On Point NYC, that didn't happen overnight. There was a lot of work that they put into prior to opening up that safe consumption site. In Ward 7, there's Marvin Gaye Park right on Division. It's actually nicknamed Needle Park. I know that HIPS is very familiar with it. Of course, I'm a Ward 7 resident. I know about it. I was just over there a couple of weeks ago. The reason that we suggested that the first harm reduction safe consumption site should be the St. Eastman shelter, first and foremost, it's not directly within a neighborhood. It's kind of off the path. It's in St. E's, but it's not directly in the neighborhood. There is so much more work that would have to be done in terms of outreach and education to the community to really put one more directly in a neighborhood. And so I know that people would be reticent to have one directly in their neighborhood, mainly because of stigma, because people just don't understand that this is a disease, that there's a mental health component to it, and they don't want those kinds of quote unquote people around where kids may be, where other adults may be. And so we have to figure it out. So that doesn't mean that we shouldn't have them. Those are 2 different things. That's why I'm suggesting a minimal investment. You wouldn't even have to spend $5 million to stand up a harm reduction safe consumption site at St. E's. You can put all of the things that you just mentioned that NYC On Point has right at that site. And then if you do that, then you can tweak it. You can, flush the bad parts out to be able to take that to another site where it's not going to be directly in a community until, while at the same time, the outreach that ROS does, the outreach that other organizations do like HIPS, and the education takes place to make it more amenable, make it more understandable to community residents that you can have this type of facility and function safely as a community. We have to teach our residents to rally around those with addiction, not to ostracize those with addiction. That's the basic problem. And so if we're able to do those things simultaneously, then we'll get to a point where a community that is suffering badly, such as Bellevue, such as Columbia Heights, such as St. E, such as Congress Heights, that are suffering badly, they'll be more accepting of a harm reduction site because they know what it'll produce. But we can't just plop down a harm reduction site in any neighborhood. It doesn't work.
Got you. And thank you. I appreciate that feedback. I was thinking sort of in the, wards 1, 2, and 4 also sort of are the whole city. No ward is sort of not subject to this opioid crisis right now. And I was thinking over by Howard Theater. Actually, if you go to that Shaw neighborhood around Howard Theater, you'll see so many people out there. And I saw they had shut down the CVS. I said, can we put a temporary harm reduction center here? But I hear what you're saying is sort of how we have to progress this and process this as far as having at the men's shelter, showing its effectiveness, and then putting in a community. So I appreciate that feedback, actually. And I think that is important. So thank you for that. I think our goal here is really to just help people and do it in the most effective way and open our community. So I really do appreciate that feedback. I wanted to ask LJ, you talked about this. If we do, wherever we do harm reduction centers, I think having credible messengers and community lead is critical. Can you speak to why it's so important for our Department of Health to really engage with community partners and credible messengers to be able to be effective in their work?
I'm trying to find, thank you for that question. I'm trying to find the most appropriate way to describe this. I mean, why would the people of DC that are struggling with substance use disorders trust the government? Why? It's the crack epidemic. It's only until okay, now white suburban people. And of course, from the national conversation, right? And then we start shifting into this public health messaging. I'm very glad that we're talking about public health emergencies again. Of course, the makeup of DC is different than the entire nation when we're talking about it so broadly. But it goes back to the other part that I said and that Jaren echoed and that has been mentioned by other colleagues here, is that having people that look like you, having people that are from your neighborhood. And that also means allyship can occur, right? There's some things I mentioned, I disclosed that I have lived experience, but I'm not a Black Washingtonian in Ward 8. But there's these allyships that can be made. It doesn't have to be one specific person that holds everything. It's making cross-community connections. It's playing to where people have strengths. It's people also knowing their strengths. That's a little more on a personal side. But it's people knowing where they fit in the puzzle and there actually being a place for them. A place that's also not just relying on volunteering, that has funding, that has and then it's that snowball effect, right? You get HIPS connects and then and then we connected with Ambrose and then we'll probably connect. It's just one step in front of the other. And these snowballs already exist. People already doing the work. We're just burnt out. We don't have enough funding. Volunteers can't be consistent. We get jaded. But then when it comes to people really understanding, even without all of the detailed workforce or anything like that, when I'm just walking down the street and I have my Decrim Poverty DC shirt on and people are oh, what's that? Or if I'm tabling, depending on the words I use, if I say, we need safe injection sites now, people are oh, calm down. But if I'm hey, we need a safer place for people to be able to be inside, get medical resources, and also use their drugs, they agree. So a lot of it's just semantics, language, wording, and making sure that it doesn't always have to be a standard focus group. It can just be we were walking around talking about this for 2 weeks and no one was responding, and then we tweak it. And we're already working on that with the campaign, and we will be sharing that with people, some of the language things that we've been noticing. But honestly, in my experience from doing community outreach in Ward 8, from doing flyering in Ward 4, from doing very formal HIPS things, I've actually not had a lot of negative feedback. It's mostly just like, is that even possible? Everyone's like, heck, or yay. Everyone's like, yes, this is great. Safe consumption. Because the other reality is that like all studies in the 200 plus OPCs that exist across the world, overdose prevention centers, it actually makes all of the local communities safer. But you both are right on the point that it's like the evidence is only one thing. And we as people are actually more moved by the stories and our emotions. And if they don't trust that, they don't trust that. And that's real. So we got to meet people where they're at also on, even on the NIMBY side of like, we don't want that here. But the reality is like.
The deaths is really the bottom line. When you drive the point home that as bad as the homicides are in DC right now, we know the gun violence is horrible. Twice as many people have died from opioids. That statement alone, which is backed up by data, causes people to have compassion in a different way about saving lives. This, at the end of the day, we're all committed, and we've been working with HIPS on the Narcan training side, saving lives. And it's stressing the point to people, if you are going to use, do not use alone. Because COVID and the shutdown and the quarantining, that's what spiked those numbers. A lot of people that were found that had died were alone. So whatever kind of center, whatever, I mean, all those details have to be worked out, but the bottom line is you don't want people to use alone. You want, and I think everyone has compassion. People don't want people dying. So that is the key message is to get out that people are dying in large numbers. And that's why our per capita rates are so high. Quick side note, Virginia's numbers are bad as well, but Maryland, we need to learn more from Maryland. Maryland has, to Ambrose's point, the workforce, the infrastructure. Maryland, I don't know the details, but I'm just looking at the numbers. Maryland's numbers are like half what DC and Virginia's are when you look at the 100,000 CDC numbers per 100,000, statistics. Maryland's are half what DC and Virginia's are. So even just right next door, we need to really learn. From what I've heard from people, it's because of the treatment resources and other facilities that were already in place. We're behind in DC and we need to catch up.
Mm-hmm. We need to have a workforce conversation. We need to have a workforce conversation.
Yes. And Councilmember Lewis George, time is expired. We have been joined by Councilmember Zachary Parker from Ward 5, who is a member of this committee. Councilmember Parker, if you have an opening statement or some questions for these witnesses, go right ahead.
Thank you all for joining. I missed much of your testimony because I was in another meeting, but I've had the opportunity to hear from several of you at other hearings and really just appreciate your continued advocacy around this, the push to build a more coordinated care network for residents who are struggling and or just at different places in life. One of the things I would say about this hearing today and why I am so appreciative is one, to the leadership of Councilmember Henderson. We met earlier this year and she said, what is a priority of yours? And this is one of the things that I named, the opioid crisis in DC that I don't think is getting nearly enough attention. And I feel as though outside of this hearing, I'm not here, or this committee rather, I'm not hearing a lot of discussion about it. And so I wanted to say thank you, Councilmember and Chairperson. But I'm also just appreciative of the work of district agencies and partners who are in the trenches. And I'm hopeful that after today's hearing, that this will lead to a framework for that coordinated care that many of you all have talked about. So I don't have questions, but I'm really looking forward to digging into solutions and how we can move the needle. As was noted, we're seeing increasing opioid deaths in the district, and it's only to believe to continue going up. I've shared, I know 2 individuals, a personal friend who died from a fentanyl overdose, and these are college-educated, career-working individuals, not people that are walking the streets, which I think is often the image. And so it is a pervasive issue that is impacting everyone. And I'm hopeful that today's hearing will lead to some real solutions. So thank you all for being here. Thank you, Chairperson Henderson.
Thank you, Councilmember Parker. We're going to do a second round of like 6 minutes because I just have some follow-up questions. If that's okay with you, Councilmember Gray, and then we'll go on to our next panel. And this is just the beginning. We're gonna keep talking about some of these things, but I want to follow up on a couple of things. So one, actually, Ms. Parker, where you were talking about the pandemic leading to the spike. One of the questions I had from an outreach prevention standpoint, because we know from the data from the Office of the Chief Medical Examiner, is that most of the fatal overdoses that we have seen were people in their homes. So how do we do outreach when someone is either has some type of shame around their usage? So, when we think about the demographics of what we're talking about here, right? Black men between 50 to 69, many of them who have probably been living with addiction for quite some time, whether it be for pain management, whatever it might be. How do we connect with those individuals who are not outwardly presenting as I have an addiction?
Well, that's a good starting point, but also we have to realize, as the numbers, as Ambrose pointed out, and the data is showing that we're moving into that younger adult and teen population, that unfortunately it's not just an older Black man problem like it started. So I just want to stress that point. But in terms of getting the people in their homes, simply stated, Narcan. We want even kids, we train kids on how to use Narcan, because we've had kids as young as 8, 9, 10 years old resuscitate one of their caregivers in the home while they're calling 911. So part of that is just that piece, and then really stressing the other resources so that people understand where they can call and where they can get help. Like you said, we have to continue to destigmatize the use. And to Councilmember Parker's point about the stereotypical drug addict, we have to take those labelings off, because fentanyl is in everything. Okay.
Yeah.
That is, and I know Dr. Chapman is testifying later. I know he's going to stress that fentanyl, I mean, now we have no heroin, it's all fentanyl, and people are seeking only fentanyl. So 99% of the reported deaths through March, because that's what they say we have 2023 from the Chief Medical Examiner, 99% fentanyl.
Yeah.
So the pandemic combined with fentanyl, one pill you're done, or one time you're done. I mean, you're dead. There's no trying again. And then because it's being put in things, we have to go back to that old practice of you can't accept anything from anybody, unfortunately, and especially around Halloween, but not just Halloween, but unfortunately, how people bring stuff into the office, bring food in and snacks. You can't accept, because you don't know.
We had that situation at that elementary school where
give you a
gummy
cookie or a
bears.
gummy bear, right, a brownie, anything, and it could have fentanyl in it. You don't know. And so unfortunately,
let me clarify, there was not fentanyl in the
right,
gummy bears. Let me just
got you.
Yeah.
But you don't know. So some of these people who are dying, the so-called professionals that are dying, what they're consuming, they didn't know that it had fentanyl in a lot of cases. So, but just that's my answer to it. And I'm sure our friends at HIPS that do a lot of outreach have
I want to bring in Jaren, because she had her hand up.
Oh, gotcha.
Even from when Councilman George was on. Jaren?
Absolutely. Thank you guys so much. One of the things that LJ mentioned earlier was about like the crack response, the government's response to crack, right? And now what's going on. I think that goes into why there's this distrust for having the government kind of be the lead in how we should respond to this. When we look at particularly how the government responded with Black people and crack so long ago, it's this real... It's a real hesitancy to trust the government and how we should respond now. I haven't seen this type of drug response since the crack epidemic, right? Like, we have not seen this type of outreach, this type of public health emergency just based off of drugs. So I really want to think about how the Black and brown community particularly was targeted by the government, and why there's this bit of distrust for how we should be moving about this moving forward. So thank you, LJ, for bringing that up. I think that was an excellent point that I just wanted to double down on.
And I also want to add that, I mean, speaking onto that to keep going with it, is one of the reasons that the drug user movement in New York City is so strong is because of the Black Panther Party and the Young Lords Party. They were doing harm, they didn't use the term, but they were doing harm reduction in the 1970s. They were like, okay, the government's not helping us. Who's going to save us? We're going to save us. So then, and I don't need to talk to you about this. We all know what they were doing. But and it's because of that direct history that they have holistic healthcare in On Point. They literally named Dr. Matula Shakur that was part of a lot of that movement, a part of the taking over Lincoln Hospital Detox Center, because they were like, they don't care about us. We are dying through these drugs. So we got to take care of ourselves. So we're in a unique position where harm reduction and a lot of these methods that were very renegade, underground, not funded, are funded now.
Mhm.
And this is why I keep trying to say like compassion and movement and community, because like that's what harm reduction truly is. We've just also created strategies like Narcan, syringe exchange. But I only bring all of that up to be like, we are in this unique moment, so we don't need to be unfunded and renegade, but to still kind of honor that the reason why that worked wasn't because of the lack of funding. The reason why that worked was because it was like earnest community engagement from the community by the community. And that's the cool thing. I mean, the thing about DC is we have all these nonprofits, but even the nonprofits have different scales in which they do their community outreach.
Mhm.
And I will say like, yeah, HIPS gets government funding, but like when we're out in the street, like no one's like, you're a government worker, like no one's.
Yeah.
They
Which is
trust
the
us.
thing that we like folks, when
Sorry.
folks come to us and they're like, oh, DC government, you need to do X. And I tell them, I'm like, first off, you don't want DC government running a rehabilitation facility. Ooh. I was just saying, it's just,
No.
there's some things we do well, and then there's some things we don't do well. I will say this.
But there's more that needs to be done. There
Well,
is more.
no, I know and I'm not saying that there isn't. And I also want to say this too, and then I'm going to wrap because I'm supposed to be keeping to my own time and I'm not doing a great job of it right now, but I'm going to do better. I'm saying that out loud so you guys can hold me accountable. Is that when we have these conversations about safe injection sites, et cetera, for me as an elected official, I have to balance out, especially in this like tension political times that we are, these people at the other end of Pennsylvania Avenue who would love nothing more than to say absolutely not, especially because we know how they responded to needle exchange for so long, right? And so I think the thing that a lot of people don't know is that in New York City, much of On Point, it's privately funded. The only thing that the New York City government paid for were the machines for the drug testing. Everything else is privately funded for a variety of different rules and things like that. And so when folks come to us and say, DC government, you need to do X, Y, or Z, I want to have this conversation by acknowledging there are limitations, very real limitations, but we're going to do our best to work within what we got, not to allow them to dictate, but also we have to just acknowledge the realities, especially because of how the writers set us so far back on needle exchange for so long.
But that's why I suggested the homeless shelter, the men's homeless shelter first. A little bit, you're not going to get as much pushback from down Pennsylvania.
They don't want us to do right turn on reds. You think they want to
I
take up
hear
this
you.
stuff?
I hear
They
you.
petty.
I
Come on,
hear you.
Ambrose. Councilmember Gray, do you have some?
I really want to reach out once again to Rosalind. Rosalind, thank you so much for being here and being a part of this discussion. And I really want to hear from you in terms of whether anything is resonating with you in terms of what additionally we need to do in order to engage folks with the efforts that we have available to us. So can you speak to this, Rosalind?
Thank you so much, Councilmember Grant. It's wonderful to see you. Thank you for your time today and your longstanding commitment on our health and our drug-related challenges in DC. So the main thing again is again the upstream piece of prevention is important. It's important to look at comprehensive prevention and not forget the primary prevention part, because we don't want to lose sight and assume, the whole perception that everyone is doing drugs. Everyone is not doing drugs. So one of the things that we do in our messaging, if 65% or 35% rather of youth, let's say there's something that says that 35% of youth are smoking marijuana, let's say, that means 65 are not. So we have to understand that while we do look at harm reduction and secondary prevention and recovery, we also want to keep primary prevention on the table. One of the good things about the reasons that our prevention centers were established was to address some of your concerns, Chairman, about it's a very unique public-private partnership where we are the extension of DBH in the community, and the strength of our prevention centers is our partnerships. We are a founding member of the Health Alliance Network. We partner with HIPS. We have connections that cover the whole continuum of care from prevention through recovery. And so people in the community are comfortable either coming to our staff directly, or as has been pointed out, we have a small staff, but coming through our partners to come to us. And that is the strength of what we do. We link everything through our prevention center to make sure that people get the services that they need. And so to continue that boots on the ground, community-driven approach, Councilmember Gray, I think is the strongest point to stress. And so we have to be very creative. A lot of prevention is like school-based prevention. That's a long conversation for a different time. And I'm going to give you my written testimony for the record later. But a school-based prevention is great, but we got to meet the kids where they are. And a lot of times there's a lot going on in the schools. The day is so structured that may not be the best setting. A lot of times it's not, quite frankly. So a lot of our most successful work is outside of the school. So when you start talking about, well, we're going to put this drug education curriculum in the school, that's great, but don't limit our work to the schools, for example. Let us reach the kids where we can reach.
And Chairman Gray, let me add that there's so much more that can be done. First and foremost, I hear all the time on the radio and I see on TV opioid prevention messages that come from the Prince George's County Department of Health. We see nothing from the DC Department of Health in terms of on TV and on radio for opioid prevention and education messages. This was brought up in the conversation I mentioned earlier that I had a meeting with Director Turnage and Dr. Bazran, and I brought up what was called the 7 Ps of opioid public health emergency. It's by the National Governors Association, the 7 Ps of a public health emergency on opioids. One of those Ps is public perception. And in our conversation, and to his credit, Director Turnage said that he would take that back to the mayor. I said, we need a public a messaging campaign, a robust one on TV, on radio, because that's going to reach young people. That's going to reach people that are at home. Okay, you're not going to have 5 members of the staff of the prevention center knocking on every door to be able to teach people when opioid overdoses are happening in the home, on TV and on radio. That's what PG County Public Health Department is doing. DC Health Department needs to do the same thing. And I said, work with us, work with our community, work with the Health Alliance Network, community-based organizations on developing that messaging and getting it into the metro. Some of that is being done through Live Long DC. And I will say this, I have to give Dr. Bazran credit because I wrote a letter to the mayor and to the council chair last June about the need for Narcan distribution. And she did that. She put Narcan in our public schools. She put Narcan on at our metro stations. She put Narcan at some of the bus drivers, and she's continued. They distributed more than 65,000 boxes of Narcan. But it's so much more that's needed. That's to me, the first step. There's going to be vending machines. There's going to be test strips. So all of these things are part of the ecosystem, but we got to move faster on the other parts of the ecosystem where we will not get our hands around this. And a robust public campaign would be absolutely essential. And I hope that the mayor takes us up on that idea to be able to do TV and radio messaging on opioids.
What kind of response have you gotten to the additional messaging that you have suggested, Ambrose?
Councilmember, I'm just waiting to hear back. I'll tell you this. It's easy if I wanted to be able to lay criticism or lay blame, but I'm not the type to do that. I just don't do that. I actually think that something. I agree. Some things are working. It's just that we got to work harder. And I'll say this. I actually, not only do I like Dr. Bazran, but I think that she is working. And every time that I have made suggestions to her, she has taken them seriously and she has tried to implement those. She
is serious about her work, Ambrose. I completely agree with you. And I hope that we will recognize the opportunity to continue to work with her as we move forward to put our arms around this thing and to try to really tackle it with earnestness.
Yes, and because we always seek collaboration first. The only thing that I am as an advocate, I'm not afraid of confrontation, but I always seek collaboration first. And that's what I've been seeking, collaboration.
Thank you. Thank you, Ambrose. Thank you, Councilmember Gray. Councilmember Parker. Yeah. All right. I want to thank this panel of witnesses for kicking off this conversation. We appreciate your time. We're going to move on to our next panel of experts. Dr. Beverlyn Settles Reeves, the care manager at Howard University Urban Health Initiative and a program manager for Howard University OUD Project ECHO. Michael Greer, Director of Federal Affairs for the National Committee for Quality Assurance. As I say your names, please come on up. Queen Adedusi, who's the policy strategist for state and local government affairs, Color of Change, and Madison Fellows, who's a fellow at Georgetown Law O'Neill Institute for National and Global Health Law. Now, I saw Michael. He in the hall. But Dr. Settles Reeves, you're first, so whenever you're ready. Oh, if you turn on your mic.
Open it.
There you go.
First of all, I'd like to thank the committee for inviting me here. I'd like to thank Mr. Ambrose for making me part of his outreach and working group. So very honored to have that. I'm Dr. Beverlyn Settles Reeves. I have a doctorate degree. I work at Howard University Hospital. I work for the Urban Health Initiative, which is based in the Department of Community and Family Medicine. I'm also project manager for what's called our Project ECHO, and it's actually Project ECHO for opiate use disorder at Howard University. And the ECHO stands for Extension for Community Healthcare Outcomes. And I'll give you a little bit of background on that particular project that we run. I do care management, so I work closely with the population directly and provide services and different levels of healthcare and needs and social needs for patients. And I work closely with our peers who work closely with us, and especially our peer leader, who is responsible for much of our community outreach. I have been in the behavioral sciences for probably about a little over 15 years and came about due to a transdisciplinary research team. So I've worked across the board with many different agencies. I've worked with many different addiction centers and other things related to behavioral health, and got really involved with substance use disorders probably over the last 10 years. I'm a people person in all the work that I've done. I've done research. I'm actually a physiologist by training, oddly enough, but it's that opportunity to work with a transdisciplinary team that brought me into the behavioral health scenario. All my work's been with the population and also with young adults dealing with trauma. And that's when my first experience was with beginning addiction research. So we looked at over 600 emerging adults and looking at biological markers affecting their exposure or being affected by exposure to trauma and violence inside the home, outside of the home. And that's been a good 10 years ago. And I guarantee you many of those population kids now are probably caught up in this epidemic. And so in that, I've gotten more involved with the addiction side. Yes, it is a public health crisis, and we've already are seeing that is certainly determinant. And it's been coming through the pipeline for a long time. It's coming to the headline because it has reached a crisis and explosive scenario. We were early on when I was working with the Urban Health Initiative, a lot of our population were older individuals who had been using heroin for a very long time. And now I'm starting to receive more younger clients. In the last 3 months, that has significantly changed. And while still dealing with our elder population, who is now not only dealing with the addiction itself, but they're dealing with other health issues that have evolved just from aging and long-term use of drugs. And so now that population is beginning to see overdoses with the introduction of synthetic opioids into the population. Many of my older patients early on were very, very afraid when the news came out about fentanyl. And they were trying to avoid it. Now they no longer avoid it. They can't avoid it. It's impossible for them to avoid it. And so now you have the compound situation of them being in the older population, dealing with health issues, other health issues, and also long-term mental health issues. And they're succumbing to fentanyl, which is 50 times more potent than heroin, which was what they were used to using in their younger years. So with both backgrounds, I'm proud to say that I'm able to utilize both sides of the table, not only the research, but the actual human contact and working with individuals. And how I got here is actually amazing, but I am honored to be here and proud to be here too. I think we need to sit at the table and talk about it. And if we don't do it, it's going to overcome more than just the population that's being directly affected. It is definitely collateral damage that comes with this. And it's going to affects every aspect of life, not just these individuals dealing with their own health and mental issues, but it deals with economics. It deals with the healthcare system. It deals with insurance companies. It deals with everything. There isn't any topic that isn't touched by this condition. And so we have to address it. And I think the District of Columbia, in its role in the United States, I think certainly can put a big picture on the table and be the standard across the country. And so I think it's important for us all to be here. I'm glad to be here. Thank you.
Thank you. Mr. Greer?
Always feel weird. Good morning, 4 minutes left. Chairperson Henderson, members of the committee, staff. My name is Michael Greer, and I'm pleased to be here today to provide testimony regarding the opioid crisis in the District of Columbia. I came today as a concerned Ward 8 resident and a public health professional. I am honored to be a panelist of this distinguished roundtable and to continue to advocate for policies and initiatives that will support all residents of the district. Today, I celebrate my Ward 8 anniversary. I look forward to a greater Ward 8 and how our efforts today will help build on a greater Ward 8. My professional role, I serve as Director of Federal Affairs for the National Committee for Quality Assurance. I am privileged to advocate for legislation and policies that impact lives all across America, including right here in the district. But before I was privileged to walk the halls of Capitol Hill, I was privileged to walk the halls of this building. I cut my teeth having discussions with members of council, deputy mayor's offices, and many of the distinguished panelists that are with me today. I served as policy advisor for the Office of the Deputy Mayor for Health and Human Services, where I negotiated legislation, revised and reviewed regulations, and prepped for hearings and roundtables, just like this one, and led numerous special projects. Among two that I'm most proud of are the leading of the data collection process for the justification for opioid settlements in the district, which required us to reach out to every agency across the district that would be impacted by opioid use and collect that data and bring it as a justification for the opioid settlement. Additionally, I served as the audit liaison for substance use treatment for persons who were recently incarcerated. My experience has shown me firsthand that when you focus on a problem, particularly around opioids, you can make a difference. I know that from my time at the Department of Behavioral Health. And I know that also from my time that there are many dedicated staff and leaders focused on making a difference every single day. At the Department of Behavioral Health, I focused on three major things. The expansion of, environmental stability beds, the strategic framework for the DC SSC or the DC Stabilization and Sobering Center, and the deployment of the new DBH mobile unit. My time at DBH showed me that there are challenges within the agency that are known and are working to be addressed. With the influx in funding coming to DBH through the opioid settlement, there are internal operations that need to be addressed to ensure that we will be able to innovate with the new dollars and address the needs of providers and the community writ large. I'm heartened by the establishment of the Opioid Office of Abatement. And I actually led one of the initial discussions with the Office of Attorney General for the legislation regarding the legislation. The incorporation of mayoral, legislative, and community voices will bring accountability and transparency to decision-making and ensure that funding goes where it is needed most. With the right mix, we can drive the innovation that is needed to improve healthcare outcomes and save lives while addressing the longstanding disparities. I would just close by saying, I believe that in addressing this crisis, we can look to utilize a lot of the funding that we have to make structural changes to improve the opioid epidemic and address things from housing to employment, and as well as ensuring that our providers receive additional stability and support so that they can make long-term investments that will allow them to better serve residents that are recovering from opioid use disorder and substance use more broadly. I truly believe that we have a dedicated network of providers here in the district and believe that the Department of Behavioral Health also has a dedicated team. However, in order to be effective with the opioid dollars, there is more support that is needed for administration to make sure that those dollars get to the providers that need them, that do the work every single day. And I know that there's probably going to be a lot of discussion about the changes that have occurred. Though there have been a lot of changes in getting money out of the door when it is needed. There are now a lot more reoccurring contracts and a lot more work that is ongoing. But as we've seen, deaths continue to increase, and we need to roll out new things that are going to address the opioid epidemic with these new opioid settlement dollars. And so I would encourage us to think about that as we're moving forward. And thank you for the opportunity to testify today.
Thank you, Michael. Queen?
Good afternoon, Chairperson Henderson and all the other council members who are present and fellow community members. My name is Queen Adesui. I'm a steering committee member for the Decrim Poverty DC campaign and a concerned resident of Anacostia. I recently joined Color of Change as a policy strategist after spending 7 years with the Drug Policy Alliance, where I advocated on the federal and local DC levels for policies that treat drug use and addiction like the health issues that they are, and work towards addressing the public health impact of drug criminalization. Over the years, I've had the privilege of working alongside various council members and the opportunity to speak before this council, highlighting the wealth of evidence that demonstrates that the status quo of arresting people simply for possessing small quantities of drugs has not only no public safety benefit, but it also inherently worsens our public health outcomes. We cannot properly address overdose in our city without addressing criminalization and prohibition at large. Before diving deeper, I want to remind everyone that fentanyl testing strips and safer smoking and snorting kits were illegal to possess and distribute just a few years ago. I and many others had the same conversation then that we are having now about how criminalization of drug use supplies and the substances themselves make drug use more risky and dangerous, how it complicates the efforts of outreach workers and service providers, how it is evidence to increase the risk of accidental overdose death, and how it's evidence to complicate and extend the recovery journeys of so many. And understanding that drug use and addiction are health issues, small quantities, person use quantities of substances alone should not land you in a cage in DC. The collateral consequences of an arrest, even if it does not result in years of incarceration, has such a tumultuous impact on people, especially people who may be struggling with a substance use disorder and or poverty. Thousands of Washingtonians are arrested each year with drug possession as their most serious charge. And if you guessed it, you guessed correct that the supermajority of people, upwards 90%, that are arrested for small quantities of substances happen to be Black Washingtonians. Ward 8, 7, and 5, in that order, are carrying the entire city when it comes to not only drug arrests, but also overdose. And that is not by chance. That is not because drug use and addiction are concentrated in these areas. Drug use and addiction happens in all wards, with people of all circumstances. This is not an opinion of mine, this is based in data. Drug use happens in all wards, yet according to data from the Criminal Justice Coordinating Council, an independent agency of DC, between 2018 and 2022, there are areas in Ward 3, for example, that did not have a single arrest related to drug possession. This area also happens to also have lower rates of overdose as compared to other areas of the district that happen to experience over-enforcement of drug laws. Unraveling the war on drugs and putting forth policies and infrastructure that actually are grounded in evidence and compassion is no small feat. This is transformative work that requires a multifaceted approach and the same level of investment that we have seen done on behalf of the failed approach of arresting and locking people away simply because they use drugs. Criminalizing drug use is not evidence to improve public safety. It is simply a mechanism that folks are comfortable using to disappear people and issues that we are not ready to properly address at the root. It has never been evidence to reduce drug use or reduce the drug supply. We cannot arrest our way out of these issues. Portugal decriminalized all drugs back in 2001 in an effort to address overdose. And they were faced with radical decreases in overdoses, decreases in the spread of diseases from drug use activity, and a radical increase in voluntary accessing of treatment. Under Baltimore State Attorney Mosby's leadership, our neighbors in Baltimore stopped prosecuting minor drug possession charges at the start of the pandemic. And according to Johns Hopkins researchers, that policy in an 18-month period led to fewer new low-level drug arrests, almost no rearrest for serious crimes for those who had their charges dropped, and fewer 911 calls. These outcomes occurred without even a concerted effort to remove criminal penalties and radically invest in a harm reduction infrastructure that would address the health and wellness of people who use drugs. Johns Hopkins also released a fiscal study that found that prosecuting simple drug possession is more costly than any other misdemeanor due to the requirement of sending drug samples for lab testing in each instance. Even in cases where simple possession cases do not proceed to full trial or incarceration, the costliest stages of the process are those incurred prior to the dismissal of charges. These findings suggest that the policy did not result in increased public complaints about drug use and that those who had charges dropped did not go on to commit serious crimes. The fact that we see people experiencing and dying from overdose within our jail and frankly across the country, even in maximum security prisons, highlights that criminalization and prohibition as a strategy towards a drug-free world is a pipe dream. We, especially elected officials, have a responsibility to accept that people use drugs. We also need to accept the evidence reality that not everyone who uses drugs struggles with an addiction. It's actually a minority of people who use substances at any given moment that is struggling with an actual substance use disorder. In that acceptance, we can more clearly see what is necessary to reduce the harms or risk associated with drug use and the supply under prohibition. Overdose deaths are preventable. Drug regulation and a safe supply ultimately is how we eliminate overdose. People are not dying from adulterated alcohol in our city's regulated bars, for example. Absent that, the roadmap towards improving health outcomes and in turn safety include no longer punishing people simply for possessing drugs, and implementing harm reduction strategies for the entire criminalized drug market more broadly, not just opioids, appropriately investing in 24/7 harm reduction centers that include safe use and drug checking services, and lastly, providing appropriate investments and incentives for community health workers who service people who use drugs, especially those with lived experience. Thank you for your time.
Thank you, Queen. And Madison.
Good afternoon, and thank you for the opportunity to speak with you today. My name is Madison Fields, and I'm a law fellow at the O'Neill Institute for National and Global Health Law based at Georgetown Law Center. At O'Neill, we use the law as a tool to solve critical public health challenges in the United States and around the world. I work primarily with the Addiction and Public Policy Initiative, where we work to advance a public health approach to substance use disorders and the overdose epidemic through legal and policy strategies that promote evidence-based treatment and support recovery. We focus on three main areas to accomplish this: expanding access to treatment for substance use disorder, ensuring governance, accountability, and transparency for funding, and building a policy bench, developing a space for a diverse set of voices to lead the creation and implementation of addiction policy. We continue to prioritize timely and transparent data collection to better inform our steps in tackling the opioid crisis and taking a whole person approach to enhancing the health of our communities. I'd like to take a few moments to address some of the issues before the council today. Real-time, transparent reporting of public data on substance use disorders and overdoses is an urgent issue. Such public reporting of data not only holds our elected officials accountable, it also will help public officials and communities make decisions that reflect today's challenges, not yesterday's. Data collection today can lag, be unavailable to the public, and prevents the type of analysis and data translation that is essential to an effective response. Illicitly manufactured fentanyl has touched just about our entire drug supply in the United States, and other types of synthetic drugs have become more prevalent. What worked a year ago, or even last month may not work today in tackling such a complex and dynamic issue like the opioid crisis. Prioritizing data collection and analysis better informs our approach. It also increases visibility of our most vulnerable populations. We need to collect data on overdose mortality and morbidity that analyzes demographic, like race, age, class, geography, and substances involved, et cetera. We can also use data collection to see the effectiveness of our interventions, like our naloxone distribution and use. States such as Rhode Island and Massachusetts have models that the District of Columbia may look to as you, as city leaders, develop effective data collection efforts. Coordinating timely data collection and analyzing that data to assess needs and effectiveness in our response to this crisis is imperative. In addition to effective data, we at the O'Neill Institute emphasize the importance of a coordinated fiscal response to addiction issues. O'Neill's recent publication, Transcending Money, Ego, Turf, calls for a complete fiscal redesign in our approach to substance use disorder. The report includes guiding principles and concrete recommendations for federal, state, and local governments to leverage this momentum and transform government budgets to incentivize investment in coordinated, targeted, and outcomes-driven approaches to substance use disorder. This report was developed through focus groups and interviews with individuals from varying disciplines, from government, public health, law enforcement, and criminal justice, health, and behavioral health systems. In our report, we recommend policies and programs across all government that support recovery and reflect science and evidence, standardize outcomes for substance use disorder across government agencies, aligning funding for substance use disorder across government agencies to meet a cohesive set of outcomes, and a governance for an ecosystem of care with coordinated data collection. It was critical that we take on a whole government, but also a whole person approach. The social determinants of addiction, similar to the social determinants of health, include healthcare access and quality, employment, the criminal legal system, housing, and preventing intergenerational trauma. Each of these factors inform our quality of life, but can also be predictors for susceptibility to substance use disorder, the accessibility of treatment, and the likelihood of sustained recovery, whatever that may mean to the individual, whether it be abstinence or just substance use no longer infringing on their day-to-day. Meeting people where they are, including individuals who are incarcerated, is a hallmark of this approach. The intersectionality between the opioid fentanyl crisis and incarceration is undeniable. In our publication, Dying Inside, to End Deaths of Despair, Address the Crisis in Local Jails, we highlight the inadequacy of care and treatment for substance use disorders in jails and prisons, while outlining the legal framework for the right to adequate treatment for medical, mental health, and substance-related conditions for incarcerated people. Investing in programs that support these rights, but also offer services for reentry that prevents a disruption in care is extremely important. In all, for DC specifically, we recommend coordinating goals across DC agencies to respond to the opioid crisis, coordinating timely data collection and analysis, standardizing reporting across DC agencies, and aligning funding to introduce and sustain evidence-based programs and initiatives to combat the crisis. Thank you.
Thank you, Madison. And for my colleagues, we'll do a 10-minute round. Madison, I actually want to start with you. Okay. You mentioned the need for real-time reporting of data, which I agree with. Even last night when I was on the OCME's website, the most updated report, while it is dated June 20th, it is March data. So I feel like, I don't even know what's going on for the last few months besides the surveillance updates that we get every now and then, where it's 24 overdoses in 24 hours. Can you speak a little bit about what that delay is causing in terms of our ability to address the problem?
In addressing the problem, one, it doesn't allow us to figure out what works and what doesn't. This crisis is something that we've had different organizations from local, state, federal governments take action in response to it, but it's not always coordinated. And just an example of how data collection is extremely important in changing that so that our response is truly effective. In our response efforts, we've seen a decrease in overdose deaths for white populations as a likely result of our efforts in combating the opioid crisis, for example, harm reduction, accessibility to treatment, but we haven't seen that same decrease in Black and Latinx communities. Data collection draws visibility and keeps us from overlooking communities that are often underserved. So seeing how one response may be effective for one demographic, it might not be effective for another. It's important that we look at it at every level by race, age, whether that person has used for a long period of time, what their home life is like, really drawing on the social determinants of addiction and health. It's important so that we have that visibility to see who we need to help, what they need. But also it's important that lag prevents us from seeing what works and what doesn't. We at O'Neill believe in evidence-based treatment and an evidence-based response. So a lot of our approach is rooted in science and evidence. And that's really important to us,
Yeah.
but seeing what is effective requires data collection, but also analysis.
I think that's important too, right? In terms of clearly something's not working. Because in your testimony, Queen, you talked about like there's drug use that's similar between Black and white populations, not just in the district, but around the country. But when we look at our numbers, it is disproportionately African Americans and Latinx who are dying. So, Dr. Settles-Reeves, what are we doing differently for one population that we're not doing for the other? Is it income-based because more affluent folks have access to treatment when something is wrong, or there's more options available to them where, someone can go away for a bit to sort of get back on track? I'm just trying to understand what resources are available for one that we're not doing for the other that we need to fill in the gaps for.
Well, certainly what you mentioned, this equal distribution of funds and money. In those areas for the affluent, you're going to find more up-to-date, latest treatments. You're going to find more access to treatment centers, providers who are well-versed or experts in the field. But I think access is a big thing. Money does buy the better tools, okay? And in populations, and especially in our communities, we're not always the first to have the funding to get state-of-the-art equipment, staffing, which is critical to have staffing. And maybe those partners who are more willing to accept Medicaid, Medicare, which is a reduction also in terms of payment. So the disparities are certainly economical, and the disparities are cultural as well. We probably get more honesty and more feedback from our clients because they're culturally related to us, but yet and still, they may not get the same truth. Stigma is a big thing. So when you look at an African American with substance use disorder, and you look at a white American with substance use disorder, there's a difference in how their journey is imagined. More negative images are associated with minority populations than in the majority population. And that's been, we can say that throughout history, but it does make a difference in terms of treating individuals. It makes a difference in eliminating stigma, even within populations. The stigma is always connected. Part of the problem also is in terms of substance use disorder, it may be more discreetly treated in other populations than in our population.
Right. Someone went on vacation or they just went away for a little bit.
Exactly. And those centers are generally in very nice communities and
Arizona.
out of the way. Someone didn't, exactly.
Yep.
And we can't afford to always send our patients there, or will their insurance that they may have to have.
Well, so speaking of insurance, Michael, I want to bring you in on this conversation because of your experience at, not just DBH, but AmeriHealth Caritas is, in my understanding, right, there's been this heavy focus on parity when it comes to the behavioral health pieces between Medicaid and private insurance. But in reality, and In reality, we know that's not necessarily the case.
Very true. I'll start from a federal lens and go down.
Okay.
So when we're thinking about what passed, the Federal Mental Health Parity Act that required that there be equal payments for treatment, it was great in theory. Then they realized that no one on the state level actually knew how to enforce it or had the resources, because most states bifurcate their regulation of insurance companies, particularly in the health space. It's always very interesting. You have insurance companies that, or excuse me, your Department of Insurance that has some regulatory authority, and then you have your department, your Medicaid department, that will have other authorities.
It's like DC.
Yeah, exactly. And so there are a few states that have just been like, you know what, we're going to get out of this. We're going to stop this, and we're going to move this authority over here, or transfer some specific authorities to their Medicaid agencies. So that has happened, but I'm not. That's not something I'm advocating for. I want to be clear. That is just kind of what people have done, and so it realized that state agencies have to work together, and then the federal government never developed a framework for them actually to work together. They released a 22-page worksheet and said, "This is what you need to do in order to have parity." And then they kind of walked away. And from there,
Wait, when go back, what years are we talking about here?
so the actual worksheet was released in 2021, I believe that was.
Okay, I'm trying to get who was president then, you know. No. And
The parity law was passed under the Trump administration.
okay.
So that was pushed out. And so, yeah, and it was.
So you're basically saying we've been on the struggle bus. We have this great ideal of parity, but we have not actualized it, which has made it very difficult for state and local governments to implement the ideal.
And to the resource part, state and local governments don't necessarily have the resources necessary to actually enforce that parity. In many regards, you need kind of machine learning in order to look at the rates that are paid for each of these specific services, and looked at their credentialing type, as well as where that service was provided. You have to look at so many different factors. And so you really need, in order to kind of enforce that on a state level, you really need to have a partner that can do that data crunching, because it's big data crunching that you're doing. And you need to be doing that on a continuous basis.
Look at that. She's talking about data, you're talking about that. I love it when it all sort of comes together. I think what you were talking about highlights to one of the frustrations I had, even working on the federal side, is that a lot of federal folks don't have on state and local experience. So they are like, well, this is going to work, but you've never been down there to know, okay, you've given me guidance, but what does this actually mean?
On the federal level, they think all state agencies hold hands and sing Kumbaya.
If only. If only. Thank you for that. We're going to tease on that a little bit more, especially with our government witnesses, because I've even noticed the bifurcation that we have in the district. It works a little, but then we get to these sticking points where you have the Department of Insurance, Securities and Banking, who has health companies, then you have DC HealthLink, then you have healthcare finance, you have DBH who's not getting in on it. Like I want to believe we're all playing in the sandbox and talking together, but sometimes there might be miscommunications that happen.
Could I have 20 seconds just to?
Okay. I'm supposed to be holding myself accountable for my time.
Sorry. I would just say, just on the data piece, there were two things when you're talking about those kind of really nice outpatient treatment facilities, particularly in this area. There is a space issue. You have individuals who have the resources, again, to be able to go and just drop cash, that you have Medicaid programs that are trying to compete with. There isn't that space that you need. To that point, that's why we need to think innovatively and try to understand how we can build more capacity for maybe not the highest acuity, or maybe if that's what we want to do, if we can put together a very comprehensive strategy about building that capacity to address those needs.
Yeah, thank you for that. Be respectful. Councilmember Gray.
Thank you very much, Madam Chair. I wonder if our witnesses could speak to, we have just worked hard to create a new healthcare system. And is there a way we can, introduce our efforts at the local level so that the healthcare process that we are introducing now will be able to get more actualized for the folks that are working with us, especially around the opioid questions that we're raising now.
Well, I would start with a huge chunk of dollars that we're getting through the opioid settlement. This is essentially money without strings. It just needs to be utilized and leveraged more as effectively and as efficiently as possible. I think that one of the things we need to really do is look at our providers, look at our missing capacity, and then develop an actual strategic spending plan for these dollars that invest long-term to ensure that our providers build their capacity and ensure that we build new providers that can address those missing capacity needs that we have for treatment. I was on a panel a few weeks ago and spoke with a gentleman who said they are looking at building new inpatient treatment beds all around DC. And I said, all around DC, why don't you come into DC? Right. You need to come into DC. We don't want to send our residents out. And he said, well, it's expensive. I have to put a lot of money up. I have to do a lot of things in order to operate in DC. Well, I think that we can think about that missing capacity, particularly around some of our inpatient options, and say, hey, what can we do to incentivize that higher intensity treatment to be in the district right here, where we can not only foster the recovery that individuals need, but the social reconnection that will ensure that they have long-term sustained recovery that prevents them from needing that service again.
If I can also, sorry. Just to underscore again, I think it is critical that we have safe use consumption spaces in the district. Frankly, if we are wanting to get serious about addressing overdose, as was mentioned, On Point NYC in their first 18 months of opening, intervened in over close to 1,000 overdoses. Again, that is surpassing how many people we're losing entirely to overdose in the district. And if we want to get serious about that, we have to address safe use. And as someone who's lobbied on the federal level on behalf of DC autonomy, I understand what we're up against in terms of Congress. They've been making it clear that they do not care about the autonomy and home rule of DC, but our folks need it. And I think it's imperative that we actually put up the fight that's necessary to get the services that we need here. So in addition to equitable access to actual appropriate care, and also the variety of care, making sure that people have access and are not being told what kind of treatment they should be accessing, having a variety of care that people can choose from with their provider, without the fear also of criminalization. I think I want to underscore again that criminalization isn't an off conversation when we're talking about health and overdose. Criminalization has a direct impact on our overdose crisis. So addressing the impacts of criminalization as a public health crisis in of itself is going to be necessary here.
But how are we supposed to translate the continuing effort around, not criminalization, I don't mean that much as the concern now with us being able to bring these kinds of opportunities available to people in the city. We have a brand new hospital that's just opened, in a hospital that's just opened within the last 2-3 weeks. Are you all able to speak to how we can take advantage of those opportunities?
Well, I think one of the things within the city are that we have a lot of programs, but everyone kind of operates in silos. So there's not a lot of cross communication amongst providers, amongst institutions when it comes to dealing with choices and treatment. Everyone has ideas, but no one knows what the other is doing. For one thing,
But how do we change that?
well, I was going to mention, for example, the Project Echo that I am program manager. The foundation of Project Echo actually came out of New Mexico. And what happened was in New Mexico, there's a lot of distance between treatment centers and between access to healthcare. And so it started because of the rural areas that, although they had providers there, did not have the expertise to treat certain diseases. And this project came about because a physician who was a specialist in liver disease, a patient living in the rural area who was a widow and who had children and had to work, could not access care. The liver disease was there, but she couldn't get treated. And so by the time she got to the specialist, it was too late, and she succumbed to her disease. So the Project Echo was developed in that there was a hub for an institution or specialist, and then they could project out, or I should say, have surrounding communities where they communicated using a Zoom-based platform, which is what we have, to train, teach, consult in those communities so that those who are on the ground there in those communities and rural areas could actually treat patients and have access to specialty care. Now, although the scenario here in DC, although we are an urban area and a city with lots of transportation and access, we don't communicate. And that is a platform in which you can reach out to someone in this community.
But how do we change that? How do we change that absence of communication that you just alluded to?
We need to form networks with those agencies. We need to form networks with the institutions. We need to form a base. Urban Health Initiative originally was based in the family practice center. So a family practice where the family practitioner sees a variety of individuals and patients with different needs, to include substance use, could actually start at the base there, and then via some sort of a Zoom platform, like we've gotten very efficient in using it during the pandemic, to reach another physician, another provider, a specialist, so that the patient could get the choices and treatment right there and then be followed up. So instant access, not having to wait or try to get the patient there or hope that the patient will keep their appointment, or that, I didn't know that this provider over here provided this service because I was not aware of that. So I think agencies need to be better at communicating with each other to provide services across.
How do we get people to do better with the communication?
Well,
that's an important point. I mean, I don't deny that at all, but
we have to eliminate some of the competition.
Well, okay, how?
Well, I think if everyone at least had operations on a foundational level where you were, a lot of it is competitive funding as well. So, I mean, you have to, in order to sustain your program, you have to have funding and resources. And if one program doesn't have the funding to do the outreach, that could be a problem. But if there was, say, foundational funding for programs and services, obviously we could, enhance that by going competitive. But I think everyone has to not be so closed in and holding on to information simply because they have to sustain themselves. I think if there is a way in which everyone is able to at least operate and build upon that, communication, I think, would flow better. People would be more relaxed, less, less closed in terms of communicating with other agencies, because we have a lot in DC. I've actually had to
do.
make physical connection with people.
But we don't always take it, we don't take effective advantage of it.
Absolutely don't take advantage of it. We're too busy trying to also maintain financially as well. So, you know, you're less likely to want to reach out to someone when you got to keep home base going. So, but I have made it a point to personally reach out to different agencies and make a connection with them. And look, it's also a kind of a bartering thing. I mean, we have an institution where we have multiple specialists. You may have a patient or a client that could use services. I have an InLink, you have an InLink. You may have specialized services that I can use. So I've had to make personal and go out and make personal presentations to different agencies and meet with them to kind of drop those barriers that I am not trying to compete with you. There are plenty of patients out here for everyone. And that we need to share our information and be able to communicate and link to one another. We need a network. We need a comfortable network.
How do we do that? How do we make this happen effectively? I mean, I don't deny your point. Your point is well taken, but how do we do that? How do we make that happen?
Councilmember Gray.
I'd be willing to go and make presentations to people, but it's got to be much bigger than that. It has to be much bigger. We all have to talk.
Councilmember Gray,
Yeah.
I'm trying to hold everybody to their time.
Yes.
And I think you're right on of how, and I hope that we can get there in more conversations. But you are over your time by a couple of minutes. And Councilmember Parker is here patiently waiting. So I'm gonna go on to Councilmember Parker.
Thank you. I really appreciated that back and forth. Ms. Fields, I want to come to you. You referenced your Dying Inside report addressing inmates and the lack of care that they receive. Can you just speak more to what type of supports are necessary? You also referenced Rhode Island as a model, both in terms of data collection. In my cursory review, as you were mentioning that, I was looking and it seems like they're doing a lot of work and supporting inmates and just making sure they transition out of incarceration to care. And so, yeah, if you could just speak and expound on what type of care should we be looking to build out here locally for those who are incarcerated?
Yeah, definitely. So it's sort of a two-pronged issue. Expanding accessibility to treatment while incarcerated, but also continuing that care so that people can integrate back into the community safely and without disruption to their health care. Medication for opioid use disorder is something that has been proven by science, not just saying that, but as extremely effective in treating substance use disorder. So accessibility to those medications while incarcerated is important. There are a lot of barriers, even without the condition of incarceration, to accessing that medication. For example, you have to be abstained for a certain amount of time and different requirements like that. But expanding access to that, I'm not a Medicaid or Medicare expert, but I will say that in like continuing care, like a part of achieving that is ensuring access to that financial support while incarcerated. And there is, their financial circumstances do change from incarceration, their insurance coverage, their Medicaid coverage, their ability to be employed. So it's very important to maintain that financial stability so that they can have access to that treatment. In general, not even just people with substance use disorder that are incarcerated are not receiving the adequate health care that they deserve while incarcerated. It's sort of a population that is discarded a lot of the times because of stigma and people's own personal feelings, but it's important to remember that we do have that right to health care, whether or not we are incarcerated. So I think prioritizing access to medications for opioid use disorder is extremely effective and something that should be a top priority for the incarcerated population, but also continuing that care, offering reentry services when we know that someone is going to be released into the community, having them set up so that they can know what's going on with their financial coverage, their insurance coverage, but also who can they talk to? People who have substance use disorder, like it looks different for a lot of people. There are a variety of services. And when we speak about the healthcare system in general, serving these people, it requires primary care, preventive services, mental health services, counseling for people who are dealing with these issues. And incarceration itself is a proven trauma. People who are incarcerated are generally not the healthiest going into incarceration, and that is exacerbated by the conditions of confinement. So it's important to ensure that accessibility, really hammer down the fact that they do have a right to adequate treatment. It should be accessible, it should be quality. They don't deserve the bare minimum because they're in confinement. That's something that we at the Institute believe in, the evidence-based practice of like medications for opioid use disorder. But me personally, I am passionate about the fact that people who are incarcerated deserve treatment.
No, I really appreciate that. And we know oftentimes those incarcerated and those in jail, it serves as a revolving door. And
it does. And
the disruptions in care and access is a concern. And that is a very concrete next step for us here in DC of something to look into. I really appreciated your emphasis on the transition period, even regarding Medicaid. While one may not receive benefits while incarcerated, we know they're coming out, and how can we get that process started to ensure that they have care once released?
Exactly. And we have studies that have found that individuals leaving incarceration are between 56 and 129 times more likely than the general population to die of an overdose after reentry.
Wow. So even if we focus there, that what I'm hearing you say is that could lead to a significant impact or a significant decrease in those that are succumbing to opioids here.
And there is data collection. I'm not sure how recent, but the time that someone overdoses after reentry is a short period of time, and 2 weeks.
My time is ticking. I really appreciate it. You also referencing the data collection issues and how we can improve here locally. You mentioned Rhode Island. I looked at their drug overdose surveillance data hub, and I just wanted to make sure that is what you're referencing, that portal, and how they're making that accessible.
Yes.
Awesome. One last question before I move on. You referenced ecosystem. That is something that we've heard time and time again. And just how are you all thinking about that word? And if you could just, in layman terms, like what does that even mean, and where can we start? I know what ecosystem means, but like in practical terms, what do we need to do to create one here in DC, and where should we start?
I think it goes back to that collaboration piece across different disciplines so that we can create this ecosystem of care. Sorry to use the word in the definition, but just incorporating, like meeting with like people across different disciplines, whether it's legal, physicians, people in emergency departments, people with lived experience. There are a lot of efforts that are siloed because people don't communicate or don't have the means to communicate. And now that we have this influx of funding with the opioid settlement proceedings, it's critical, like the stakes are extremely high to use that effectively and create an ecosystem of care where someone can be screened for substance use disorder, treated effectively, whether that treatment is inpatient care. A single mother might not be able to go to Arizona, like we mentioned, and receive treatment, but maybe counseling, maybe funding opportunities, different supports in that way. It's kind of, I would say an ecosystem is taking the whole person approach, helping with resources for housing, employment, sustaining their recovery, whatever that looks like.
Thank you. Ms. Adesanya, I really appreciate you always bringing the facts and continuing to push on the fact that we are criminalizing people that really need care. That is a point that is not lost on me, and I really appreciate you constantly lifting that up. Mr. Greer, I wanted to come to you. You were talking about we need to create a long-term strategy and vision for how we're going to use settlement funds, both in expanded capacity, but also to make structural changes. And I wanted you to elaborate on the structural changes that you believe we should be looking at here in DC.
Sure. I would say when I'm thinking through some of the structural changes that are needed, particularly around the administrative portion as it relates to the Office of Opioid Abatement, it takes about 6 months for a procurement to get out the door and on the streets. That is what it is. That is the process. And so when you're talking about competing for that, developing the scope of work, making sure it is reviewed, it is legally sufficient, it takes about 6 months. And then we put it out, or that process can take about 3-4 months if you're lucky. Then you put it out on the street and you can possibly award it that first time. So we're looking at about a 6-month period. If we were thinking about spending opioid settlement dollars in FY24, we would already need to have contracts being developed and being ready to be out on the street to meet the first day of the fiscal year, to actually provide services. It is my speculation that that is not the case. Structural change means bringing in more people to write those contracts and making sure that there is a concerted effort within DBH to streamline kind of the development process, as well as what we're doing in working with providers. I had a conversation with a provider and they explained to me how they had spoke to 5 different people in DBH within 1 week about different grants, different programs, different funding. We can do better with that. We can think about our structure and how we're touching our providers, decreasing their administrative burden, making it easier for them to manage their funds and have the time that they need with the patients and our residents that need them the most.
I really appreciate that. And Dr. Settles Reeves, I'm out of time, but I wanted to just acknowledge your testimony. I really appreciate your contributions to the field, as well as your remarks that you shared. So thank you all.
Thank you, Councilmember Parker. And thank you so much to this panel. I appreciate you being here. And like I said to the other panel, this is the start of the conversation, not the end, but we are going to move on to our next panel, which are SUD, direct service, medically assisted treatment, pharmacy, and peer recovery experts. Michael Pickering, who is the Director of Advocacy at RAP NC Inc. Dr. Osella Parasol, who's the Program Director of Prestige Healthcare Resources. Dr. Edwin Chapman does internal and addiction medicine. And Dr. Tamara McCants, who is the Chair of the Board of Pharmacy and Associate Professor, Howard University College of Pharmacy. All right, Mr. Pickering, you're first. You are not on. Just hit the button on your mic. There you go. Now you're on.
Chairman Henderson, Chairperson Gray, good morning. Thank you for the invitation and opportunity to join today and for your shared commitment to maintaining a vital behavioral health safety net for our most vulnerable neighbors. I am Michael Pickering, Director of Advocacy for RAP Cadencia. I must begin by acknowledging RAP's director, Virginia Reed, and the team at RAP who report every day in person to provide critical life-saving services. Founded in 1970, RAP is the district's longest-serving behavioral health provider and is the only provider to offer the full American Society of Addiction Medicine continuum of care. We are the only SUD provider to offer integrated medical and psychiatric care. We partner with DC Fire and Emergency Medical Services for emergency department diversion for withdrawal management and SUD crisis services. Earlier this month, we received full 3 accreditation from the Commission on Accreditation of Rehabilitation Facilities. In 2014, the RAP Board of Directors took the bold step to initiate management services with Gaudenzia for the purpose of implementing a program and administrative reorganization and eventual acquisition. This relationship has allowed us to reestablish financial footing while enhancing service delivery. In calendar year 2022, we provided SUD, mental health, and crisis service to 1,444 district residents. Our patients include racial and ethnic minorities, the LGBTQI community, persons living with HIV and mental illness, and individuals who are criminal justice involved, and those who are housing insecure. The Office of the Chief Medical Examiner reports 458 fatal overdoses for the calendar year 2022. The impacts of these deaths continue to disproportionately devastate communities of color in underserved communities. RAP's clients are predominantly Black or African American. The heroin epidemic is not new. RAP with our community partners have been responding to this epidemic for more than half a century while concurrently treating the rise and ongoing use of cocaine, crack, PCP, and ever-present alcohol use. Fentanyl is new. Every day we are losing mothers, fathers, sisters, brothers, neighbors, and friends. I wish I had the answers for you. DDH and the Department of Healthcare Finance provide critical technical assistance as we move to a managed care posture for behavioral health and implementation of electronic health records. We applaud DBH's continuing commitment and funding of harm reduction as integral to the behavioral health continuum. DC Health has funded harm reduction vending machines in some of our highest risk communities. We look forward to Community Bridges standing up the city's first stabilization and sobering center and welcome the agency as a new partner. As a broad-based community of stakeholders, providers, community groups, and the faith community, we have distributed tens of thousands of doses of naloxone, saving countless lives. DBH has stood up crisis teams and 988 services. We are making great strides. It's not enough. We need to do more. In calendar year 2022, we lost 458 of our neighbors to fatal overdose, the highest incidence in the country. These deaths disproportionately impact wards 5, 7, and 8. Preliminary data, as mentioned by an earlier panelist, suggests that 98% of those are linked to fentanyl. The good news is that we maintain decades-long collaborative agreements with community partners to provide services that ensure patient choice and make a connection to mitigate social determinants of health. These agreements facilitate care management across the safety nets. The bad news, we're doing paperwork, not treating patients. We find ourselves in a perfect storm. Transition to managed care, required national accreditation, and implementation of electronic health records. We'll do it all, we'll get it done, but at huge cost to our operating budgets, and most troubling, I fear there will be impact to quality of care and patient outcomes at smaller agencies. Rates for residential SUD treatment have not increased in nearly 7 years, while operating and personnel costs continue to climb. And then we were hit with COVID. DBH and DHCF must meaningfully adjust rates for these services, building in automatic annual inflationary adjustments. 2 legacy providers have already shuttered. The authorization and billing process for residential substance use treatment is overly burdensome and not reflected of proven policy in neighboring jurisdictions. Residential providers must first gain authorization from an MCO, then gain authorization from a DHCF third-party vendor if the treatment episode exceeds 15 days. All that can only be completed by licensed practitioners, our highest paid staff. Again, our clinical teams are at a desk doing paperwork, not treating patients. Residential SUD treatment must become a Medicaid benefit. In calendar year 2022, we lost 458 of our neighbors to fatal overdose. Should the people most qualified to intervene be typing or providing care?
Thank you, Mr. Pickering. We'll have some questions for you over our time. Dr. Pearsall.
Good morning. I'm very grateful to be here today and a little overwhelmed about the topic. My name is Dr. Celia Pearsall. I work for Prestige Healthcare Resources. I'm a PA. I have a doctorate in public health and I have a doctorate in divinity. I sit here today as a wife of 33 years and my husband has 36 years clean of opioids. He's a Vietnam veteran. That has impacted my family greatly. I come as a person that's very proud to say that. I don't have to ask for permission anymore. I've been married long enough not to have to. But I'm in this fight because of my husband and my family, because I know it's real. Not only the disease is real, but that treatment is possible. Treatment is definitely possible. He went to treatment 9 times before he was able to achieve his first time clean. The difference was that on that nighttime, and he's a veteran, there was something available in the district. He is a district resident or was a district resident. He came here at the age of 4 from Germany. And his family was career military. His father served in Korea as well, but there was something that the district offered at that time. He went to the Vanada program. It was what we would call now a respite program. It was a place that he could go and rest. I don't find after 27 years of working in this field that people are ready to make a cognizant decision because they've OD'd. They may be homeless, they may have another social determinant of health, and they need that eradicated or fixed immediately. So they'll say yes to whatever to get that night's sleep, to get that hot meal, to get that shower. But it does not mean we should not offer that. There's no facilities that have a bridging program of sort. We need a bridge in the District of Columbia for people to be at before we can get to that phase so they can get treatment. Of course, we know there's no detox of sorts for anything other than opioids, but even that is taxed to the limit. There's a program that's out there that we model at Prestige. We are positioned in 3 locations. One is in the District of Columbia, one is in PG County, and one is in Baltimore City. In Baltimore, I have more flexibility. I'm able to work in a model called treatment on demand. That means we offer 24-hour access when a person needs it. Please don't hear me say that's for Prestige. John Hopkins and other providers will tell you, they will call our number, somebody will answer the phone. I made that commitment myself for the first year for 24 hours. And guess what happens? We will bridge that gap. We hold them, even if the person is not supposed to be with us because detox won't open until the next morning. We will hold them when they're discharged and we will send them to where they're supposed to go. I heard Dr. Settles talk about that. That's what it takes. It takes commitment to eradicating the disease and not receiving the payment. I made a concerted effort with Prestige, and our providers will tell you, I have partnered with over 126 providers last year. We did everything. I do boots on the ground. Why? Because the disease of addiction doesn't start at 9 in the morning and end at 5. Somebody's going to call you at 2 a.m. in the morning, and we have to be dedicated to that. The opioid epidemic just masked like 25 years ago. We can blame the pharmaceutical companies with the uptick of the medication. We can blame heroin when those were done in 2010. But right now we have a pandemic of sorts that instead of pointing blame, we all need to kind of put our feet down, put our boots on and just dig in. I applaud the efforts of Narcan. I don't battle over how many milligrams it should be. I want to be able to use it and to get it to my consumers. I am very active about that respite care approach because we also have a non-medical respite in the district, and that is working too. When the people show up at the hospital and they have nowhere to go, when you push them back out in the street and you think that they're going to find that treatment center tomorrow morning at 9, they are not. They are not. We're battling something that's stronger than a person's will. And I want us to be able to approach it from that way. I'm not sure if that's in, I have 38 seconds. Thank you. But I'm in school, so we don't want to, your hands speak. But as I said, I want to really, if there's a way the district could bridge that gap, that would be awesome. I am a 4-time combat veteran myself. And I'm going to tell you with the suicide rate, everything is so strategically placed that we can't separate these issues. We cannot, co-occurring is real. It's not what came first, the chicken or the egg. Co-occurring is real. We need to be able to address co-occurring illnesses. So I would love to say, as my distinguished colleague said, have the solution, but I don't, but I'm willing to work.
Thank you so much, Dr. Pearsall. Dr. Chapman?
Thank you, Councilwoman Henderson, for having this hearing. My name is Dr. Edwin Chapman. I'm a 1973 graduate of Howard University College of Medicine. So this is my 50th year practicing medicine. For the first 28 years, practiced primarily internal medicine. But in 2000, I was asked to be the medical director of one of the three methadone clinics in the district. That experience was most enlightening. And I tell people that that's when I really learned to practice medicine, because I realized at that point, the integration of so many problems in our patients' mental health, economic problems, along with substance abuse, and then common medical problems. In the year 2005, I began using buprenorphine, which is one of the three FDA-approved medications for substance abuse, through a contract or a pilot demonstration project with the DC Superior Court as an alternative to methadone. In 2010, I had about 100 patients, and before the COVID epidemic, I had about 275 patients in treatment. That experience really actually took me back to Howard University in the Department of Behavioral Health and Psychiatry, not internal medicine. And the idea then was to integrate mental health, substance abuse, and primary care because of our siloed system. Concurrent with that, I was a founding member of the Urban Health Initiative that Dr. Settles described. Parallel to that, we realized that there were also social issues, and I was a founding member of the Leadership Council for Healthy Communities, which is a faith-based group. Again, trying to merge the medical needs and the social community needs into a cohesive package. Initially, the pastors were primarily focused on AIDS, but over time, we were able to demonstrate and show them the relationship to AIDS, hepatitis C, and other problems to substance use disorder. One of the most recently, we've been able to get a contract with the Department of Behavioral Health to help returning citizens who've been incarcerated, who now are in a medication-assisted program in the DC jail. That did not exist 2 years ago. So that's been a major step forward. Another major step forward is the fact that all 6 emergency rooms in the District of Columbia now have medication-assisted programs. The problem is that if one overdoses and goes to the emergency room, generally they're not admitted to the hospital. And if you could imagine that a significant number of those persons are homeless or have other economic problems. So if they enter the emergency room and then they're discharged, they go back to the same environment because there's no respite or center for them to go to really kind of get their lives together for 4 or 5 days and then perhaps get housing. Another major problem that we've experienced is really conveying the need for changes in the way we prescribe certain medications. And I mentioned buprenorphine. Again, I've been using for 17 years. In 2009 or so, we experienced some restrictions on buprenorphine in that the FDA changed the labeling such that they said that doses over 24 milligrams were not proven to be effective, although we had loads of data from other studies showing that it is effective. And mind you, that was 5 years before fentanyl hit in 2015. We published 2 studies from Howard University using the College of Pharmacy showing that higher doses work better. And now we're seeing other studies from across the country, but yet in the district, we still have prior authorizations for doses above 24 milligrams, and we've lost some patients because of that. I'm going to stop there.
Thank you, Dr. Chapman. We'll have some questions for you. I'm feeling like this is a very Howard-focused situation. Dr. McCams?
I mean, Howard University is the Mecca, so, but
Let's not start the wars on.
good morning, Chair Henderson and the members on the Committee on Health, Chair Gray, and the Committee on Hospital and Health Equity and staff. My name is Dr. Tamara McCants, and I am a Ward 7 resident and licensed pharmacist in the District of Columbia. I am extremely honored to be invited to provide this testimony on behalf of myself and the profession of pharmacy during this public roundtable. Today, my comments will be focused on the integral role that the pharmacist can play as part of an interdisciplinary team to improve treatment and recovery approaches, adopt harm reduction measures, and promote compassion and public education. My very first exposure to heroin addiction was pretty much exactly about 30 years ago. Back then, if we were utilizing the term opioid crisis, I wasn't familiar with it. I was a summer youth employee working for the Department of Human Rights in Harlem. I lived in Brooklyn and I had an hour-long train ride every morning. I read a lot of books that summer, but one of the most impactful books that I read was Dope Fiend, The Story of a Black Junkie by an author named Donald Goines, written in 1971. In reading this book, I learned 3 concepts that have remained with me for the past 30 years. No one utilizes drugs with the intention of getting addicted to it. Addiction is a disease process in which no one is exempt from it. And the book made me sincerely empathize with the desperation of a person that is addicted to drugs, especially opioids. These 3 concepts have guided me in my work and in this field today. Pharmacists undergo extensive education and training to become experts in medication. We spend an average of 8 years in school learning everything there is to know about medications. Throughout our education, we study pharmacology, learn about drug classes, mechanisms of actions, dosage forms, medication safety, and quality assurance. We also receive education on pharmacy law, ethics, and the legal aspects of dispensing medications. And if you're lucky like me, you may get to utilize that knowledge as a public service on the Board of Pharmacy. But we rise to the occasion to save lives every single day. We know the exact differences between Percocet, hydrocodone, oxycodone, fentanyl, methadone, and Suboxone. We know the circumstances in which they can be safely prescribed. We know how to calculate morphine equivalent doses to ascertain overdose risk, and we understand the science behind why and how people get high. Lastly, we can appreciate the public health benefits of harm reduction and implement effectively across the city simply due to our accessibility. After graduation from Florida A&M University in 2001, with my Doctor of Pharmacy degree, I came straight to Washington, D.C. In my mid-20s, my colleagues and I implemented a pharmacist-led HIV/AIDS treatment adherence program. We were pharmacists that were an integral part of the treatment continuum, ensuring that our patients had access to clean needles and syringes and substance abuse treatment programs like RAP Incorporated. I transitioned to Howard University in 2010 as an assistant professor. In partnership with DC Health, Howard University College of Pharmacy, the only college of pharmacy in the District of Columbia, established the Capital City Pharmacy Medical Reserve Corps. We recruit and train students through an elective emergency preparedness for healthcare professionals. And in fall of 2008, we identified the public health crisis, the opioid epidemic. And through that, we started a book club so that we can ensure that we understand the empathy that it takes to treat these patients. Pharmacists are well positioned to bridge existing gaps in the opioid use disorder care. We can identify and screen opioid use disorder risk. We can refer patients to treatment and support programs. We can ensure access to medicated assisted treatment and monitor that therapy. We can expand naloxone access. We can expand opioid use surveillance and treatment, including withdrawal management. And they are models all across the country that we can duplicate that can be sustainable here in the District of Columbia.
Thank you, Dr. McCants. I'm actually going to start with you. So it's so funny you're talking about your summer as summer youth living in Brooklyn, going to Harlem. So I had a summer where I was living in Brooklyn and going to Manhattan. An hour on the train, got a lot of reading done that summer. And then you also mentioned you guys started a book club. I'd love to know what books were on there, but more specifically to the point of this hearing, if you had to say like what were the top two things that you feel like we could be doing differently to engage pharmacists in this fight of this crisis, what would those be?
So the first thing is compensation for administration of buprenorphine and counseling, or also medication assisted treatment, not just dispensing the medication, but the counseling and the monitoring that goes with that, compensation for those services. And the second thing is the expansion of the naloxone distribution program, where every pharmacy gets the naloxone and is able to distribute.
Is that not the case now?
At this time, in order for us to be able to get that, I understand that we are in a transition process, but it's a long process, pretty similar to what everyone else is talking about in terms of the administrative process to kind of get
the bureaucracy
to get to the people. So if we can get an improvement in that process, then that would be the top two things for now.
Okay. Dr. Pearsall, I thank you so much for your testimony and for sharing your own personal story. I'm so interested in what you're doing in Baltimore. And well, how do we get that here? Turn your mic on so everybody can hear you.
So I'm trying that here.
Okay, because you said you have more flexibility in
I do,
Baltimore.
I do.
So what is it that allowed for
Not
that?
just Baltimore, PG County as well.
Okay.
So my consumers don't have to go through Access Hotline to be part of our program.
Okay.
They can walk in, they can, someone can call me in the middle of the night. They can do all those type of things without barriers. I had to do exactly what Dr. Sellers did. I went from person to person, program to program. This is who I am. I went to churches. We did diabetes and mental health. We did we taught them about how to use naloxone. We partnered with the prevention center. We partnered with everybody in each neighborhood. We're in the ward 7 to 8 faith leaders. So we are doing it on a small scale, but most people are very motivated by their bottom line. I'm not saying the prestige is not. I am a retired person, so I get what they call sure pay. That gives me a lot more flexibility. But part of my signing on after retirement to this agency is that they give back 5%, and I was able to yield my salary for 6 months and make $1, per pay period, because I believed in the process that it could work. We all our locations are 3-year CARF accredited, and if you look us up in PG County, we have a 70% success rate.
What's your capacity?
Well, where we are now in PG County, 120. Right now, my capacity is unlimited. It's based on what Comar tells me, that I have to do for every 15. I have a counselor, but what I do with my counselors as well, because you don't want them spent. I hire people to do one thing. If you facilitate group, that's all you're doing. You're facilitating.
Okay, so you're not.
The second part is doing sessions and reviews. We're not burning out. My people are touched at least by 3 people a day. The people and my their ability to keep coming back, they keep coming back because somebody's touching them every day. Somebody's calling them. You have to be a link in the chain. We can't be everything. We are that thing. Let her be that thing. Let him be that thing. It's no competition. We have to collaborate. One band, one sound. We have to collaborate. So I'm going to say I was raised on a farm. North Carolina, cotton, cucumbers, outhouses, tobacco. My grandfather had a 3rd grade education, but he left us 164 acres. with 15 sons, 1 daughter, never on welfare. And so it was pride in what you do is for the family. You know, this fight is my family. My life would have been totally different without my husband. I know what a treatment center can do. I know what MAT can do. I know what a program can do. I know what God does every day. And when families come to me and they want counseling, whether it's in the faith initiative, whatever, they just want to know, is hope possible? We have to give something to refuse to hope. The pharmacist has to be able to say to the person when they come in, not just explain the medications, but to explain, this is why this is happening to you now. Right? We have to tell people the truth. Last but not least, we have to stop saying children are too young to know the truth. They see it every day in their homes. I've revived a 6-year-old with Narcan. I've used Narcan up to 9 times on one person. It's not a pretty thing to see, but it's real. I know children that have revived their parents, teenagers. Don't say that there are things that kids shouldn't know. Kids should know. We need a youth rehabilitation long-term for youth here. It's not a question on if, it's already here. The DMV works together.
Yep. Let me ask you about the respite piece, because I heard you on that. And then also, I think Dr. Chapman, your part around if someone overdoses and they come to an emergency room, they're not going to get admitted. So are you going right back to wherever the house where you got the drugs from, and then is just sort of revisiting the cycle? One of the things that has come up in conversation is even when rehabilitation is covered under Medicaid, it's for a very short period of time. It's not, well, and I think short, I don't know. I mean, y'all tell me, I think short is short. Okay. But even from a respite standpoint, how long do you allow for folks to stay with you?
So right now, this is not a Medicaid program that we're doing. It's called non-medical respite, what Prestige has. We have 2 MCOs that work with us, MedStar Family Choice and AmeriHealth right now.
Okay.
We are looking for other people too. They come in 45-day increments. It can be extended based on the MCO. They don't have to be part of our network. If they're a part of MBI, we're going to make sure that their CSA is called and MBI still treats them. We house them. We take them to doctor's appointments. We make sure they get where they have to go, because you have to be a link in the chain. So right now the MCO is kind of dictating how long they stay, but it's safe housing, no rent. We re-engage them with whatever that thing was, medication management, all those things. And we ensure that they have an enlarged support system. We don't want to be their only support system. We want to be a support system. And so we are able to help them holistically by bringing other people in. And that model can work, and it does work.
So this is one of the things I have some worries about as we head to opening up our sobering centers. And Dr. Chapman and Michael, please feel free to chime in here, is that we're going to have individuals who are brought by FEMS or otherwise, or who walk in. They're going to be there. They're going to sober up, whatever that looks like. And then there's not going to be the connection piece on the back end. What should we be doing in those conversations? And perhaps you guys have had conversations with the contractor who's going to be running those centers in terms of like, what does it look like, to Dr. Pearsall's point around who is the link in the chain?
So what we've had several conversations.
Can you lower your mic so we can hear?
Sorry.
There you go.
We've met several times with the vendor who will be managing the sobering center. And I think they're going to be a great partner to the community. And the purpose of those conversations was actually bed and care management, to transition them to, I work for RAP. So it's, but we can step someone from the sobering center down to RAP, withdrawal management, and then into high intensity residential treatment, then into low intensity residential treatment, then to outpatients.
But you guys have capacity issues too, no?
Yes.
We all do.
Well, but it's our capacity issues are largely workforce related.
Okay. Dr. Chapman.
So housing is a tremendous piece in our treatment. 25% of my patients are either homeless on the street or homeless in the shelter. And another 25% are living in difficult housing circumstances. So I just lost a patient recently who was homeless. and he got shot in a drive-by. So these are circumstances that make it very difficult to stabilize patients. If you look at the front page of the Washington Post today, I think the way we handle the homeless situation, moving people around from one encampment to another, is barbaric. And that impacts the entire medical system, not just the opioid epidemic, but controlling diabetes, hypertension. These patients are going to rotate in and out of the hospital, in and out of the emergency room, in and out of jail, and they cost the system much more. So if you look at some of the slides that I presented, I was on a panel at the Brookings Institution back in 2018 with Alice Rivlin and some other economists, and we talk about wrong pocket savings. The savings from treatment actually go into other areas. So they keep people out of jail, they keep people out of the emergency room, and they make it possible for people to take care of their children. So all of those cost savings are expected to be provided by the insurance companies, and yet the insurance companies see these patients as a loss. So we have to come up with another model, and I put forth a bundled model where we take providers who are used to taking care of these patients, work in a collaborative, and we can save money across the board.
Okay, I think we're going to do a second round because I have some follow-ups, but I'm trying to be good. Councilmember Gray? Do you have any questions for these witnesses?
I do not. Thank you very much, Madam Chair.
All right, thank you, Councilmember Gray. Councilmember Parker?
Yes, thank you. I want to come to you first, Mr. Pickering, and I want to go back to the conversation we were talking about with the previous panel regarding structural challenges. And I know there may be some, and you could talk generally if you don't want to talk about RAP specifically, but one of the things that came to mind was the certification process, where it's my understanding providers are still expected to get external certification from one of 3 providers as well as DBH. And can you just talk about the impact that that has on you as a provider and others? If you want to weigh in on that, feel free.
Well, I call it everything everywhere all at once, because it's the national accreditation requirements. So it's not actually a certification requirement. We're still required under DC regs to certify locally. We're implementing electronic health records, and we're transitioning to managed care. Doing all of that while we are understaffed, and our most valuable personnel are the people who need to do this work. That's an enormous problem. And when you layer that over the fact that we haven't had a rate increase in more than 7 years for residential services, but the salary for those employees has gone up by a third on average. It's really difficult to get it done. We're very proud of the fact that, you know, a team of 4 people got our national accreditation. And continue to provide services to patients.
And would you agree that it's impacting your ability to provide services to patients?
Absolutely. You know, as I said in my testimony, our clinicians are sitting at desks doing paperwork versus meeting with patients.
Another issue that has come up, and anyone here on the panel can weigh in, around the prior authorization requirements. And I'm seeing head nods and smirks. And we're talking about structural changes. How is that impacting your ability to provide services to residents?
So let me just give you a little background on the 3 medications that we use for opioid use disorder. Methadone has been around for 60 years. Buprenorphine became readily available in about 2002 by federal regulation. I started using it in 2005. But the history of buprenorphine is very interesting in that it was the first office-based medication that could be used for opioid use disorder. Methadone, you had to be in a certified clinic with a lot of restrictions. And apparently in around 2000 and thereafter, the manufacturers and some folks in the federal government had some concerns about this medication, which was a Schedule III drug. Which means that the doctor could write it in the office as opposed to methadone, which was a Schedule II drug. And there were concerns that this medication would be diverted if it was used readily in urban settings. So to wind the clock forward, 2 years ago or 3 years ago, when I was at the National Academy of Science, a paper was published that showed that only 2.7% of African-American patients, urban patients, were on buprenorphine. And the rationale, again, was the concern about diversion. So if you look at studies today, buprenorphine adherence still is not good. For Caucasians, it's about 55 days. For African Americans, it's about 44 days. But when you really drill down, and I alluded to the study that we did at Howard University because I had been using buprenorphine for 17 years and had no problems using up to 32 milligrams. But when the FDA changed those regulations, it impacted adherence and comfort for a certain group of patients. And you have to remember that the opioid epidemic was very different in our community. The white epidemic, they talked about pills, and for a long time, they never mentioned the African-American community. When they really started taking off in our community, our patients, it was heroin to fentanyl in 2015. And fentanyl is 50 to 100 times more potent than morphine. So it was very, very different epidemic. And I'm saying all that to say that fentanyl and buprenorphine are metabolized through, all these drugs are metabolized through the liver, but buprenorphine and fentanyl are metabolized through the same pathway. So a patient, and I had to come up with a theory in my mind, who am I seeing in my office? These are patients who survive fentanyl on the street. So that tells you that either genetically or epigenetically, there's something different about these patients. They were able to metabolize that drug because they didn't overdose on the street. They made it to the office. And we were finding consistent with that, they probably needed higher doses. That might be the explanation for their higher doses of buprenorphine because they were competing in the same pathway. So that study, those studies that we did at Howard are now being confirmed in review. And we think that, again, this prior authorization, and you had a beautiful hearing on this several weeks ago that really showed the devastation. And one of my patients ended up on the front page of the Washington Post, a patient who was in one of the Medicare Advantage plans, and he was on 32 milligrams, and he switched plans back in March, and the new plan cut his dose to 24 milligrams, and we sent in all the paperwork, but a computer probably spit it back and denied his prescription. So that's what's happening with this artificial intelligence, that these insurance companies are looking at this. And one other aspect, the District of Columbia pays for methadone. So anybody, whether you have insurance or not, you can go to a methadone clinic, but who pays for buprenorphine? The Medicaid managed care companies. So I'm not saying that that's the rationale, but there is an incentive if you're a businessman to send patients to a methadone clinic. And that's the word on the street from, I've talked to emergency room doctors who say that, we found that African-American patients prefer to go to methadone clinics. It's not true.
I want to add one more thing, Councilmember Parker, in terms of the credentialing. In 12 states in the United States, pharmacists are allowed to have a DEA number, but in the District of Columbia, we cannot. And so what that means is that when we do get the opportunity to collaborate with a physician, nurse practitioner, that we can't make any dose adjustments. So it's like, we might be willing to meet the need in the community, but is that type of barrier that it can easily be fixed.
So what I wanted to chime in on is we're talking about the death rate, and most people don't talk about that, but in the pendulum, the white opioid rate had always been higher than the Black death rate. And so in 2019, the Black death rate overtook it. And so between 2019 and 2020, it was really, paramount that we needed something additional. And we didn't have anything additional to give these people that had overtaken it. Also, earlier when we were talking about incarcerated people, they're 6 times more likely to OD in the first 2 weeks because their system has decreased down. We can't step these people to where they need to go. Right now, Prestige is in the mayor's office of returning citizens once a week. And you'd be amazed at the number of people that come back, and before they even make it into the office, they've already used a substance. They've already used a substance. And we're there not for prestige. We're there to try to link them to where they need to be immediately, but within the first 5 days, they've already used a substance. And so now we're on a different type of pendulum. We're not on preventative, we're on life-saving issues. So education is going to be very, very important. Everybody knows about fentanyl, everybody knows about Narcan, but the education in we have to have something riveting. We have to have like the shock value. Everybody knows the golden arches. We should know this, something is universal. We have to get that out there. Messaging is very important.
One point I forgot to make was the Inspector General's Office for Medicare and Medicaid just published a report that showed during COVID, when we had the relaxations with telemedicine, that a diversion of buprenorphine and methadone did not go up in spite of the increases in overdoses. So if you look at the District of Columbia statistics, and I looked at them very closely, we had 458 deaths in 2022. Actually, we only had 10 patients that had buprenorphine in their system and only 24 patients that had methadone in their system, which the 10 patients for buprenorphine is within the 2% nationally of diversion on the street. And that does not mean that those patients got it from somebody else. They could have been prescribed and maybe underdosed and just happen to have it in their system.
Fascinating stuff. That is my time. And Dr. Chapman, I'm not sure I'm going to have another round, but I am on your mailing list. And I just wanted to acknowledge that I really appreciate all that you share with the world.
Everybody's on my mailing list.
I was going to say the same thing. I get the emails. I mean, I respond, but I read them. I have some follow-up questions. So we're going to do a second round of 6 minutes, if that's cool. There's so many different places I could go here. I mean, I think we've talked about respite. I think we've talked about the need for the link, but Mr. Pickering, let me start first with you. You talked about the workforce issues, and I think that's something that was brought up in the first panel around a lot of this work is done by volunteers or a very small team who is doing a mighty, mighty charge. Is your difficulty around recruiting staff financial, or is it something else where there's a shortage? So for instance, we have trouble finding nurses, but that's because we know there's a national shortage in terms of folks who are even entering nursing school. So what is the shortage in terms of the workforce question?
It's both a licensing issue. So
say more about that.
We don't have reciprocity with neighboring jurisdictions, so individuals need dual licenses. So our solution to that, our first cost that we threw at the wall was to pay for everybody's license.
What type of license? Medical?
RNs, APRNs.
The whole king caboodle.
The LPCs, LICSWs, graduate practitioners. I mean, that's our practice right now. Is we'll pay for your license. And for APRNs and MDs, we'll pay for your malpractice insurance. And everybody gets a signing bonus. And if an employee refers somebody we hire, then we give them a referral bonus.
The costs add up. And we're working on the licensing piece in terms of the compacts. We made some progress, with Dr. Lewis, and the next head of DC Health, this is definitely something we're going to push forward. There's several other compacts that are in the pipeline. Go ahead.
And then it goes back to rates. It goes back to compensation. We're not competitive with neighboring jurisdictions with what it costs to live in the District of Columbia. I mean, I can't imagine being fresh out of nursing school with an APRN with, it's got to be $200,000 in student loans right now. We have first source requirements that require 50% of our staff reside in DC.
I didn't know that you were under first source as well.
Yes, we are. So can you imagine having $200,000 of student loan, trying to start a family, trying to buy a house? We're not able to be competitive with what we can offer in compensation.
Yeah, lots to unpack on that front. Dr. McCants, I want to follow up with you as well. And I think we talked a little bit about this at our hearing on the Committee on Health with the Board of Pharmacy, is that pharmacists want to do more, but there are the restrictions in terms of how you all can do more than just dispense.
Mm-hmm.
So how can we help?
Pharmacists are already doing more. We're just not being compensated for it. So we need a system where pharmacists can be compensated to provide these clinical services in the community pharmacy setting. And
so let me ask, have you all had any conversations with the Department of Healthcare Finance around pharmacists getting reimbursed for some of the counseling services that you talked about?
Yep. So basically, we know that in order for us to have a productive conversation with Department of Healthcare Finance, we have to first prove in DC that it can happen. So what we usually do is we look at the other jurisdictions, see what their models are. So we have models in Rhode Island, Maryland, Ohio, to name a few. My colleague, Dr. Franklin, and we just got a small grant from the Ford Foundation to implement the community pharmacy-based opioid use disorder management with the pharmacist, physician, peer recovery specialists. So that's our point. This is always a slow creep for us. So we're going to take these 3 models with these 3 pharmacies and then show DC that this is an effective model, even though it has been shown in other places already, and then hope that the healthcare finance would respect it and think that that's something that should be compensated. But to be honest with you, it just has not been in the past. It's all new people in town. But in the past, it has just not been a productive conversation for DC Healthcare Finance to compensate pharmacists for non-dispensing services. We were one of the last to get compensated for Medicaid patients just to give immunizations. This happened like 2 or 3 years ago. So that's just to show you like where we are with it. So we know that there's other routes and we know that there's other entities to try to demonstrate our worth. And so that's basically what we work on.
Dr. Chapman?
Yes, Dr. Hunt and I have been on a panel for the past year and a half with the Region 3 SAMHSA director, showing that this is a ubiquitous problem with pharmacists. Some states, the pharmacists don't want those kind of people in our pharmacy. Some pharmacists say that they're losing money on buprenorphine. But if you look at some of the slides that I showed you, patient and treatment for opioid use disorder could cost $20,000 a year. But a person who's not treated can cost the system $68,000 a year because of these ancillary diseases, going to the emergency room with overdoses, getting bacterial endocarditis, getting AIDS, hepatitis, or giving it to somebody else. So the savings just in that model is $48,000. So we're talking being penny wise and pound foolish. Why not pay the pharmacist a bonus for seeing these patients? There's plenty of money to work in that system, and we can show you the model.
Especially as the injectable form of buprenorphine becomes more and more available. They're coming to the pharmacy anyway. So we need to just be able to because people, they don't want to be sick. We we have to have much more empathy to understand that this is not the vagrants or the vagabonds or the rejects of society. These are real people that they are just sick, and we just need to treat them, and so they could feel better, and then they can start on the road to recovery. And that's the first thing, is the access to the medication assisted treatment. We know that it works, so we just need to increase the access.
Thank you. Councilmember Parker, do you have any questions? Any additional questions? All right. Well, I want to thank so much this panel for being here. And like I said, beginning of the conversation, we'll follow up on all of these different things, because I think this was just a very fruitful conversation. And Dr. Pearsall, I'll come to Baltimore. So let's connect. And field trip. Thank you so much. We're going to move on to our next panel. So this is our final panel before we get to government witnesses. So just to set expectation. Oh, you're. Thank you. Just to set expectations for folks. So we're going to do our next panel of expert witnesses, and we're going to take a 5-minute break and then do our government folks after that. Okay. So just expectations. So Jacqueline Bowens, the CEO of the DC Hospital Association, is going to join us. Mark Lavoda, who's the executive director of the DC Behavioral Health Association, and Dr. Richard Schottenfeld, who's the chair of the Department of Psychiatry and Behavioral Sciences from Howard University Hospital, is going to join us as well. What's that? Okay, Dr. Schottenfeld's outside. Someone's going to grab, but Ms. Bowens, you're first. So go ahead when you're ready.
Good afternoon, Chairperson Henderson and Gray, and members of the Committee on Health and Hospital and Health Equity. I'm Jacqueline Bowens, and I'm the President and CEO of the DC Hospital Association. And I'm also joined here by Gail Hurt, who's our Director of Quality and our expert in this area, and I thought she'd also be helpful along with me in terms of any specific questions. So I hope you'll indulge me bringing her along. I certainly appreciate this opportunity to present testimony at this public roundtable on combating the opioid and fentanyl crisis in the district. As you know, the opioid and fentanyl crisis in the district has had a devastating impact on district residents. Particularly impacted are among African-American males ages 40 to 69. 72% of all fatal opioid overdoses occur in this age range. DCHA and our members have worked collaboratively with the Department of Behavioral Health to combat this epidemic. Through funding provided by the department, DCHA and its members launched the hospital-based peer support services model in June 2019. The program uses an evidence-based approach called SBIRT, which stands for Screening, Brief Intervention, and Referral to Treatment, to quickly assess patients and connect those interested in treatment to a provider in the community. Screenings are completed for patients arriving in one of the 7 hospitals to assess risky substance use. Of those patients that screen positive, they receive a brief intervention from a peer recovery coach. These individuals who have lived experience receive an intervention, a brief intervention from a peer recovery coach. And this is really key to the program's success because they're able to discuss their own journey and are specifically trained on motivating patients to enter treatment. Patients that use opioids are provided an opportunity to receive medication for opioid use disorder in the hospital if they are clinically appropriate. Those patients who receive MOUD are then connected by a peer to a provider in the community who offers same day or next day services so that they can receive their next day dose of medication. Over 785,000 patients have received the SBIRT screening, and of those, 20% have screened positive for risky substance use. 24% of the patients who screened positive received a brief intervention. Since inception, nearly 5,000 patients who visited a participating hospital have been linked to treatment services. Approximately 1,500 individuals started MOUD treatment within our hospitals, and 82% of them arrived at a treatment provider in the community for their next dose. This is the strength of the program and why it's considered a best practice. As we've looked at ways to improve access to treatment and sustainability for intervention programs, we have several recommendations that we'd like to talk about. First, one of the largest barriers to increasing the number of brief interventions is the limited peer workforce in the district. And we've talked quite a bit about workforce issues. I consider that we'll talk more about that, and the high demand for this critical competency that the peers represent. We commend the department for restarting their peer certification program, which is so very much needed as we seek to increase the number of peers in SUD programs and services throughout the city. The district also needs to plan for retention of this essential component of the workforce as they advance into professions such as social work and addiction counselors in order to ensure our peers continue providing services in the district. Second, DBH certified peers are able to provide Medicaid reimbursable services when employed at DBH certified provider organizations, which exclude hospitals. We know the Department of Healthcare Finance is aware of this issue and has been a partner in identifying options for reimbursement and sustainability. Third, naloxone distribution in hospitals faces barriers not present for workers in the community. Hospital pharmacy licensing does not currently allow the peer coaches to provide naloxone or associated education directly. This prevents peers from being able to dispense naloxone and train patients as they would be able to if they worked in community. In hospitals, a physician's order is required for each prescription, and a pharmacist or qualified licensed healthcare provider must conduct the training. And we recommend that regulatory restrictions on hospitals be lifted to mirror the community providers. And finally, we need to meet patients where they are when they are ready for treatment. The limited availability of community providers during evening hours and on weekends presents a challenge for peers to link patients to treatments. And we would encourage exploring funding opportunities. And then we recommend a centralized system for appointments directly. And then I just lastly would want to say that this is an important issue for the association. And tomorrow we're going to be hosting our 4th annual opioid response symposium. And this will be an opportunity for hospitals and community partners to further talk about this issue.
Thank you, Ms. Bowens. Mr. Lavoda.
Thank you. Chairperson Henderson, Chairperson Gray, members of the council. Thank you for the opportunity to appear before you today. My name is Mark Lavoda. I'm the Executive Director of the District of Columbia Behavioral Health Association and a Ward 2 homeowner. The District of Columbia Behavioral Health Association works to advance high-quality whole person care for all district residents with mental illness or substance use disorders. This hearing brings needed renewed attention to the opioid crisis that continues to kill our family, friends, and neighbors and bring suffering to drug users in the broader community. To its credit, in the past several years, the district has deployed tens of millions of dollars of federal funds annually, distributed tens of thousands of doses of naloxone, likely saved hundreds of lives, and likely helped hundreds of people enter treatment. Upcoming plans show the intent to close further gaps. Even so, the results tell us that more is needed. First, we need to make more effort to reach people not in treatment. Harm reduction is not just fentanyl test strips and naloxone overdose reversals. Many drug users are dying because they are using alone. The district needs to revisit designation of places where safer use replaces unsafe use and consider expanding Good Samaritan protections for people who work to make sure that drug users don't die. Second, we need to continue to redesign who responds to emergency calls made to 911, 988, or the DBH mobile crisis team. We cannot afford fear of a law enforcement response to prevent people from calling for help. Third, we need 24/7 street outreach to disrupt overdose spikes that immediately follow drug busts. MPD should coordinate with street outreach teams to implement 24/7 intensive street outreach within 3 blocks of seizure for 3 weeks. This could be paired with stronger public messages reporting overdose spikes. Using direct message, major overdose surge near Minnesota Avenue and Benning Road. 3 fatalities already reported. Fourth, We also need to learn from the PEP-V sites and reinstate the housing and services that PEP-V has offered for people who need someplace to go after completing withdrawal or detoxification, but before they're ready for treatment. We also need to keep PEP-V-like services available to provide flexible housing capacity needed to separate people when residential treatment programs inevitably continue to experience COVID outbreaks or other highly infectious airborne diseases. Fifth, the treatment provider network requires significant reinforcement. DBH provider organizations need a consistent process for payment updates for contracted services and billable claims. DBH and DHCF need to move residential treatment fully into managed care. The provider network should be challenged to focus more on outcomes and results. Gaps need to be closed to serve specific populations, such as creating a pathway for organizations to offer residential treatment programs for youth. DBH and DHCF need to update rules to align with upcoming revisions to ASAM criteria, defining multiple distinct levels of outpatient care. Six, the provider network cannot succeed without a new approach to the behavioral health workforce. The district needs to continue to address overall healthcare workforce challenges. Additionally, results of background checks related to substance use should not be allowed to disqualify people from taking roles that rely on lived experience. While it is clearly unsafe for providers to work while impaired, evidence that someone has sought or is receiving treatment for a behavioral health condition also should not be considered in fitness for duty tests, as happens too often right now across multiple health licensing boards. Seventh, the district also needs to continue to expand the behavioral health workforce. The district needs to invest in training from paraprofessional levels to graduate degrees. The district also needs to expand availability of experience-based alternative pathways rather than degrees to qualify for some levels of licensure. Levels of licensure should be developed or expanded to allow performance under supervision of some activities currently restricted to those with a graduate degree, such as forms of counseling that do not require the graduate training necessary to conduct psychotherapy. Eighth, the district needs to offer better housing resources after treatment to help people sustain recovery. For some, the best place to go after treatment would be somewhere that offers a community with expectation for sober living. For others, recovery means something different than total abstinence, and a place to go where someone can use in a more limited way, or where a slip or a period of recurrence while attempting sobriety will not result in eviction. Ninth, the district needs to find other ways to offer additional recovery supports, such as peer-operated centers, participation in supported employment programs after active treatment, and expanded other peer support services. And 10th, the district needs a strategy to address behavioral health needs better at different life stages, including for youth and for people who are aging. Thank you again for the opportunity to testify today. I look forward to answering any questions that you might have.
Thank you, Mr. Lavoda. Dr. Schottenfeld?
Thank you, Chairperson Henderson, Chairperson Gray, and the other council members. I'll focus my opening remarks on the work we've been doing at Howard University Hospital and the College of Medicine to address the problems. And by way of my own background, I've been developing substance use disorder treatment services, training programs, clinical research for nearly 40 years. Primary focus of my work is on opiates and stimulant use disorders. And prior to moving to the district, in my current position 6 years ago, I led the substance use disorders programs at Yale University. I moved to the district just as the overdose crisis was accelerating, and a major factor in my decision to move here was the very strong support and commitment of the dean, the hospital, the College of Medicine to develop and expand addiction clinical services training programs and address the problem here. I'm going to briefly highlight three main areas of work that we've been doing for the past over this period. And I want to preface my comments, though, by referencing the four pillars of essential comprehensive overdose prevention strategy: primary prevention, harm reduction or secondary prevention, evidence-based treatment, and recovery supports. The cornerstone of pillar 3, evidence-based treatments for opioids and fentanyl, is medication treatments for opiate use disorder, commonly referred to as MOUD, with one of the 3 medications approved for MOUD. The odds are 9-to-1 against somebody entering sustained recovery from opioids following treatment if they're not on a medication. The odds shift to 2-to-1 in their favor if they are on medications for opiate use disorder treatment on MOUD. And the overdose risk for somebody who's not on MOUD is 4 to 5-fold the overdose risk for somebody who's treated with medications. Those are the facts. The district has done a lot to improve the availability of MOUD and to make sure that people can get MOUD without cost. Nevertheless, 80 to 90% of those people in the district who need medication treatment, who have opiate use disorder, are not receiving it. This is similar across the country, but we're not doing particularly well here. And similarly to across the country, a Black person with opiate use disorder is 40% less likely than a white person to receive medication treatment. We have effective treatments, but we're not using it. So here's what we've been doing to try to address those issues. So first of all, we've been addressing healthcare workforce issues. We want to make sure that every healthcare workforce person has good understanding of addictions, addiction treatment, and the role of medication treatment. We developed an addiction medicine fellowship program. We received funding from HRSA to support that program. We're beginning next week, we'll have 3 addiction medicine fellows. Those are people who have completed training, the 3 who are coming in pediatrics, internal medicine, and family medicine. They get trained in addiction medicine. They get to embed in all of the medical services, addictions training and treatment, and they get to provide that treatment to patients throughout the hospital. So they improve care now, and they're the future of expanding healthcare workforce. Second, we've been expanding treatment interventions in a number of ways, including in partnership with the DCHA, with the emergency department initiated program of treatment, something that we helped bring in. Colleagues at Yale had developed at first. And the third, key area we wanted to highlight is we've been developing and working in community partnerships to try to better understand what's keeping people out of treatment, where are the opportunities to bring people into treatment. So we've located that work in Wards 7 and 8. We've worked in partnership with the Community Advisory Board there, the DC Dream Center, Pennsylvania Avenue Baptist Church. We started off and surveyed, did interviews and focus groups with about 120 people, people with opiate use disorder, family members, community leaders, healthcare workers. Across all those groups, stigma about addiction, misunderstanding and bias against addiction were key issues keeping people out of treatment. And the bias against medication treatment occurred among all of the participant categories, including healthcare workers, including, unfortunately, peers who are doing the peer outreach work. They haven't been fully educated in what they need to know in order to be effective in their roles. The second thing that we did, and then I'll finish, sorry that I'm out of time. The second thing is we launched a pilot intervention program using a hub and spoke model. We've been providing treatment locally at the DC Dream Center in collaboration with the DC Dream Center, non-medical, community-based organization, highly trusted in the community. We have a peer who's based at the Dream Center. She goes out and does terrific community education outreach. When she finds somebody who's ready or interested in treatment, or family member brings them in, we can start them in treatment at the DC Dream Center by linking them with telemedicine to our clinic, generally by addiction medicine fellow, who's the person who sees them. And then we provide on-site recovery guiding form of counseling that we've developed and that we've trained community health workers and peers to be able to deliver as part of expanding the workforce. It's an extremely exciting initiative. I'm really pleased that the results have been so promising. We got funding initially from the National Institute on Drug Abuse and the NIH HEAL initiative, and as part of our Center of Excellence. And just about 2 weeks ago, we were notified and awarded funding for a We're going to be the lead on a $14.5 million 5-year multi-site study to evaluate and implement this model, expand it in the district, and do it in Miami and Chicago. So we've been doing a lot. There's a lot more that needs to be done. I'm going to highlight just finishing 2 things if I could. One, we got to train up the peers. We need to provide much better. We need to certify them. And as part of the certification, we need to make sure they really understand treatments well enough so they can be good educators and advocates for it. There's a program that people at Kentucky have developed that's a training program. We should implement it, bring it here. They're happy to help us with it. And the second is we should at least begin to talk about the youth opioid crisis, the overdoses that are now expanding among young people in the district and in surrounding areas. We need to develop a comprehensive approach to address that problem. Thank you very much.
Thank you so much. And thank you to all of the witnesses on this panel. Dr. Schoenfeld, I want to actually follow up on a couple of things that you mentioned in your testimony. When you say train up peers, what do you mean by peers? Are we talking about folks in the community? Are we talking about peers as in other professionals in the healthcare workforce? What's your definition of peers?
Well, so for the peers, I was thinking about people in recovery, peers in recovery. But,
I see.
But I do think that training has to be everybody. There should not be a single healthcare provider or healthcare worker in the district who doesn't understand enough about addictions treatment to be able to be responsive to the person, to treat the person with dignity and respect, and to provide good advice and guidance and not misleading advice and guidance.
So how do we do that? And Ms. Bowens, maybe you can bring this in, because while I do find health professionals to be very collaborative in nature, and I read an article, or, I went to such and such conference, they're usually not receptive to us saying you need more training specifically in how to talk to people. Right. And when we talk about continuing education on something, they're like, oh, well, I know how to be compassionate and all of those different things. But what we're talking about here is something different. It's around, if you're noticing the signs, do you know how to refer someone? Do you know what are the steps? Ms. Bowens, how can we help on that?
Well, I mean, and this is what's so special about the peers, because the peers that Dr. Schoenfeld and I are talking about are really those individuals who have lived experience. They're largely people who are recovering, people from substance use disorders who you've brought into your organization, who really have that lived experience, who understand, who've gone through certain levels of certification as it relates to working within that healthcare environment. And so not only, we help certify them in terms of working in the environment, but they also teach us in terms of how we can speak to the individuals and bring them into the system. So it is that kind of dual learning. So it works both ways. So yes, I agree with you in terms of when you always say to people that no matter where you are within the health system, we all need advocates, right?
Yep.
So that part I do agree. But with respect to the peers, they are unique individuals who come and bring their expertise into the organization, and that level of trust to help navigate the individuals through the system. But they're clearly, there's a level of certification that they require that Dr. Schoenfeld is talking about. And I certainly want to hear a little bit more about that particular initiative. And so we want to get them certified. We want to keep them within the system because we really need them, because they're those individuals that the folks trust.
Well, that's great for adults. What do I do?
They trust. The healthcare providers learn to trust them too.
Right.
So that's the other part.
It works both ways.
When you watch what's happened in the emergency departments in the district, I know the ones at Howard University Hospital best, with peers there, they're educating the nursing staff. They are educating the ED docs. They're educating my residents.
Right.
They are the ones who are saying, this person has this disorder. This is how we talk to them. They play
they're now embedded educators and role models. And they've transformed already the way care is delivered, and they are transforming how people are educated. So I think they play a critical role in the healthcare team in helping with the education.
Okay.
But I agree with you, you can't force people to learn it, but.
Right. And I could definitely see that value, particularly, but let's change gears because we're talking about adults, but you mentioned this growing crisis amongst youth. What do we do there? Because it's not the same model at all. And these peers aren't going to be in schools. So what do we do there? Or do I have to hold a whole nother hearing on the youth epidemic?
I think we're going to need a whole other hearing, but I mean, really quite seriously, we've been having these conversations happening at a national level. Ford Foundation is organizing a conference. We're organizing a conference, pulling together people. We've been working with the Department of Behavioral Health. This is not easy. There may be some opportunities to use school-based behavioral health professionals to be able to help address, because we have a workforce that's there. There may be some opportunities in schools to take respected seniors who are people that people look up to, maybe some of the athletes and others, and to engage them in providing the models and at least prevention activities. But this is going to be critical and innovative. Unfortunately, we're going to have to invent some of this.
It's a whole different conversation.
Whole different conversation. Okay. I mean, I think that, and I could definitely see that, because in what you were saying, and I think in other testimonies that we've heard earlier today around the stigma about addiction that is still prevalent in communities of color, the bias in treatment, in terms of what does recovery look like or not. I can only imagine a physician trying to tell a parent, your child has, your 13-year-old, your 16-year-old, whatever, has an addiction. And what does that, how do you communicate that to a family member so that they are not blaming themselves, not going through all of those various cycles, but also aren't saying, well, they'll just be fine. Like they'll figure it out. They're just going through a phase, as opposed to, wanting to pursue treatment, and what does treatment options look like?
Just for your future, we do have, hearing on this. Dr. Siva Kalyamurthy is somebody that we've jointly hired at Howard and at Children's, and he is a unicorn. He is board certified in general psychiatry, child adolescent psychiatry, and addiction psychiatry. And he's a wonderful person, and he's really comfortable and good at trying to engage young people and their parents. And he's overworked already.
And also,
not only
that issue, but also let's not forget the concerns about the child protection issues that those parents would have too with that. So you've got to bring all those issues, the denial issue, the protection issues, and the concerns about, so that parent hearing this, and then their concerns about where does the law enforcement concerns come in when these things are discovered. So we got to bring all those issues too. So it's these issues plus that. So this discovery of that your kid may have an issue, but when that comes to bear, the reporting, so many issues that come to bear when these things get discovered.
Right. But, and I see your light on, Mark. I would also acknowledge too that for wealthier families, when this arises in their children, they are able to quietly and quickly figure it out.
Right. So that's my point. So all of those, the biases, I'm just putting out just the myriad issues that when we bring this to bear, we've got to talk about.
Right. Mark?
Yeah, so I did want to jump in. I think Jackie is absolutely right to be talking about the concerns about outplacement. Those are real concerns, and figuring out how to manage mandatory reporting in a way that we can get people into care when we need to get them into care without the child fearing, oh, my mom's going to get reported. I'm going to get pulled out of my home as well as my school, and figuring out how to keep the parents safe. I think this is also about multi-generational treatment. Addictions run in families. And so making sure that we are thinking about how do we provide the resources to anyone who's involved in that family's life is going to be another critical component there. I also just wanted to come back to the school-based services. I think both the school behavioral health teams can play an important role, and also peers themselves. It's not going to be the trained peers who are in recovery, but just students talking to students candidly about what their risks are and what it means to participate in treatment successfully. The other group that I want to name is pediatricians. The statistics actually show that about 70% of students or youth who report a behavioral health condition report it first to their pediatrician. And so if we have pediatricians who are well-trained and well-resourced, who know I've got somebody down the hall who I can make a referral to talk about this more in depth, or I've got a consult service who I can call and right away get the one-on-one advice that I need, those are really critical resources for pediatricians and making sure that they're at the table for that discussion.
Yeah, I think that that's an excellent point in terms of there's all of these pieces, but the quickness and the seamlessness that is necessary from identifying a problem to it when someone is ready for treatment, being able to make that available to them. I've said this before. I have a friend who is a public defender, and she would often say, you know, I always have wait lists to get my clients into diversion programs, treatment programs, et cetera. There is never a wait list for jail. And on that side, I'm sort of thinking to myself of like, we got all these wait lists and we have people who are dying, right? When I tell my friends in terms of the numbers of people who we lost just last year alone, the attention that we have paid to one type of death versus another type of death in this city and across the country is one that I feel like we really need to unpack on that. But I'm over my time. Councilmember Gray, do you have any questions for this panel?
No, thank you very much, Madam Chair. I appreciate the conversation that we've had, and I will look forward to us continuing to be able to have this conversation.
Thank you, Councilmember Gray. Yes, we have a lot of work to do. Councilmember Parker?
Yes, I want to pick back up on this thread of structural issues that we need to address. And Ms. Bowens, you laid out several, but first I want to come to Mr. Lavada. There was one area that you honed in on, the background checks for individuals that in their past may have had a substance abuse disorder, which would then preclude them from working with a provider to provide care, service, and treatment to those struggling with substance abuse. That seems pretty clear cut that that's not what we should be doing. And I wanted to just ask a clarifying question. Are you referring to the peers program that the others were talking about, or are you just talking more generally that it's a barrier for providers in general?
We specifically see this happening for peers. We also see it happen for people across the professional spectrum working in behavioral health and in healthcare generally. Unfortunately, there's this list of which kinds of crimes need to be reviewed in background checks. And if people have any one of those within, I think it's the past 7 years, then there's like a caution flag. If people have 2, then they're pretty much told you can't work. And the reality is, particularly for these positions where we're looking for people with lived experience, they often have that in their record.
And those are the individuals that we do want, because they may be able to reach someone that has a similar experience.
Exactly. And so I think that there both needs to be some additional flexibility for organizations to make independent judgments about, we are aware of the circumstances and we believe that it is safe for this person to work in this environment. And also just more discretion on the part of the board to say, yeah, we understand that this happened. We see the evidence of your recovery. And maybe the 7-year look back is too long. Maybe it should be 3 years or 5 years instead of 7. Maybe the list of crimes is too long. Maybe we don't need to include some of the things that get bundled together when people get arrested for using drugs on the street. And I think we could come to a more rational system to bring more of those people into the workforce
I
successfully.
can hear Queen Adesuyi from earlier saying we could just decriminalize drugs, and it moves us further to solving the issue that you're talking about, but also ensuring that we lean more into care versus punishment.
Yeah, so
I'm not saying that's what you're saying. I can just channel what I imagine she would be saying.
and what I want to say is that's still probably not enough. Because
Mm.
even if we don't convict someone for the drug use, we're going to convict them for the petty crime. We're going to convict them
That's
for
right.
whatever they did to get the money they needed to buy their next hit. And those things are still going to be part of that record.
Okay, I want to switch gears. Ms. Bowens, you laid out several recommendations. Are you suggesting that peers should be able to prescribe and distribute the naloxone?
So what we want to do is just make sure that the same availability to prescribe in the community is the same that we can do in the hospitals. So we really just want to have the same ability to deliver it. So you kind of get that label of prescription, but it is to be able to deliver it in the same manner. So we use the term prescribe, but it really is to be able to deliver it in the same manner that you're able to
But
deliver in the community.
specifically the peer coaches
The peer coaches, yeah.
in
So-
a
so
hospital
Gail-
setting.
So Gail, give the specific, I want to make sure for the record, I say it correctly because you're better than I am.
Yeah, so
I-
the issue is not necessarily hold on, there's a chair right there. And if you could just introduce yourself for the record.
That's why I had her here, because she can say
Yes,
it better
yeah.
than me.
Always prepared.
Yeah, always prepared.
Hi, Gail Olano Hurt from the District of Columbia Hospital Association. And happy to provide a little more insight into that question. The issue is not so much the prescribing. Certainly, if you think about in the district, there's a standing order for naloxone, but that doesn't apply to the hospitals. The doctors do need to prescribe the medication. That's not really the crux of the issue. The crux of the issue is a nuance in how the hospital pharmacies are licensed versus how external pharmacies or regular pharmacies outside of a hospital are licensed in terms of who is allowed to dispense that medication and provide training to the person who is receiving it on how to use it. And so in a hospital, there are many more restrictions on that because of the way the pharmacy is licensed. So if a peer was out in the community, we have many peers who work in the community, their ability to use that standing order in the city and or have naloxone available to give to someone to teach them how to use it is very different than what happens in the hospital. And we've been trying to work on a program where when folks discharge from the hospital, if it's identified as a potential need, that they're able to receive that naloxone when they walk out the door or that their family is. And we have found this as a barrier because it's so complex in terms of once that order is entered, how the process needs to happen to get the medication to the floor for the individual and who has to train that person. It may be the pharmacist has to come up from the pharmacy, do the education rather than the peer who could be trained just as if they were in the community. I've been trained and I could do some of this in the community, but I couldn't do it if I worked for the hospital.
And let's go one step further while we have you. What is the impact of this? I would imagine if you need a doctor to actually distribute it in a hospital setting, given everything else that's happening within our hospitals, you're now talking about a lag in treatment or significant wait times. Can you just speak to what is the consequence of this disparity in the distribution, access, and providers versus hospitals?
Right. Specifically for the naloxone, which is what we're talking about here, the barrier is getting the naloxone in the hands of the people who may need to use it after they leave. Ideally, we would like to think that they get an MOUD in the hospital and they go somewhere else, get those follow-up treatment and they stay in. But the reality is they may go out and use again an overdose, or maybe in environments where their friends are using an overdose. And we want to use every avenue we can in the city to get that life-saving treatment out and available. And the hospitals being a point at which many of these individuals receive care when they may not receive care or interact with healthcare workers in other settings is an avenue to try to get more of that naloxone out in the community. And that's the barrier, is the potential that somebody may have been in the hospital yesterday. And today they may be sitting with a friend who overdoses and they didn't have the naloxone because it just was not possible the way that the system is structured for the hospital to be able to dispense that medication. That's the underlying barrier.
Super helpful. And similarly, Ms. Bowens, you're highlighting some of the pay disparities between providers and hospitals, but it seems like that we're already working on that.
We're working on it, but any assistance you may provide in expediting it will be greatly appreciated. Same with the compact.
Always on the job. I love it. And then I'll end here, Mr. Scott or Dr. Scottenfield, apologies, and Ms. Bowens, you both talked about the peer program. How do we, in the short term, expand it? So expand the pipeline.
Well, I think Department of Behavioral Health is now running a certification program again. I'm not sure exactly the resources they need to make sure that they can take in more people, but that'd be one, because that's a good place to provide the training. And we should also push the department to incorporate more extensive training around addictions treatment as part of that peer certification process, because that's not currently there. I don't think they're opposed to it, but I think it would be helpful to encourage them or insist that they do it. Implementing a 15-hour curriculum would change what they're doing, but that's probably what's needed. That's what Kentucky found was needed and effective to make a difference. So those would be two ways. You're going to increase the pipeline, but you
Just clarification, needed. Why?
What? Because the misunderstanding about what is an evidence-based treatment and what works, or the role of medication, is pervasive, including among people in recovery.
So quality
often,
of service.
So the quality of what they provide is often off. This is what worked for me. It's going to work for you. But the reality is, this is what worked for me. I don't know what's going to work for you, but let me tell you what works for most people. And let me tell you how this works is what we need to be able to help them shift to. This is what I've been doing. This is what works. This is what's been shown to be effective. This is going to help protect you. This is how it works. And in order to do that, they need a lot of training. They need experience having that conversation.
Could Howard potentially run that training program?
We could certainly, help with it, play a major role in it. I've got the addiction medicine fellows. We'll put them in there. These would be good things. And we're in the game. We're trying to.
And I would add that it's that part, but it's also just with all the other jobs in our field is retention. So they are not only, they get certified, but we lose them too, because they are a highly attractive role. And so just the idea of maintaining them in the role, whether it's about wages, whether it's about jobs, so that same work that we have to do around job satisfaction for them and keeping them in the roles. They're attractive in terms of going off into social work and other things. And so it is that same competition that we have to do. So it's the whole gamut. So both things.
Thank you all. I am
very much
at
for
time.
questions.
Thank you.
Okay. I think you raised an excellent point, Ms. Bowens, at the end there, because I'm thinking for individuals who are peers or doing this work, many times we're asking them to do 3 other jobs as well. We want them to be peers in addiction recovery. We want you to be a violence interrupter. We want you to go out to and I think Dr. Pearsall made an excellent point of sometimes here is your job. It is your one job, not 5 jobs of you trying to save everyone. And I think we probably need to think a little bit more about that as well. One last question that I wanted to ask was, it seems throughout our whole conversation of our expert panel witnesses, everybody's saying we need to do more PSAs. Is that what I'm hearing? Like that I remember when there was a lot of conversation about opioids when it was taking out entire communities in West Virginia and Vermont and Rhode Island. And that has kind of died down now that we've had the lawsuits and the cases and the settlements. But here in the district, we are still facing our very real thing, but the messaging, we're not seeing it in the same manner as, say, we heard about tobacco or the dangers of those kinds of things, or even when we talk about the PSAs that we do around like safe sex practices and decreasing HIV and AIDS. Go ahead.
I think we need both more PSAs. We also need more targeted education publicity, or PSAs. So we've been very good about Narcan distribution, overdose and Narcan. We haven't been as good around medication treatments. We haven't used them. They're beginning, and I know I've been working with the department to try to get those up and running, but they really need to be expanded. That's one avenue to address that needs to be addressed. What's treatment? How to get somebody into treatment so that wherever somebody goes, they say, no, my sister, my kid, my parent, my friend has this problem. I know treatment works. I know what they're, where they can get it. And we're not that good at that. We need to do more of that.
Do the hospitals do medical assisted treatment?
Oh, yes.
Okay.
Oh, yeah.
Well, yeah, that was a dumb question on my part.
I didn't mean it that way, but yes.
No, I'm trying to, we're gonna have public witnesses after the government witnesses. And as we have this conversation, I know there's a community in the district who has a methadone clinic. They don't want the clinic there anymore because they believe that the clinic is associated with all the other things that are going on in the community, whether it be crime, whether it be trash, whether it be, whatever, what have you. And so there is a disconnect either in what people think about these clinics because of how they see them presented in their communities, or what's happening on the inside, or are these clinics also dealing with the other either medical comorbidities that people are dealing with, or just the life comorbidities that people are dealing with, homelessness, needing a job, X, Y, or Z.
Well, we have put a small number of large treatment programs in the most vulnerable communities. And we have stigmatized the treatment there. We've stigmatized the people who go there. And we don't have easy ways in many of those programs, even for people to come inside to be waiting in a comfortable place. And so developing more smaller community embedded programs is going to be one way to address it. I think what the district did around, and much of the country did around methadone programs, has given a huge black eye and misunderstanding about this effective treatment. Because if you go to a methadone program anywhere, what you're likely to see standing outside are the people who aren't doing well. The 80, 90, whatever it is, % of people who are doing well on methadone treatment got there at 5:30 in the morning. They got their medication. They went off to their job and to take care of their responsibilities. And of course, they don't want to broadcast that they're in recovery on methadone because it's got such a bad name. So what's visible are the problems, and what's invisible are how effective and helpful it is. We need to shift the perception. We need to create better environments for programs. We need to distribute programs. That's what I like about our DC Dream Center collaboration is you go there, nobody knows why you're there. You could be there for any reason. You could be there for a job program, or to look on the dream board, or to use the gym, or to get, all these different things. But you could also be there to be linked into drug treatment. And then you don't give that place a bad name, you're welcome. But we've missed that. We need to build out.
It's the program integration. And so I know you have some witnesses later on, and I think some of them will talk about where they have program integration. So it's that combination where they may be getting primary care, dental, behavioral health. So you'll hear that there's more of that focus where there is not that kind of the old fashioned way. And I think that's how we're going to combat. So, there may be programs in communities that people don't even know about. And that's the way to go.
I met with my counterpart on the New York City Council, who is the chair of their behavioral health and addiction committee. And she was we were talking about On Point in New York. And she said, you wouldn't even know what you were going there for, because the first 2 floors, it's like food services or laundry services, and there's job training, and then there's, other things. Like you have to go through the layers to even get to the assisted injection pieces. But I think this was an excellent conversation. I thank you so much to all of our witnesses today. Before, we've had these conversations, and we're still going to be ongoing. As I said in my opening statement, our goal for the committee, we're going to be working over this over the summer, and our goal is for us to have a roadmap of where we're going in the fall, with some actionable solutions, whether it be policy, whether it be funding ask. I heard that earlier from panels around what are the money needs, and then what are some other bureaucracy silo challenges that we need to get our agencies together to sort of talk about. So thank you so much to this panel of witnesses, and thank you to all of our expert witnesses thus far. As I telegraphed before, we're going to take a 5-minute break. And then when we come back, we'll have our government witnesses, Dr. Bazaran, Mr. Zamor from DC Health, and Dr. Diaz. And then we'll go from there. So thank you guys so much. We're taking a 5-minute recess. Oh, yes, yes, yes. All right, guys, we want to go ahead and get started. Okay. All right, we are back. Thank you guys so much for your patience. And as we switch things up, I'm going to call an audible and change the witness list order. But before I get there, I'm supposed to swear y'all in. Hold on. Hang on one second. Oh, yes. Here we go. That is a requirement for everyone, for government witnesses for every committee. So if you can all raise your right hand. Do you swear or affirm under penalty of law that the testimony you're about to provide to the Council of the District of Columbia and this committee is the truth, the whole truth, and nothing but the truth?
I do.
Thank you. Are we good on TV, cable, etc.? Okay. Sorry, it hasn't come back yet, so hold on a second. I still think we're on break, so. We're good? Okay. All right, so I'm going to switch the order. I'm actually going to have Dr. Diaz go first, as he has the numbers to sort of lay the groundwork for some of the conversation. Dr. Diaz?
Thank you very much. Thank you for having us today. I will be intentionally brief, but I think for the benefit of everybody, I would like to briefly explain the role of the Office of the Chief Medical Examiner, which statutorily is similar to any other medical examiner or coroner's jurisdiction in the United States. We have to investigate and determine the cause of death and classify the manner of death in sudden unexpected death, death as a result of violence, and for example, that goes drug-related, suspected drug-related death, motor vehicular collision, suspected homicide, suspected suicides. At the end of any given calendar year, traditionally, any medical examiner would have that 50% of the examinations ended up being natural. The example I gave you previously, somebody that collapses on the street without medical history, at the end of the day, they will have some sort of cardiovascular condition. There has been a paradigm shift in the United States since the year 2006. And I would like to talk briefly about that paradigm shift as we compare and contrast the number of deaths and the demographic of death in the District of Columbia as opposed to other jurisdictions. For example, I work in the state of Michigan for nearly 2 decades. And when we talk about the numbers, Dr. Chapman and other witnesses point out 2015. I will go back 1 year, the year 2014. If you look at the statistics, the District of Columbia had 83 drug-related death or opiate-related death. 2022, 458. So that's a 500% increase, nearly 600% increase, 6 times. And it is worth of note that in analyzing the decomposition in the postmortem toxicology results, in the year 2022, 99% of opiate-related death contain fentanyl, as opposed to 68%, still high in 2014, 2015. So fentanyl is the biggest component. When I was working in Michigan, it's a way larger jurisdiction than the District of Columbia, but we perform 2,000 autopsies on average every year, and approximately 10% of those were drug-related death. And by the time I left and come to work in the district in the year 2017, they had 1,500. So that's nearly 800% increase. The demographics is completely different. And I think Dr. Chapman in a previous testimony, compare and contrast that. There was a lot of opiates in pill form, prescription opiates, Vicodin, OxyContin, and so on, combined with other substances. In the district, we know is mainly African Americans between the ages of 40 to 69. That is 3 out of 4. Those 3 out of 4 of those are males. And the other demographics are not quite as overrepresented as African Americans. I keep quoting Dr. Chapman, but he made really, really good points. What is the characteristics, the commonality in those victims of opiates in the District of Columbia? Underlying medical conditions. And those underlying medical conditions are hypertensive cardiovascular disease, arteriosclerotic cardiovascular disease, chronic kidney disease, diabetes, or all of the above. If you combine that with fentanyl use, now we know why those people are dying. I am very proud to work for the District of Columbia because the resources provided allow us to perform not only complete autopsies, but to perform comprehensive postmortem toxicology. Unfortunately, and this is not to make a negative comment, in a lot of jurisdictions in the United States, they have taken the posture of not performing autopsies or comprehensive toxicology because the prevailing thought is we know why they died if the circumstances lead to that conclusion. And postmortem toxicology is expensive and time-consuming. Perhaps in the question and answer session, I could go into detail regarding postmortem toxicology, the time it takes, and so on and so forth. It is worth of note as well that the District of Columbia Medical Examiner's Office is the only jurisdiction in the United States that took care of processing and certifying COVID-related death. To that end, our cases increased dramatically. But I will put, and I will finalize with this. When I came to the district that year, 2017, we have 3,200 accepted cases in the District of Columbia. 2020, which was the year of COVID, 4,999. Then we are not certifying COVID-related death. However, the year 2022 and 2021, we have 4,500 approximately death. What does that tell you? We have a net increase in the number of cases, not unique to the United States. There is an excess of death in the United States. So much so that a lot of jurisdiction is reverting back to what it used to be 25 years ago, where natural death are 50%. However, the number of opioid-related death in the district did not decrease, quite the opposite during COVID. We went from 289 in the year 2019 to 420 something in the year 2022 and 458 in the year 2022. And then this year we have already certified 105 and still we have cases where the toxicology is pending. I'm going to stop here and then I will welcome any questions about postmortem toxicology as well as certifying drug-related death.
Thank you, Dr. Diaz. We definitely have some questions. Dr. Bazran?
Good afternoon, Chair Gray, Chairperson Henderson, Chair Parker, and council members and staff. I'm Dr. Barbara J. Bazron, Director of the Department of Behavioral Health. Under the leadership of Mayor Bowser and the guidance of Deputy Mayor Wayne Turnage, DBH supports healthier and stronger communities by working to prevent the onset of mental and substance use disorders and providing a range of treatment services and recovery supports. We welcome the opportunity to discuss the implementation of Live Long DC, the district's comprehensive plan to reduce opioid use, misuse, and related deaths. Using a public health approach, the District of Columbia, led by DBH, has adopted evidence-based practices in prevention, harm reduction, treatment, and recovery to save and change lives. In my remarks, I will provide an overview of our accomplishments, effective strategies, and future initiatives. There is a movement taking place in DC to fight the opioid epidemic driven by urgency and shared purpose. The Live Long DC strategic plan, released in December of 2018, was drafted by more than 40 community-based groups along with government agencies and federal partners. We have sustained this broad participation and sense of urgency with monthly strategy group meetings and quarterly summits to assess our progress and adjust strategies. The DC Opioid Working Group, made up of first responders, meets regularly to collaborate and ensure efficiency across agencies. The movement to fight the opioid epidemic is rooted in work taking place in communities by leaders and organizations who work, many for decades, to keep their neighborhoods safe, healthy, and strong. We hold bi-monthly meetings in each ward to review overdose data trends, to plan outreach, address barriers or challenges to care, and collaborate to educate and support those impacted by opioid use disorders. Our movement centers peer leadership and support throughout our strategy. DBH funds 4 peer-operated centers where peers model resiliency and recovery, connect people to treatment, and provide recovery support services. Primary care settings provide an opportunity to address opioid use disorders. Through our work with the DC Hospital Association, every person who comes to the emergency department of any community hospital is screened for substance use disorders. Medicaid-assisted treatment can start right there. Peers are located in the community hospitals to engage individuals and to encourage treatment. We have partnerships with the Psychiatric Institute of Washington and 5 federally qualified clinics. Harm reduction is the heart of our fight to save lives. Opioid overdose deaths is preventable. Harm reduction is an evidence-based approach to work with people who use drugs to keep them alive and as healthy as possible while engaging them in seeking treatment. Harm reduction also engages families and friends and brings the community to be a part of our overdose prevention strategy. While the opioid epidemic might be most visible in where people who appear to face substance use challenges congregate outside, as Dr. Diaz reports, the majority of overdose deaths occur in their homes or in the homes of families and friends. Our harm reduction strategies include widespread availability of life-saving naloxone and fentanyl test strips and a safe syringe program. Nearly 3,500 reported overdose reversals using naloxone have been reported by our community partners and by FEMS. The district is a national leader in making life-saving naloxone free and easy to get. More than 204,000 naloxone kits have been distributed through 130 sites across the district by mail or personal delivery. There currently are 6 naloxone vending machines located at community-based organizations and fire stations with plans to add more. With fentanyl present in 99% of overdose deaths and the law changed by the council, we stepped up the distribution of fentanyl test strips with 3,100 distributed so far this fiscal year. Our safe syringe program works to prevent overdose deaths and infectious disease transmission and offers low barrier options for accessing treatment. Working with our partners, we have made it easy to access treatment with multiple entry points that include healthcare settings that I talked about previously, free transportation to DBH certified providers located in all 8 wards, medication assisted treatment centers, and a roving DBH mobile van. A full range of substance use disorder treatment services is available, and crisis care is available day and night. The new DC Stabilization and Sobering Center, scheduled to open this summer, will offer peer support to encourage treatment. We also offer a route to treatment through our work to train staff in skilled nursing and long-term care facilities and our resource guide to aid the screening and treatment of pregnant and postpartum women. Medication-assisted treatment along with counseling is available in the DC jail, and we work to maintain the connection to care upon release. To reinforce treatment options, FEMS outreach teams engage overdose survivors who refuse transport to a hospital emergency department. In FY22, there was a 6% increase in the number of people in treatment. Safe, supported housing is crucial for individuals to sustain recovery. Along with Oxford House, DBH has added a new model of recovery housing that provides intensive care management and counseling for individuals who may relapse in their recovery from this chronic disease. We also set aside recovery housing for men and women returning from incarceration. With our partners, we have established a robust data collection system that informs our strategies, including when and where to deploy outreach teams. It also allows us to track health outcomes for individuals connected to care. Through the work of community-based organizations, the ward-based prevention centers, and faith leaders, we have focused attention on prevention of opioid use and combated the damaging stereotype that addiction or opioid use is a personal weakness or cause of shame. Thousands of residents have participated in hundreds of community meetings, events, and other activities that promote understanding of addiction as a disease. Thousands have naloxone on hand and are ready to save a life of a loved one at risk of an overdose, a neighbor, or even a stranger. Our robust social media and marketing has broken down stereotypes with personal stories of recovery. Looking ahead, we are working with our partners to update Live Long DC for the third time to address gaps or emergent issues. We anticipate the revised plan will double down on what we know works now and increase funding for faith-based groups, award many grants to community-based efforts, target recovery housing for those with medical needs and pregnant women and women with young children, and add support for young people. We also anticipate the use of the Opioid Abatement Fund to complement the work of Live Long DC. We are recruiting for a director of the new Office of Opioid Abatement and finalizing the membership of the Opioid Abatement Advisory Commission. We anticipate the first commission meeting will be held in late July. This concludes my remarks, and I look forward to our discussion. Thank you very much for having me.
Thank you, Dr. Bazran. Mr. Zamore?
Good afternoon, Chairwoman Henderson, Chairman Gray, council members and committee staff. My name is Kenan Zamore, and I am a senior research epidemiologist for the District of Columbia Department of Health. I work out of our Center for Policy Planning and Evaluation. So on behalf of Mr. Keith Fletcher, our interim director, I'm pleased to offer testimony on DC Health's actions to support our fight against the opioid and fentanyl epidemic. So much like the rest of the nation, District of Columbia has experienced alarming increases in opioid overdose fatalities. Since 2014, they've gone up, like Dr. Diaz said, over 400%. And as of March this year, we're at 105. There's also been a significant increase in the proportion of overdose deaths that involve fentanyl. In 2016, that was 62%. That increased to 91% in 2019, and last year it was 99%. So the crisis has also had an inequitable impact with Black district residents who have been over 85% of our opioid overdose fatalities since 2017. This is particularly concentrated in Black men over the age of 40. And in 2022, 71% of our fatalities occurred among people from 40 to 69, continuing a trend that's lasted the past decade. But while people under the age of 19 are not a large share of our deaths, there was sadly 7 lives lost within that range last year, which is cause for concern. Another demographic trend that hasn't changed is gender. Over 2/3 of these are male. Additionally, most district residents who overdose live in wards 5, 7, or 8. We see about 2/3 of our overdoses there. So we understand the magnitude of this crisis and the need for solutions that are centered in health equity and explicitly designed to reduce these disparities. So recognizing this crisis, Mayor Bowser released the district's first comprehensive plan to end the opioid epidemic in 2018. This multi-agency collaboration led by the Department of Behavioral Health is supported by DC Health. And we're pleased to continue our work under the recently released Live Long DC 2.0. So this plan leverages some of the lessons we've learned from the first 5 years, as well as a new focus on fentanyl to eliminate health disparities related to opioid use. We collaborate regularly with DBH on our joint efforts to reduce opioid misuse and overdoses, such as the DC Stabilization and Sobering Center. And we hold monthly meetings between our two directors and senior leadership. Our agency continues to track both fatal and non-fatal overdoses to support our programs and overall district efforts to reduce opioid misuse. In conjunction with the Office of the Chief Medical Examiner, DC Health created the DC State Unintentional Drug Overdose Reporting System, SUDORS, and collects circumstantial and toxicology data on every opioid-related fatality. We've done that since 2017. For non-fatal data, DC Health reports monthly using data from both fire and EMS and our hospital emergency departments. We also use a tool called ODMAP, our overdose mapping program, which is in conjunction with the high-intensity drug trafficking area to provide real-time data on our non-fatal overdoses using FEMS data to our community partners. Our Center for Policy Planning and Evaluation has worked to better understand the impacts of the opioid epidemic and trends in toxicology. So over the past several years, there have been several significant changes in drug composition. We observed a 400% increase in the fentanyl analog, chlorofentanyl, a synthetic drug more potent than fentanyl, and a 60% increase in the toxic adulterant xylazine, also known as tranq, which is only approved by the FDA for veterinary use. So xylazine is a unique problem because naloxone, which we count on to reverse overdoses, loses its efficacy when opioids are combined with xylazine. So these changes have made opioids and opioid use in the district much more dangerous and have accounted for some of these fatalities as well. So our research actually shows that just under half of people that receive care from FEMS had a previous overdose. And about 40% of our people who do overdose and are treated by FEMS do not seek medical care after that, which is concerning. They refuse transport. So this research allows us to understand the landscape of the district's opioid epidemic and tailor strategies and funding for an effective response. So we also look upstream to address some of the root causes of overdoses, which can be traced back to controlled substance misprescribing or drug-seeking behavior at providers' offices. The district's prescription drug monitoring program, our PDMP, aims to improve the district's ability to identify and reduce diversion of prescription drugs in an efficient and cost-effective manner that will not impede the appropriate medical utilization of controlled substances. The PDMP captures prescription patterns for all controlled substances and other select pharmaceutical products of concern, such as gabapentin, which, while not a controlled substance, can be used to increase the power of opioids. The PDMP also aims to enhance patient care by providing prescription monitoring information that will assure legitimate use of pharmaceutical products in healthcare, including palliative care, research, and other medical and pharmacological uses. So between the launch of the district's PDMP in 2016 and 2021, there are over 20,000 registered users now who made over 312,000 inquiries for their patients. Through this program, which is in place in all 50 states and DC, we can arm prescribers with ability to limit the distribution of pharmaceutical products that result in substance abuse. The PDMP issues an annual report providing an overview of the purpose and implementation of the program, and also ways that the district is using the data from the PDMP. We also worked with our partners in the education space to address opioid overdoses in DC schools. We have memorandums of agreement with DBH, the District of Columbia Public Schools, and District of Columbia Public Charter Schools to address opioid overdoses by allowing naloxone to be available in schools. We have all 119 DCPS campuses, and we have 88 DCPCS campuses now, many of which participate in the school health services program and have naloxone available in the building. These naloxone kits have had an immediate impact, including being used in 2 incidents where students experienced an overdose at school. We're committed to continuing this partnership with the education system and will continue long-term analysis of naloxone use within schools, as well as trying to expand that access to private and parochial schools. Finally, our community-based programs play a key role in providing harm reduction to users and quickly responding to overdoses in the district. We have a team of drug user health pairs, DUHPs, and these pairs use their training and experience in harm reduction to provide navigation services for both survivors of opioid overdoses and those who are at increased risk for overdose in the district. DUHPs address substance use disorders by providing overdose reversals, harm reduction education, linkages to HIV, hepatitis C, TB, COVID testing and treatment, and referrals to other social support services. We're also working with local community partners to implement community conversations. So this program will engage a broad audience of providers, consumers, and community members at large. Events through the program will educate district residents on opioid use and overdose response and reduce stigma directed towards people with OUD or to anyone who uses drugs. We're also working with HIPS to implement its Women's Wellness Initiative, which connects women experiencing homelessness who often use or previously have used drugs with linkages to care and support services. We're also setting up a drop-in center for people at greatest risk of overdose, and that'll include individuals involved in the criminal justice system and individuals who've recently experienced an overdose. We'll offer service navigation, access to basic resources, community engagement, wellness services, and connections to OUD treatment and other health services. I want to thank the Committees on Health and Hospital and Health Equity for hosting DC Health and our sister agencies to continue to raise awareness of the importance of combating the opioid and fentanyl epidemic. I look forward to continuing this conversation today with my colleagues from the other agencies and members of the committee.
Thank you. You made it. It's okay. It's always, you know, a tough thing for folks when they testify for the first time, especially when you see the clock ticking down. So you did a great job. Thank you all so much for your testimony. There are so many different places that I can go with this because there's so much rich conversation that came up today. But Mr. Zamora, I want to pick up on something that you talked about in your testimony just now, where you said, our research has shown that 44.3% of people that receive care from FEMS during opioid overdose had previously experienced an overdose. And so while we have spent a lot of time talking about fatalities, I'm curious, do we have an idea of the universe of just overdoses where people lived in terms of what we're talking about here? Obviously, it's an estimate because people, when they use naloxone, don't necessarily report that back to any of your agencies. But I'm curious, I know we have 458 deaths, but how many other people overdosed? And we're not necessarily talking about that. Dr. Bassaran?
Yes, I think that we do collect some overdose data, but I really need to qualify it. We have 3,424 reported overdoses, but understand that that data only represents the data from FEMS and our community providers.
Okay.
There may be other people who have actually been reversed in the community or in other places, and we don't have that data because that is, we don't have a way of capturing that. So we know that's the floor. I mean, but even thinking about that, that means there are 3,500 lives that have been saved.
Right. Do hospitals not report?
Hospitals.
Because you said community health centers.
Yeah, well, like for example, if Fire and Emergency Medical Center, they generally are the ones that take people to the hospital, and we do get those data, and that's included in this particular number.
Okay.
So I think that
regardless of whether or not someone wanted to be transported, because I think
regardless of whether they wanted to be transported.
Okay. Okay. I think that's a huge number, and to your point, that is the floor.
That's right.
We know that there is way more that is going on there.
And by the way, we do follow up with those individuals, and that's one of the reasons why FEMS now has added a peer to their team so that the peer can be right there as opposed to them needing to inform us and then have somebody come so that that person can be in direct contact right at that moment. And so we do, when we know who has overdosed, we follow up and try to engage those individuals through our peer resources. So it's not like it's okay, you overdose.
Right, right. Dr. Diaz, I want to turn to you to talk a little bit about the toxicology reports because, excuse me, something that came up earlier today was around the need for more real-time data to determine what's working, what's not. And I did bring up that I think the most recent report that we have from your office, while dated, I think June 20th, it was back to March. But then you said in your testimony, we still have some cases of toxicology reports that are pending. So can you talk a little bit through what is the timeline here?
Absolutely. I'm glad you had asked that question because it's worth educating the public at large. Blood doesn't circulate on the dead. And postmortem toxicology examination, it takes a balancing act between the different samples you take and analyzing those samples. There is an old saying that says that the eyes cannot see what the brain doesn't know. The same goes for postmortem toxicology. Years ago, I gave the example of years ago, what are the common substances? Heroin, cocaine, or a combination of both. Nowadays, we are encountering on a daily basis new substances that are made not in the pharmacological industry, but on somebody's garage. To give you an example, synthetic cannabinoids. Synthetic cannabinoid, the chemical formula for marijuana is rather simple. But if you substitute an oxygen for a hydrogen or a nitrogen, it's something different. And I put that as an example because there was only tetrahydrocannabinoid. That's the main component of marijuana. Right now, today, there are in excess of 2,000 components that are very similar in chemical structure, but they are not quite. So how an instrument can pick that up? The instrument cannot pick it up unless you have a reference library attesting to that. So the methods need to be validated once you are aware that there is a substance there. So you cannot have in postmortem toxicology an instantaneous result. The word screening, for example, somebody told me, and rightfully so, how come if I go to an emergency room, they will know if I have cocaine or opiates? Say, sure, because they will do a quick screen test on your urine, and then they have an idea of what you may have, and therefore the treatment will be guided to that.
They can't say specifically.
They cannot. In a world where nowadays we're dealing on the average death, they may have 10 to 15 different substances in postmortem toxicology, 10 to 15. That includes opiates, that includes stimulants like phencyclidine, cocaine, the so-called bath salts, and so on, all of that in one single person that died. That takes time. To answer your question specifically, our turnaround time for our postmortem forensic toxicology laboratory is approximately 60 days. 60 days. And I encourage anybody to compare and contrast that with other jurisdictions where it might be 6 months to a year. And as I said before on my opening remarks, some jurisdictions are taking the posture of not performing postmortem toxicology. And in that sense, if you don't do it, if you just have a screening test in urine, you could certify it, but you don't know exactly the amount of the substance and the different component, the different substances that there is.
So how then are you all able to more quickly determine if there is a new chemical compound that's now out on the street? So for instance, Mr. Zamore talked about xylazine.
Yes.
If it takes 60 days for us but you have to then know what you're looking for.
Yes.
What are our methods here to keep up with
it's
the garage chemists, as you?
It is an uphill battle, but our chemists and toxicologists are up to date in that battle. So it requires a multidisciplinary effort and communications. What other places are seeing? I have with me the syringe exchange program. That's analysis performed by our forensic science laboratory. So the syringes that are exchanged, they are analyzed in our building. What are the components there? And that could have a real-time implication on what's there. So every single day, you know, if we know, just to mention one city, that in Philadelphia, they're seeing xylazine, that's where, you know, then we start looking, validating our methods in order to be up to date. But believe me when I tell you, every single day we're finding novel substances. How do you determine the cause of death in that world? Separate and apart from the pre-existing conditions that I told you. And I think it's good to mention, I don't want to take much more time, but the paradigm shift in how the mechanism of how people die, it has changed the definition on how quickly a person could die. Could die in what I call a round. And that means I inject myself with something, goes through my bloodstream one time, the heart beats 72 times a minute on average, you could be dead right then and there. Half of the cases that we analyzed, the person died, I cannot do it physically now, but in the catcher's position. So they're injecting it in that position, they die and they're found, they don't move. So that means they didn't die instantaneously, but pretty close to instantaneously, a second or two. The substances went through their system one time and they're out. That didn't happen 25 years ago. It was a slower process of respiratory depression, coma, and death. People could die instantaneously. Now, as Dr. Chapman said, some people have genetic predispositions and tolerance. We all have. You know, that's the next level of pharmacogenetics. What are we? You know, can I process Tylenol better than any other person? You know, your genetics will determine that. Am I tolerant to painkillers or not? Or they don't do anything to me? So that will be the next level. To answer your question, and I will speculate a little bit, you know, the ratio that was given 7-1, I would say probably is closer to 10-1 if we review the histories of people who died of drug-related death. 80% of them, they have previous instances documented by family. And you have to take into account in that universe, there is a universe of people that die by themselves, that were no emergency medical service first responders went, or they died at home. And again, I want to reiterate that when you're dead, analyzing is difficult. Just, you know, I grew up in the Caribbean. You died at 8 a.m., by 4 p.m., you are completely decomposed, exposed to the element, right? In Michigan, no. In Washington, D.C., yes. So if I die here now in a controlled environment, my fluids are not going to be amenable to decomposition. But if I died on the street on Pennsylvania Avenue and you find me 3 hours later and you do the testing, it requires a lot of comparing and contrasting. That's what makes it difficult because the person is dead. So you need to analyze a lot of different substrate in order to get accurate results.
Thank you. I wish I got in like a disclaimer to people who are listening in. We're going to talk about some morbid things. But thank you for that. I'll have some more questions. Councilmember Gray.
Thank you very much, Councilmember. What a very informative presentation by the medical examiner. Thank you so much to him and for the work that he's doing at this point. And I'll look forward to continuing to work with him and to you, Dr. Bazran.
Councilmember Gray, can you repeat your question?
No, I was really just simply citing the fact that I appreciated the work that he's doing and the presentation he made today. And I'll look forward to continuing to work with him and with you.
Oh, great. We look forward to continuing to work on this issue together as well. Councilmember Parker, you have some questions for this panel?
was gonna go in a different direction, but Dr. Diaz, that was a fascinating exchange that then just made me have so many other questions. But for the push for more real-time data, you're saying the analyses that your office needs to do makes it hard for that to happen? Is that the takeaway?
Right. Those analyses take time. And the instrumentation, also you cannot analyze one at a time. You need to batch once you have a minimum number to analyze in a single instrument.
So one of our earlier panelists shared about the Rhode Island dashboard, and I went and looked at it, and their latest update was June 19th. It's not today, but it was June 19th. And so what are they doing that we're not doing? Or are they having different cases than we're having?
No, yes and no. No, they're not having different cases. We have data as well, but what is not seen, we publish data on opioid-related death every month in our website, on the medical examiner website. But with a disclaimer, there are cases that are still pending. So if somebody dies today, and today is June the 28th, reasonably, if the toxicology is negative, the autopsy could be finalized within a week or two. But the complexity of the number of substance preclude that unless you do a truncated analysis.
And that makes sense to me, that there are some analyses that just take more time, they're more complex for a host of factors. But what you just said is the data is on your website monthly.
Yes.
Which is even sooner than March for the dated June report. And so maybe it's just getting that information out to the public more readily and to providers so that they can utilize that information.
Yes, absolutely.
So that is helpful. Mr. Zamore, how many overdose deaths account for mishandling of prescription drugs? You talked about our tracking of that, and I know I imagine it's a much smaller number than fentanyl and all of these other things. But can you just speak to how many of our overdose deaths are related to the abuse of prescription drugs?
So in the toxicology, and this would be in the medical examiner's reporting as well, we don't see a huge role for prescription drugs. We see them on board, but we don't know if they may have been present in doses to cause the death.
So I recently went with DBH and a host of other partners in Ward 5 to a prescription take back event. And I was glad to be there. But that's also making me think, like, if we have limited resources and limited time, maybe we need to devote more of our time to where we're seeing more of the deaths. It's still pretty important to keep harmful prescriptions out of the wrong hands. But what you're suggesting is that that's not a significant cause for people dying as a result of overdose.
I think a lot of that is really the national narrative, where we saw, people who were prescribed eventually became addicted and then started seeking on the streets once the regulations for prescribing were tightened up. Like, typically, we don't really see that type of initiation here. We really have older users who've been using for decades, but the reason they're dying is the supply is tainted. It's just become much more dangerous to use.
And Dr. Diaz, you wanted to jump in?
Yes, we need to keep an eye, because what is true today may be the complete opposite tomorrow in terms of abusing drugs and in dying as a result of opiates. And for example, OxyContin, that's a commercial name for oxycodone, we only have 15
That's 15?
15 in the year 2022. Hydrocodone, which is Vicodin, only 1. And so it's minimal as you compare the universe of 458. However, there is no guarantee that will change in 6 months' time. Because it keeps changing the number of substances that are encountered. Thus far, it's not a major issue. And that tells you the complexity. When I said about truncated toxicology examinations, you can you can have an answer within a couple of days if the person has opiates, stimulants, and so on. That's quick. But to have detailed enumerations with numbers of concentrations of 20 different substances in a person, take into account that we're talking about the substances that will end up killing the person. But we also analyze what the substances are caught with. And that includes a whole host of issues, from Tylenol to xylazine, which is tranq, to baking powder, that's very old fashioned, to all sorts of animal veterinary medications, including one that I haven't heard since I was a little kid, a French medication that was used for fever, but creates tremendous side effects in the immunological system. They're cutting now in the West Coast with that.
Wow.
So that's not going to kill you, but it might chronically may kill you because it may create problems in your bone marrow. So those are analyzed as well. What is the role in the death of those substances?
Super helpful. Dr. Bassaran, I wanted to come to you. And we heard a lot of discussion about the PEERS program. One of the things that you had talked about earlier is the sobering center that is to open will have a peer operation. Can you just speak more how many folk will exist in that sobering center?
First of all, within the center, there'll be a full range of clinicians and peer supports, and they will be available 24/7 around the clock. And so that will include certified peers who will be there to work with individuals as they come in.
So quick follow-up there. I still want to know the number, but I remember concern during our oversight months that people were saying, well, nobody asked for these sobering centers, and instead we need to focus on opioid deaths. And when you said that, I was thinking like, oh, we will be able to care for people who are struggling with substance abuse or opioid abuse. And I just want to make sure it's the same type of peer support. Are we talking about peer coaches for those that are struggling with alcohol abuse or drug abuse, or is it the same thing?
Okay. First of all, one of the things that we did as we built the budget for the sobering center is we built a blended funded framework. And the reason we did that is because SOAR dollars are a portion of the funding, and there are restrictions in terms of how those SOAR dollars can be used. However, we do know that alcohol is also a drug of choice for many people, and we wanted to be able to serve whoever came through the door. And so the peers that we have will be people who are in recovery from alcohol abuse, people who are in recovery from opioid use disorders.
So if I am struggling with opioids, those peers can support me even in the sobering center.
That's correct.
Okay. So that addresses the concern that we heard from advocates earlier that said, we don't want these sobering centers. We need more opioid support. And what I'm hearing you say is there will be support by way of those peers on the ground. That was a layup.
Thank you for that. Yes. By the way, I'm very excited about this center opening.
Yes. A few other questions. I only have a minute left. There was also some concern and discrepancy around how many peers have been trained through DBH versus how many have been employed. Do you have those numbers? And what I'm hearing is that far fewer are being employed than are being trained.
Well, first of all, I can say to you that I think a part of it was during COVID, we ceased the peer certification program for obvious reasons. We have restarted that program. And so we have trained up additional peers. And during FY23, for example, we have certified 10 additional peers. We have several hundred peers available right now that are working all across the system in hospitals, in our core service agencies and SUD centers and so on. And so that's a very important piece of our peer certification program. Right now, we had 141 in FY '21.
Those 121 trained or
No,
employed?
certified.
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 Okay.
128 in FY '22 and 144 in FY '23. So we're continually training peers so
Okay.
that we have that support.
Chairperson Henderson, could I have one more minute?
Sure.
And I am going to have to leave. I have a community event that I have to get to that is about health and wellness. And so, Dr. Bazaran, two things that I would like to raise, and if you all could follow up, I would appreciate it. So just a comparison of how many are trained or certified versus employed, if you all are tracking that number, because I am hearing there is a difference, and maybe that's not a criticism to DBH, but it would let us know about what do we need to be doing to get more of those people into employment. And then the second, I'm hearing questions around the certification for the peers, that that certification is not recognized, as I'm hearing and understanding, outside of DC. Whereas other jurisdictions are transferable, perhaps because they're going through national certification programs.
And we are working towards national certification.
Okay.
So that's one thing that we do have on the table. And then the second thing to note is that in terms of peers being hired, we just actually had a hiring expo for peers. And at that time, 2 people were hired right on the spot.
Nice.
And we got applications for others that are currently being considered. And so we are really moving to address that issue.
Okay, so
And I
just
can
to
give you the
just to
numbers.
reiterate, comparison between how many are certified
Right.
versus employed.
Right,
And it seems like you all are working to
correct.
help people get employment. And then the second is, I guess, a timeline of your working to get national certification for the
Right.
peers, so that certification can be recognized in other jurisdictions, namely Maryland and Virginia, if need
Certainly.
be.
And we're working towards that.
Okay, thank you all.
Thank you, Councilmember Parker. Dr. Bazaran or Mr. Zamore, when can we expect an update to the district's Live Long DC plan? We rolled it out in 2018. Seen a spike. Do we feel like our plan is still good?
Well, I think that, first of all, I'd like to say that we've been really working with the full complement of our partners around the plan. And we've been working on that for a while. And we hope to have a new plan very shortly within, the
This
fall.
calendar year?
Yeah, within the fall.
Oh,
Yeah,
August
right.
31st.
Because we are really moving in that direction.
Okay.
And because we've learned a lot about what we might want to address differently. And I shared some of those things in my remarks.
Right.
And so we're really moving to do that. Things like what we have learned. We want to engage the faith-based community, but the $60,000 grants are too small. So we need to expand them. We want to give mini grants to people in the community who have great ideas as another thing. We want to expand the housing and residential services and supports that people need. We want to address youth, big issue for us right now in terms of substance use disorders. And so those kinds of things will be included in 2.5, I guess you might call it, because we're now at 2.0. And we do hope to release that early fall.
Okay.
End of summer, early fall.
That's good to hear. But, one of the things that we heard about from the witnesses earlier was that we need to step up our public messaging altogether, whether it be PSAs, education, those types of pieces. Is the plan that as you guys update Live Long DC, that it will be attached to a public messaging campaign in the same vein that I see PSAs on TV about fatherhood, about still in terms of smoking, don't drink and drive. We're not seeing the same type of messaging about drug use, except for, as folks reported, the overlap that we're getting from PG County.
Yes, well, first of all, we do have a public education campaign underway right now, and I'm sure you've probably seen a lot of the.
I've seen it at the bus stops, but I haven't heard
you
it
know,
on TV or
Well,
on the radio.
and probably you've heard some of that when you go to pump your gas, because we do have it there also. And so we will be expanding that. And we do a lot of public education in person in various venues to try to get the messages out. And so, yes, that is certainly, I think, a big piece of what we need to do as we're moving forward.
Because I think the in-person piece, I do feel like that's important. But when I think about how this country changed its viewpoint towards recycling, what did we do? We went to the kids. We did programs around recycling, et cetera. Then the kids came home and they were really excited to tell their parents, oh, don't put the milk carton in the trash, mommy, put it in the recycling bin. When we did outreach campaigns or public safety campaigns about tobacco, it was very specific of this is what can happen to your lungs, or don't smoke or we even seeing ads on TV now around using cannabis and driving, which I think is something that's dispelling a myth and a notion that somehow you're good to still drive when you're under the influence of cannabis. So I guess I'm just trying to understand more, like, a lot of our methods of public messaging seem just a hair bit old school for what we're facing right now.
Yeah, well, the other thing that I should share is that we also are advertising on social media, which we think is a big thing, particularly for some of the young people. And even if you dial 888-811, which is the Live Long DC app, you will get information also on where you can go for treatment, where you can get naloxone.
Are we focus grouping our efforts with various age groups to see if it's working?
I think that that's a part of the plan in terms of developing the next iteration of our communications efforts.
Okay, I think that's super important, because when I think about even like one of the most popular social media accounts around getting information out on COVID was John Hopkins, the
That's
Bloomberg
right.
School of Public Health, and sort of their look. And I think even we had a hearing earlier this year with DC Health talking about bringing in teens to work on their things around the peer health programs and the messaging for that. So I just want to be sure that putting information out to put information out for information's sake is not good if we don't know if it's attracting the audiences that we want, but also hitting them in terms of messages that are important to them.
Right. And the other thing too is, I think earlier you heard from at least one of our directors of the peer centers that are located within and throughout the community. And there's also youth leadership groups that are attached to those particular centers that also are actively involved in putting the message out and making sure that it's targeted to that population, as well as doing it in school as a part of the school-based behavioral health care program.
Part of our strategy, besides the naloxone kits, have been in terms of the fentanyl test strips, which we put out and those kinds of things. And one of the things I was thinking about as I heard the testimony from Mr. Zamora and from Dr. Diaz is that if fentanyl is in, and even earlier when LJ Sislin was talking about, about the drug supply being different, where fentanyl is basically in everything. Do we fear that some folks will get to the point where if fentanyl is in all the drug supply, why do a test strip? Why do a testing? If I need the hit, the rise, I want the pain to end, I'm just gonna risk it all. How do we balance this out when we're combating something that is literally in all of it?
Well, I think that there are a couple of things. First of all, I would not use fentanyl test strips. And also we are looking at some more effective methods of testing to make sure that we have handheld machines that can actually indicate whether or not there's fentanyl in the drug supply.
But the testing strips only tell you if the fentanyl is appears, it doesn't tell you the potency.
That's correct. It only tells you that it's there. But if you know that it's there, then you can make some different decisions. You can decide A, not to use it. You can decide B, to have somebody with you as you're using it to make sure that you can get help. And so it does give the user some different opportunities in terms of how to save their lives. And I think that that's the whole purpose of the test strips.
Dr. Diaz, did you want to add to this convo?
No, I agree 100%. Yes, 99% have fentanyl today,
Right.
but a year from now may be very different. And it's always worth having knowledge than not having that knowledge, in my opinion.
Okay. So what do we do about new emergents like xylazine, which is, you introduce that and naloxone is now less effective?
You are 100% correct. And naloxone, a lot of people define as an antidote. It's not an antidote, it's a reversal of an opiate. But if you have 5 opiates in your system, each one with a different half-life, that means some substances stay in your system 2 hours, some 6 hours. You might be able to reverse 1 or 2, and then you see that the patient will die. That's not to discourage the use, because it works. It certainly works. But that's one of the issues. And if I may, I can abuse your time, and if I can wear my physician hat rather than medical examiner, I think, in my opinion, this is a personal opinion, I think we could prevent some death in our community, because it's very specific, elder African-American men with pre-existing conditions. If we can get them medical treatment for their pre-existing condition, maybe a percentage of them will be in better shape to withstand their drug use until such time they get treatment. A personal opinion.
I don't have enough time to get off another question. I'm going to be, I just want to check in with Councilmember Gray. See if he has any questions now. Okay. Oh, he did. All right. Okay. So I want to keep going then. Yeah, there's so many different pieces that we heard from today. Dr. Bazran and Mr. Zamora, obviously I'm not looking to you guys to represent the entire health cluster, but nonetheless, here you are. There was some testimony earlier today that was raised around reimbursement rates. Residential facilities, the pharmacists who's saying like, we want to do this work, but we're not being compensated for it. How can we bring these issues to the forefront in conversation around the work that we're doing with Live Long DC, so that we can see some movement from the Department of Healthcare Finance on some of this?
Well, first of all, the Department of Behavioral Health works very closely with the Department of Healthcare Finance. And one of the things that we're doing right now in partnership with them is a rate study as a part of our 1115 waiver program. And as a result of that, we're looking at what is the real cost of delivering X service, and then how do we bring our current rate in line with that? Now, those rates have not been published as of yet. However, it's coming very soon. It's coming in FY 24, because it is a part of the CMS process. And so that's one thing. The other thing to look at is the fact that CMS, the Center for Medicaid and Medicare Services, does not allow reimbursement for the housing, the residential care, the sleeping, for the services are reimbursable. And so we use local dollar allocation to pay for the actual bed, if I can kind of divide it that way. And we really are looking at, so what does that look like? So one of the things that we have done this year, by the way, is provided additional funding to our residential providers to kind of help them in terms of being able to cover the cost of care. So we're working on that. It is on our radar.
So what is,
And you can,
there were a couple of different pieces that were brought up. What was your reaction to Mr. Pickering's comment around the rate increase being necessary for residential facilities? I think he said they hadn't had a rate increase in 7 years.
and here again, as I
Is that
said-
part of the rate study?
Well, I think that there are some of the services, remember, all residential services are not reimbursable by CMS. It's only the service provision piece of those. And some of those services are eligible and some are not eligible in terms of the 1115 waiver.
Right, but
Mhm.
again, his point was that there has been no rate increase overall, not just from CMS, but also from us locally. Have
Mhm.
we increased our local?
No, we have
contribution
not
share?
increased our local rate at this time. And
Is-
it's
is
something
that-
that's under consideration, but we have not done it.
Is that part of the rate study? Or is that
Well,
something
it's
different?
not a part of the rate study.
Okay. Because one of the things that came up and has continued to come up is how do we get more residential treatment beds? If I have providers who are already here today telling me our rates are not good enough,
Mhm.
then how do we get more providers to choose to come to the district, whether it be for adults or youth?
Mhm.
Because I think we talked about this a little bit during budget and performance. At least the last census count that we have is that there are 20 beds in the district,
In terms of,
residential rehab.
no, in terms of residential beds, right now, we have 270 residential service beds, 30 environmental stability beds, and 4 crisis beds. That's the nature of the beds we have currently right here in the district.
Are they full?
I'm not sure if they're totally full. I don't think so. No,
So we don't have a wait list for our residential beds?
no, not to my knowledge.
Okay, so
But
you're
those are the numbers. Those are the actual numbers.
that's helpful, but so we don't have a wait list for residential beds, but I have a crisis that's ongoing. So what are we missing here in terms of this? I would say this, there are folks in the community who would be very surprised to learn that we have beds that are available because there are folks in their community who need treatment, but somebody's not getting connected to where they need to go. So how do we improve on that?
Well, I think a part of it here again, I think that's one of the reasons why it's really important for us to have outreach and have peers on the ground that can connect people to care and to continue to push out the messaging on our app so that people who are looking for services know where to get them.
Well, so
I
that,
mean, so that whole communication piece is.
I mean, that's the app. If I'm a provider, let's say, I'm Dr. Christina Henderson.
Yeah.
I have a patient who's come in, they are ready for treatment. Do I have to call every center to find out who
No,
has a
you
bed?
don't. You can call the Access Helpline and call one number and they can tell you where there's availability.
Is there a dashboard of some sort that says, this is the daily
No, we
census
don't have a
today?
bed, we don't have a bed board at this point. That's another one of the things that I'm very interested in establishing. And it's one of the things that as we move to the full carve-in of behavioral health into managed behavioral health care that we plan to construct. But we do not have a bed board, which is what you're talking about.
Okay, of the beds that you did mention, how many of those are for youth?
Very few of them are for youth. Almost none are for
Okay.
youth.
All right, so let's look at the youth provider
Right.
piece. How are we gonna change that?
Yeah, well, I think that here again, we need to recruit providers to serve youth. As a matter of fact, one of the things that I will be doing is we have a noted expert, as I think Dr. Schottenfeld said, who's joined Children's Hospital, and we are going to be meeting together to kind of sort out how we might be able to do better at that. That is a real need within our system. And it's not only that, it's some other jurisdictions are not only doing the beds, but then they're also looking at things like recovery schools and parts of schools that are recovery oriented.
Okay. can we get an update on those efforts perhaps in the fall? To sort of kind of see where you're going on this, because Mr. Zamore, you said children under 19 are not a large portion of the numbers that we see, but there were 7 last year. Dr. Diaz, are we seeing an uptick in this? I'm hearing from lots of the witnesses today say we have a youth problem that is on the rise. We haven't gotten there from a youth problem in terms of fatal. They may not have showed up on your numbers yet, but how the non-fatal piece, how are we capturing that?
That would really just be fine EMS and hospital data. But I mean, it's tough because.
So what do the numbers look like for youth?
They're rising, but not rapidly. I'd say probably about a 10% increase from last year. We can get more specific if we follow up.
Yeah, because I'm a 10% increase from what? So you got the numbers of, you have the numbers for FEMS. What you didn't tell us was disaggregated by age. That would be helpful just to kind of see what's going on, and then a comparison so folks can kind of know. I would say yesterday I posted on my Twitter page a chart from the latest OCME report. I think for a lot of people, they had no idea that we went from 83 fatal overdoses in calendar year 14 to 458 last year. That was sort of an eye-opening thing for them. And I feel like in the conversation around data and transparency, we just have to be open with people around, like, I could say all day long, it's a growing crisis, but some folks, they just need to see numbers in their face of what we're talking about. Is that something we could do?
Yeah, absolutely.
Okay. All right, this is people think it's fun when you don't have colleagues who are here asking questions, but it puts the pressure on for you to not have dead time in the space. Dr. Bazaran, I wanted to ask about an update on the launch of the Office of Opioid Abatement and the commission. Do you have an update you can provide on how things are going?
Oh, certainly. First of all, I think that you are probably aware of the fact that we received funding certification on May 23rd of this year, which allowed us to move forward in terms of accessing the funding that's available. A little over $11 million is currently in the fund. And so, of course, we don't have staff attached there. And so I deployed some of our internal staff to work on that under the direction of Dr. Jean Moise, so that we could begin to get this up and running. So we have done the following. We have sent out letters to the named individuals in the act so that they know that they are appointed to the Opioid Abatement Commission. We are working with both council as well as the mayor's office to get your identified members so that we can then hold a meeting, the first meeting of the commission, which we'd like to have that done, certainly this summer. The other thing to note, and I hope anyone who's listening who's interested will certainly file an application. We posted the application for the director position on Friday.
Okay.
And so we're hoping that there will be somebody with 10 years experience in the field and a track record of running an organization such as this one who will apply. Once we have the director in place, then we can hire the other 3 positions that are attached to this program. So we're moving along. I think we've made a lot of progress. The budget is loaded. And once we have the meeting and we look at what our needs are, and also the other thing I think is very important is we want to make sure that we make the best use of the resources we have. So we really want to look at, these are the services and supports that we can fund with SOAR dollars. These are those additional things that we need. And so since the opioid abatement dollars are more flexible, we'd like to use those to kind of add to the package. The other thing I was very excited about when I read the act was that There's a focus here again on the public health model, which we certainly adhere to. And also there's a focus on co-occurring service delivery, as well as really using the data to determine what we need to do as we move forward. As you know, the council or commission will then make recommendations to the chair of council and the mayor, and they will, through their deliberations, make the final determination in terms of how those funds are spent. So I think we've made some fairly good progress.
Oh, yes, since the budget. This is good to hear. We sent names to the chairman. Have you gotten those names yet?
No.
Yes, okay, so that gives us something for us to do on our follow-up and follow up with the chairman on that. Because I think it's important that this commission at least have a meeting sometime this summer to sort of plan for where we're going, knowing what budget cycles look like. And then also I think what Mr. Greer was saying earlier around like, there's lag time in terms of a procurement, there's lag time in a granting process. And so we want to make sure that we can get going this calendar year on some of that. Okay, I have a little bit of a rapid round. One of the things we talked about with Mr. Pickering and that particular panel was that there are limits on how many days someone can stay in a residential facility and it be covered by their insurance or covered by Medicaid.
Well, no, I think the issue is that you have to meet medical necessity criteria to maintain your place in a particular level of care. And that's in accordance with the ASAM criteria, which is the quality of care framework that we use, which is used, by the way, all across the country as kind of that platinum standard. What he is referring to is years ago when I started in the business, couple years ago. Essentially what would happen is somebody would come in and they'd have 6 months just to be there, or they had 30 days just to be there. And there wasn't the same kind of medical necessity criteria standards that are a part of the ASAM criteria.
How do you
We have to
evaluate
follow that? Huh?
How do you evaluate that? Right. Sure, I might be off the drug and sober in 14 days, but I'm not ready to
I know,
leave.
but there's a whole level of care. It's not that that's the only thing that you can have is that one level of care. There really is a graduated process that people can utilize as they move more and more into recovery. The other thing we've done is we certainly have things like environmental stability housing, so that for 180 days, there's a clean and sober place for somebody to live.
So let's
and
go
so
back
forth.
to you talking about the levels of care. Could someone potentially go through the levels of care with the same provider?
Yes. And RAP, by the way, does have a range of levels of care.
Okay. Could you, someone from your team, follow up with the information around like
Certainly.
what are the various levels?
Yeah, yes, certainly. We can follow up and give you some information on ASAM.
Okay. We also heard earlier that there are federal limitations for federal money on how prevention and outreach funds can be spent. So for instance, you can't pay for food anymore or entertainment on the federal funding. Do we have those same limitations on our local funds?
You can't pay for food. However, that's where it is right now. Interestingly enough, on 2 days ago, I was in a meeting with the Assistant Secretary for SAMHSA. And one of the things that she indicated was that she understood that that was a real barrier to care. And that was something that they were looking at removing so that we could in fact use block grant dollars to pay for food and other essentials that were necessary in terms of the engagement process.
So why do we have that? If we know that that is a barrier to care, why do we have that as a restriction for local dollars?
Well, I think in terms of local dollars, we can use local dollars for some of that, but there are limitations. But we can.
Really answer
And we
my
do.
question.
Right? We do. I'm looking at my team because we do.
Okay, so is there a limit locally that you cannot use local dollars for food?
We can use local dollars for food if we're having a meeting or an activity with people who are in care. What and so.
What about outreach?
For outreach, we do things like we give snacks out when we're going outreach, we give water out, and we do fund those. We don't carry meals out.
Okay. We can why?
I don't know how to respond to.
It's just-
we don't have, we don't have like a food cart that we're moving around in.
No, I understand. And I'm not talking about DBH in particular, but you have grantees and outreach folks who want to use food as an inviting tool to bring people in to share information, et cetera. So I'm trying to understand, the feds do weird things all the time, but I'm trying to understand why we locally, if we know that this is a barrier, why do we say you can't spend local money for food?
Well, you can spend local money for food for consumer related kinds of activities and events. But what I thought you were saying is, do we do like Meals on Wheels?
No, I'm talking about in
All right, I
connection
misunderstood.
with trying to.
Sure, we do that.
Okay.
But it's even going to be better because the assistant secretary is really on board with removing that prohibition period. And so that will even give us more flexibility and more resources to be able to do that, because we know that's the way you engage people.
Yeah. Earlier in our first panel, there was a proposal from Mr. Lane around using the St. Elizabeth Men's Shelter as a pilot site, if you will, around drug testing and some additional pieces of outreach. I know I'm putting y'all on the spot, but any immediate thoughts to his proposal?
Now, I don't have any immediate thoughts. However, I can tell you that the Department of Behavioral Health is working very closely with the Department of Human Services to bump the list, to look at who is in the shelter environment, who is homeless, and who also has a mental health or substance use need, and how can we then work with them to engage them and do outreach to them so that we can get them the care they need.
Mr. Zamora, this might be outside of your scope, and if so, I'll just follow up with DC Health. But Dr. McCants, who's the chair of the Board of Pharmacy, mentioned in her testimony that in 12 states, pharmacists are able to get a DEA number, but not in the district. Do you know why that is the case?
We can follow up with you.
Okay, I know you're in the hot spot. Y'all are going through a period of transition over at DC Health, but I wanted to ask that question and put that on the radar. I also want to follow up on something that Dr. McCants talked about, the medically assisted treatment program with DC Jail, and something that multiple witnesses brought up around once someone transitions out of the jail, how quickly can we connect them to make sure that they're still continuing to receive their treatments? How can we improve that process?
Well, first,
now, I want to preface that by saying I recognize Federal Bureau of Prisons is its own animal situation. We barely get notice sometimes that someone is returning and when they are returning, but DC Jail is different. So go ahead.
Okay, in terms of DC Jail, we actually have in-reach into the jail. Our forensic services program does in-reach, and there is the Ready Center program that we support. And what that does is it does two things. One, it does in-reach before the individuals are released to make sure that they can be connected to a service provider, that they have the medication they need upon release. And also the other issue that came up was around Medicaid. In the District of Columbia, Medicaid is not terminated when you go into the jail. It is suspended. And so that, the minute you're out, it triggers reinstatement of your Medicaid. And so you can then get the services you need. In addition to that, we also work through the Ready Center around employment opportunities. Supported employment is a service that we provide through the Department of Behavioral Health, as long as peer support and other things. And so we've worked very hard with DC Jail in putting services on site, including MAT, including screening, including a specialized unit for both men and women who have a substance use disorder, and then having the Ready Center so that we can help people step out and continue their recovery.
Do we do a similar type with the Youth Services Center with DORIS?
No.
Is that because?
I think it's a great idea. We haven't. I'm just
okay.
being honest. We
Okay,
haven't.
all right. I think we should explore that.
Sure. We haven't.
Because there's likely individuals who are over there who are also dealing with something similar.
Mhm.
And last night, well, it was yesterday, it was all day, but last night, by the time we got to the government witnesses, was talking about the Youth Services Center and their capacity issues, but also just some of the challenges that they're dealing with right now. And this might be an excellent opportunity to layer on, because if you have a young person who's been committed, who also is dealing with addiction issues, this is an excellent opportunity. It's almost like you have a, let's just say, I'm not going to say excellent opportunity for some undivided attention for that young person on this particular issue. Finally, I want to ask about the parity conversation in terms of, this came up from several of the witnesses earlier, where they say we have capacity issues for treatment facilities, but also when we are competing against someone who has cash versus someone who has Medicaid. Do you have the tools to enforce parity?
Well, I think that the Medicaid agency, along with every state in the union, does have a parity requirement. And
I know we have a requirement, but do you feel like you have the tools necessary to actually
Well, what
enforce?
specifically would that look like? For example, nobody goes without services because they don't have the ability to pay. We use our local dollar allocation to support that. So, you know.
I guess I'll have to dig into this a bit more, and perhaps it's not you guys, it's healthcare finance with a little bit of DISB as well. But I would be curious in terms of what is the reporting that allows for you to verify that there is actually parity that is happening. So we can say yes, oh yes, of course we take Medicaid, but is anybody actually looking at your numbers to see, well, how many Medicaid patients did you actually take in your organization? Or did you just say we take Medicaid, but like wink, wink, you're always going to take the private pay or the private insurance over Medicaid?
Yes, I think the Department of Healthcare Finance would be the best agency to respond to that.
Okay.
I don't really have that data.
We will follow up on that front. If you give me just a moment. Dr. Bazaran, do we have an opening date for the Sobering Center?
No, we don't have an opening date. We are still working certainly with the construction crew, and we're hoping to have it open late summer.
Okay. All right. Well, thank you so much to these government witnesses. If you could just follow up with the information that we talked about, or we will follow up with your various agencies on the disaggregated data, et cetera. Oh, wait. I like to say it out loud. For Dr. Bazaran, the information on the various levels of care when someone is stepping down in terms of treatment. And doctors, or excuse me, I'm giving you a whole new degree. Mr. Zamore, information in terms of DC pharmacists and the DEA numbers and the constraints there, but also if we could get the FEMS data or the overall overdose data that we do have disaggregated out by age, not fatal, well, fatal and not, you know, everybody, the whole kit and caboodle. That'd be great.
Yeah, I think his DC Health would be able to.
Awesome. All right. Well, thank you all so much for being here, for this good conversation, and for being great partners. I think we have a lot of work to do, but it's always good to have agencies who are engaged in the conversation. So thank you so much.
Thank you.
So we are going to switch to our public witnesses. All of our public witnesses are virtual. So I'm going to actually do panels of 8 because I only have 16 people on my list. So that would be for those who haven't testified before us before, in order to be elevated as a panelist, you do need to affirmatively accept our invitation. So we're going to invite Marsha Middleton, Sarah Goldman, Rhonda Johnson, Larry Bing, Patricia Quinn, Ashley Ruff, Brittany Marshall, and Rhonda Hamilton. Give it a minute while you guys transition. Okay, I don't see Miss Middleton, but I do see Sarah Goldman. So Sarah, if you want to go ahead and present your testimony.
Hello, my name is Dr. Sarah Goldman. I am an emergency medicine physician here in the district. I see patients every day with opiate use disorder, and we know that all of these patients have a lot of comorbid illness, behavioral health issues, and a lot of medical problems. And I think what a lot of providers are really frustrated about is that we spend countless amounts of time trying to connect people to resources, only to see the same patients come back over and over again in the same position, really crying out for help. And I know that there are a lot of resources in this city and a lot of organizations like Medicaid, MCOs, getting paid to help these patients coordinating their care, and they are not doing so. I would really encourage everybody to take a closer look at the care coordination services going on in the city, because it just seems like there's no communication between all the different providers. There's no communication with behavioral health providers. There's no communication with NGOs. It is just really frustrating. I will also say that I think that, the old system of trying to coordinate care is just really not working. And I would really highly encourage people into looking at programs that are doing things differently, one of the programs that I think a lot of us are really interested in is contingency management, especially around people with opiate use disorder. And if there's a way that we can obtain funding to try to run a pilot program, I think that would really help patients who are really crying out for help. That's all. Thank you so much.
Thank you so much, Dr. Goldman. If you just hold on, we'll ask some questions. Rhonda Johnson.
Good afternoon, Council of the District of Columbia, Committee on Health and the Committee on Hospital and Health Equity. My name is Rhonda L. Johnson. I am a CEO, certified peer specialist, author of 4 published books that address co-occurring disorders, and I'm also a survivor of the crack cocaine epidemic. As a survivor and native resident of Washington, D.C., it saddens my heart how our children and their families are searching for answers from the leadership of Washington, D.C. that experienced the crack cocaine epidemic without solutions for the opioid crisis. If you ask the children what must be done to save them, you will learn that the opioid and fentanyl crisis in DC is a result from generations that have not been educated on what are co-occurring disorders. Combating the opioid fentanyl crisis in DC means this: Council must designate more funding for integrative care. The Council must provide hope to our city by addressing what are co-occurring disorders and how they are the driving force to this opioid crisis. I ask this council the question: do you understand the damages from what are co-occurring disorders? I ask this council, do you know the number of adults, children, and or senior citizens that battle this silent epidemic that is known as co-occurring disorders? Lastly, I ask this council to dive deep into the unaddressed effects and effects of those with opioid disorders and co-occurring disorders and learn their correlation to the crime that's happening in our city, ward by ward. In my conclusion, as we are here today to address solutions for the opioid and fentanyl crisis, I ask this council to consider to create and develop a Washington, D.C. peer council under the leadership of the District of Columbia's City Council. Under this leadership, the peer council can provide education, hope, and strategic solutions from a different perspective that would coincide with the different agencies, organizations, and nonprofits throughout the city. The Washington, D.C. Peer Council should entail members from the certified peer specialists, peer recovery coaches, returning citizen peer leaders, peer hospital navigators, peer veterans, peer library navigators, peer community support leaders, peer responders, advocates, influence, peer trauma-informed care leaders, and youth leaders should be a part of this council. The Washington, D.C. Peer Council can provide transparent solutions as a roadmap from those who have experienced the damages of the opioid fentanyl crisis and its association to co-occurring disorders in regards to addiction, mental health, and suicidal ideation. This Washington, D.C. Peer Council can provide to the D.C. Council what's working and what is not working in real time with real solutions from peers with personal and professional insight and perspective to report the data. We need data here today, y'all, to report the data to the City Council ward to ward. I have included in this testimony the Now Hope to Reality outline for your review. I welcome an opportunity to meet with you to share more strategies on how the Washington, D.C. Peer Council can be impactful with the opioid and fentanyl crisis. Thank you for allowing me to testify today.
Thank you. Larry Bing?
Yeah, good afternoon. Can you all hear me?
Yes, sir. Go ahead.
Hey, thank you, Councilman Henderson, for inviting us. I've been listening all day, and I can say that I agree with most of what I've heard today. I am a prevention navigator. My wife and I, we work out of Dr. Chapman's office. We do what's considered wraparound services for people who suffer from substance abuse and mental health. I just wanted to speak to two things specifically. One that Dr. Bazaran was speaking about when she was up earlier, the Medicaid. The client base that we deal with normally have been dealing with this long term, and they're homeless. So a lot of them at this juncture don't know if their Medicaid, by the time they go to get the medicine, sometimes their Medicaid has expired because they don't have an address. Coming out of COVID, people, the government has been sending out letters telling people to recertify Councilman Gray and Councilman Henderson. And if you're homeless, you don't have an address. So a lot of times clients are not being able, like Dr. Chapman spoke to that earlier about one particular client and the medication and him being unable to receive it. And so that's going to continue to happen because we have a lot of homeless clients. The second thing I wanted to speak to is the Suboxone protocol and the nature of what's happening now. We see a lot of clients that are relapsing, and the reason for it is because they'll be giving generic medication. Most of the clients that have been with Dr. Chapman for long term were on the original brand, and now they're being told that they have to take the generic medication, which in turn doesn't help with their addiction as it relates to this fentanyl now. And so we're seeing a lot of people relapse. And so I know that as a result of listening to the hearing today, that there are a lot of things that have to be dealt with, Councilman Henderson, but some things we need to really sort of get to right away, especially as it deals with the homeless population. Housing continues to be a big issue for our population. People not being able to find places with or without vouchers these days, Councilman Gray, and Councilman Henderson. So there are a lot of things. Earlier, Rhonda just spoke to being on the committee. I too would like to be on the committee. I was asked, I think my name was submitted to be on the opioid committee going forward. And I'm really hoping that I'm allowed to participate because, as Rhonda said earlier, real-time stuff is important dealing with our clients because we see them Monday through Friday. I speak with them over the phone, on my air call, on the computer daily. And it's painful to continuously tell a client daily, weekly, bi-weekly, and monthly that nothing has changed as it relates to housing. You understand? It's hot outside now, but eventually it's going to get cold again. And one other thing, and I know some of you that are downtown are aware, they have 3 hotels that are about to close because they're saying that the money has ran out. They are setting up now to put those people out of the hotels and put them in the shelters, which is going to create a big, big mess. To just let it be said, it's going to create big mess. Those people have been in those hotels for some time, have been able to shower, rest, and all that. Now you're telling them to go back to a shelter. Yeah, they're putting case management and all that in the shelters too. A lot of people don't like dealing with the shelters, Councilmember Henderson. Y'all, they went downtown, they got the 10th population off the street. So now you're telling them that you done ran out of money, and I want you to go back to where you just came from. In addition to everything else that they're already dealing with, primarily is addiction and their mental health structure. So we need to revisit this, especially about this hotels and money running out, because if you sort of seen the streets clean up with people being able to be in a hotel and have somewhere to rest. In the next couple of months, you're not, if they put them back in the street, they're going back to what they know best, Councilmembers Henderson and Gray. They're going to hang on the street. They got to have somewhere to sleep. Thank you.
Thank you, Mr. Bing. Patricia Quinn.
Thank you, Councilmember Henderson and Councilmember Gray, for the opportunity to share DCPCA's recommendations to address the opioid crisis. I'm Patricia Quinn, Vice President of Policy and Partnerships at the Primary Care Association. We'll focus on three main ideas in our testimony: innovation, harm reduction, and well-being measurement. DC needs aggressive new strategies to stem the tide of escalating opioid deaths. One strategy with significant potential to drive new interventions and innovative solutions is the Institute for Healthcare Improvement Equity Action Lab model. An Equity Action Lab brings together frontline providers of care and people in the district impacted by inequity in health outcomes to a shared table to identify, prototype, and test solutions. Coupled with the tools of human-centered design, the Equity Action Lab centers the authority of community members with direct experience, context experts like many of the people on this panel, along with the content expertise of care providers. What emerges are new insights, renewed commitment, and promising new ideas to assess for scaling and improving. We have used the model to address inequity in maternal health outcomes, and we believe it should be funded and employed to improve our opioid use disorder system of care. As the district and its communities, families, and individuals confront the lost potential, lost opportunities, and lost lives sacrificed to opioid addiction, we must pursue strategies centered on harm reduction. We must ask and answer the question, how do we best help people stay alive so they can have a chance for recovery? We should explore safe consumption sites for overdose prevention as a means to deliver other health services. Additionally, we need to provide guidance to family members on how they can effectively provide support while preserving their own well-being. Too often, families have few choices and no guidance for how they might use the tools of harm reduction to help keep their loved ones suffering OUD as safe as possible. Professionals need to translate the tools and techniques they employ for layperson use. People who are addicted engage and intersect with family and community members who want to help but may not know how. Particularly as the Department of Behavioral Health launches the Office of Opioid Abatement and the Opioid Abatement Advisory Commission, DCPCA recommends consideration of well-being and quality of life metrics. Measures of well-being are a better indicator of the social progress necessary for sustained recovery. Simply being sober is not enough. We need to meet basic human needs for safety, housing, and food, and the very human needs for connection and meaningful participation in families and communities. DCPCA has identified a well-being measurement framework based on that developed by Wellbeing in the Nation and centered on Cantrell's ladder. The ladder asks respondents where they would place themselves on the ladder now and where they expect to be in 5 years. Using a measure that resides solely in the hands of individuals and communities to which systems are accountable, builds community power, and promotes cross-sector alignment. Community members experiencing the worst disparities in well-being will define whether and how our systems are successful in supporting individuals and communities to thrive.
Oh, yeah.
Thank you for the opportunity to share our recommendations. We look forward to partnership. Before I close out, I'd like to say this is certainly a professional passion of mine, but it is also a personal passion of mine. I'm the mother of a young man in recovery for 10 years from heroin addiction. And I know that my son is alive today, not because I loved him more than the other mothers whose sons did not make it, not because he was somehow more committed to recovery than so many other people were, but that he had a system of care and things to address the social drivers of health that build a platform for his recovery. And we need to do the same for absolutely everyone struggling under opioid use disorder. Thank you.
Thank you, Ms. Quinn. I don't see Commissioner Ruff on, and I don't see Brittany Marshall, but I do see Rhonda Hamilton. So Ms. Hamilton.
Yes, greetings, Councilwoman Henderson. Thank you very much for the opportunity today. I too have been following along and you've heard quite a bit. I'll do my best not to repeat what's already been repeated. I'm testifying today as the president of the Healthy DC and Me Leadership Coalition. I am also the author and spearhead of the intended standalone Capital City Emergency Level 2 Trauma and Wellness Center that we feel is needed in Ward 8. I speak to you from on the ground I've heard many of the professionals here testify today of their concerns for proper care communications and coordinating of services and resources. I would like for you to understand, Councilmember Henderson, that many of our citizens, and my testimony today is intended to add to the urgency for root cause, decision-making, legislating, and outreach of services. What we're finding, as you hear constantly mentioning in the housing instability specifically, is the reality that I, as a mental health advocate, would be on a call with various agencies, all attempting to provide housing for our homeless citizens, only to find out that the homeless citizens are still in the street because of the inability of these agencies to move them forward. The concern is that DC has consistently sent an average of $2 million back to the federal government for inability for staffing capacities where our citizens were in need of these services. We provide outreach to citizens living at bus stops who have Social Security payee information logged at one of these agencies that are provided contracts. I do not understand why the district is continuing to award large contracts without proper oversight. Our citizens are able to get drugs quicker and faster and more readily than they are to get the true comprehensive services that are needed. East of the river, we're concerned that there's not a culturally relevant presence of resources in order that our citizens would be able to find comprehensive care processes that can identify with what they're dealing with. Our children are being raised by unhealthy adults. We understand that with the usage of fentanyl and opioid, our citizens are more prone to experience depression, hallucination, and other mental health disorders. We also understand that NIH tells us that 48%, councilwomen, of our people that are dependent on drugs will also be depressed or experience depression. We know that at least 30%, if not approximately 200,000 DC citizens are experiencing depression, are experiencing anxiety. On top of that, the co-occurring, as you heard today, the comorbid and medical health issues are relevant every day in the social determinants. Everything, as you heard, from the housing instability to shelters where they're compromised and unhealthy. We have a one-size-fits-all model in the city that is not working. I've got 84-year-old seniors living at bus stops, 79-year-old seniors living in shelters. Homelessness is supposed to be temporary. So I just wanted to point out that with open air drug markets happening daily in the city, with our citizens lacking the access to comprehensive, impactful resources, and with those of us on the ground being contacted only after 2- and 3-year turnaround processes, or citizens that we can convince to sign housing paperwork only to go back to the street to wait for vouchers to be issued. I don't understand why 3 separate organizations have to touch paperwork for situations that were already emergency. So I wanted to come forward, Councilwoman, to make certain that any effort that you guys are going to make towards cleaning up the opioid and the fentanyl and the drug problem in our city be done so with the understanding, the underlying understanding, that we cannot arrest our way out of this. There is a root cause of mental health services needed far and wide. We need oversight for the agencies that are being awarded contracts, but not being held accountable to the proper care of our citizens. And finally, our agency had access to over 200 hotel rooms during COVID, and we could not get a single DC agency to come to the table and have a conversation with us. Our citizens are living in the street. There are agencies out here like ours ready on the ground to do something to help the problem. Our citizens are crying out for help every time the guns go off, every time they're pitching their tents, and when they exercise their right not to vote in these processes because they do not feel that their matters are important enough. Please, when you make your final decisions, consider those of us on the ground that are standing in the gap, watching the play out of mental health services that are not being addressed and the social determinants that are further exasperating them. I too work with Dr. Chapman because I believe that we need a comprehensive system of care. Our citizens should not be able to access drugs sooner and more readily than they can the care that they need. Thank you very much, Councilwoman, for the time to testify today.
Thank you, Ms. Hamilton. And I just want to underscore what you said. I'm in 100% agreement that it shouldn't take longer for residents to access care than it would take for them to access drugs. And I think that should be incumbent upon all of us in the district government to ensure that that is not the case. I want to say thank you to all of these panel of witnesses. I have a couple of follow-up questions and a couple of follow-up statements. So first, Mr. Bing, we did include your name in the recommendations that we sent to Chairman Mendelson for the Opioid Abatement Commission. And as I just talked to Dr. Bazran and her folks, the chairman has not yet sent those names in. And so we're going to follow up. That's something that we need to do on our side to follow up with him to see whatever the particular next steps are, because we want to make sure that this commission gets off and running this summer. The beauty I find of the Opioid Abatement Fund and Commission is that there is a lot of possibilities to do some of the work that both Rhonda Hamilton and Rhonda Johnson brought up around addressing not just the addiction pieces, but the coexisting other social conditions that folks are facing, whether it be housing, whether it be the mental health piece, like addressing the comorbidity pieces and some of the stuff that Dr. Chapman talked about, but also Dr. Diaz from the Office of the Chief Medical Examiner. For some folks, if you have hypertension and diabetes, and now you're introducing opioids as well, it is a very much more potent combination that we have working. And so we need to be addressing all of those various pieces. Dr. Goldman, if you're still on, I wanted to ask a clarifying question if I heard you correctly. I think you said you were talking about the need for more care coordination. In particular, you mentioned contingency management. Can you did I hear you right when you said contingency management? And if so, can you say more about what that is?
Yeah, so contingency management is a program that incentivizes vulnerable populations, for example, people abusing opiates, and it incentivizes them to stay in treatment and to attend their treatment appointments. And I know that the federal government is now allowing Medicaid dollars to be utilized for this. And contingency management is one of the only programs that has been shown for people with, for example, meth addiction or opiate use disorder to stay clean. And even after the incentive program ends, people are shown to actually stay clean longer. And so the state of California is now piloting a contingency management program throughout their entire state. And I have been in talks and trying to see if we can pilot something in the DC area. And there are a lot of people like Dr. Chapman who are very excited about an idea to use this in this space.
Okay, thank you for that, because we were wondering over here, what is contingency management? So this is helpful for us to be able to follow up and get some more information on. I have a general question for anyone who wants to chime in. We just finished the government witness panel, and one of the things that came up is Dr. Bazran saying there is no wait list for residential treatment facility beds. And I thought that was curious in that might not be the known out in community. And so I want to hear perhaps some feedback from some of you who are on the ground in terms of your thoughts on that. Ms. Hamilton, I see you shaking your head.
I think that it is obvious. It speaks to what exactly you're here. It's not strange. It's just not right. It's exactly what's going on. We have a disconnect. And unfortunately, I challenged the mayor in the 2022 general election for this very reason, so that the community's voice would be heard. We simply feel that there is a disconnect coming out of the administration to matters on the ground. And while I don't want to take up too much of your time, I can tell you it exactly is representative of what's going on. We're hearing that all these services exist. We're hearing that programs are available. We're seeing ribbon cuttings, but on the ground, it's grim. And we don't understand the disconnect. And so citizens are pulling away, and you have your representations at the voter box. Folks are disengaged because they do not believe that the processes in place are meant for them. And that is just too dangerous.
Ms. Quinn or Dr. Goldman, do providers know we have beds available?
Yeah, so I do want to echo the sentiment that was just stated. There are a lot of policies that go on that never actually reach the ground. And from an ED provider, I don't know all the programs that are going on, but I do know there are a lot of people being paid to sort of chaperone people into these programs, and they're not doing their job.
Okay.
Every single day, I have people, I try to reach out to Medicaid MCOs, I try to reach out to different, organizations, trying to figure out who the behavioral health providers are. It is impossible. And I will also say that these MCOs create these barriers that make it impossible for providers and patients to actually get the services that they are entitled to. And again, I just want to echo that it doesn't seem that despite having years and years worth of failing scores, it doesn't seem that these MCOs are actually ever held accountable.
Thank you, Dr. Goldman. I'm over my time. Councilmember Gray, do you have any questions for this panel?
Panel having such good input, and we'll follow up with our staff as much as we possibly can. So thank you so much. We appreciate that.
Thank you, Councilmember Gray. I just want to note we've been joined by Councilmember Brianna Nadeau, Councilmember from Ward 1. Councilmember Nadeau, I just wanted to give you an opportunity if you have any questions for this panel.
Nothing from me, Madam Chair.
Thank you, Councilmember Nadeau. Thank you so much to this panel. I think if you guys, if some of you have been listening in, you know that our last expert panel, I was talking about youth, and they basically said, oh no, we need a whole nother hearing to talk about that. So this is not going to be our only conversation on this issue, because I feel like we have to unwind this. Frankly, having 458 fatal overdoses, but over 3,500 in total tells me this is a crisis, because we're talking about the fatal pieces, but we're not even talking about the near misses and the work that needs to happen there. Ms. Quinn, did you want to say something as I move on to the next one?
Just that there was a real theme on this panel that is about engaging people on the ground with real lived experience in strategies, solutions, innovations, and DCPCA strongly supports that.
Yes, ma'am, we do as well. All right, thank you so much to all of these panel, or to all of you for testifying. We're going to go on to the next panel. For those of you who are waiting, again, if this is the first time that you're testifying with us virtually, you need to affirmatively accept our invitation. I only have 8 more people on my list, so I'm going to call all of the names that I have, and then we'll go from there. So Peter Wood, ANC 1C03, Shane Sullivan, Victor Battle, Dr. Joseph Muller, Ami Anjal, Jamila White, ANC 8A05, Dr. Patrick Canavan, and Anna Jones. Guys, just give us a moment while we transition. I do see Peter, so Commissioner Wood, why don't you go ahead?
Hi, thanks. Good afternoon. So my name is Peter Wood. I'm an advisor neighborhood commissioner in Adams Morgan in Ward 1. To be honest, a lot of people have already said all of the important points. So I'm really just here to kind of reinforce a lot of what's been said by people here today, and really just from people in the community that I've talked to, both as commissioner. Also, I do some volunteering with end-of-life services, which kind of overlaps in terms of pain mediation. And as a former researcher who did some research on related subjects, really basically 3 questions I want to go over, just kind of give us a scope of what my perspective is, but also I think just kind of summarily what we've heard today. So 1, just identifying what is the problem that we're hoping to fix. So, I mean, we even see it in the kind of words that are used throughout the media, throughout different policymaking circles of what we're talking about here. I would argue that it's not necessarily helpful to refer to what we're dealing with as an opioid and fentanyl crisis. The crisis isn't that opioids and fentanyl exist, it's that people are suffering and dying. Of course, the substances that lead to that are an important factor, but I think terminology and semantics really do matter. There are a couple of aspects to the problem. One is obviously local. So locally, we can control the laws that we use, and we've seen the lasting effects of years of criminalizing matters of health, and the overdose crisis really reaffirms that when people are treated as criminals for behavior that is a health emergency, it doesn't get resolved. It often gets exacerbated. It often gets exacerbated for decades and generations, and we're continuously cleaning that up. A lot of that's also tied to really what I think is just lack of stability. We see that in a lot of people's testimony today, the little bit that I've been able to catch, which is things like displacement or housing instability, job loss, social instability, even other types of just lack of kind of a solid foundation in one's life. Those are things that either lead to or exacerbate the vulnerabilities that are a huge part of the overdose crisis. This is, I know, not new, but I think it's important to point out. But as I already kind of alluded to, overdoses are caused by various substances like opioids, fentanyl, xylazine. But I really think it's important, I think that I've heard it on a few occasions mentioned, that it's not just about specific substances, it's about the dynamics which create those substances creating problems. Or kind of put differently, there's always going to be substances to fill in gaps in a system if the system is bad, and those substances are in some degree arbitrary. Of course, when you get into the chemistry and to the medical resources, the specifics do matter, but we need preventative care, not just reactive care. We need overdose care. We don't need further criminal policy to address something that just really isn't adequately addressed as a criminal matter. And just on the other scale, federally, of course, that's made complicated because Congress is kind of, especially when it's run by Republicans, but Democrats too, often attacking ideas like harm reduction and decriminalization, which could really pose to benefit a lot of people in DC and elsewhere. So second question, what are possible solutions? Generally speaking, resources, they need to be located where people need them. It's a complicated, often multifaceted question, but we often see that we can have investment, but it's not necessarily being placed in positions geographically that are advantageous to just incentivizing use or just increasing access to those. But kind of more broadly speaking too, I think that reducing stigma is really important. It's kind of an old trope, but I think it still bears repeating, which is we got to win the public opinion battle, especially in DC, considering that we have this constant additional pressure from the federal government. We need to make it so we hold strong and really reduce those kind of social perspectives, which make it even harder to just address or even establish what the problem is in the first place. So third, last question, what can we use the funds that we have access to now? Well, how can they be best spent? It's of course a nice issue to have, which is you have money to spend. So I break it into those two kind of categories. Infrastructure, specifically put, I support overdose prevention sites. They need to complement multiple services. This is really important. I've heard one criticism saying that there's not enough research on overdose prevention sites. In my experience, this is kind of the opposite, that sobering centers, in juxtaposition with sobering centers, I think that sobering centers actually lacks the research, pretty well-established research, and you can go onto PubMed and check it out yourself, but they're important. Education and culture, I also think that that's kind of something that has to complement this. Overdose prevention as a label, I've heard, is often better than safe injection. Things like that can be really helpful just in terms of how we kind of market things. But without decriminalization of substance use, this money spent will be a short-lived bandage. It's instead of bandages, we need deeper change. We need empathy from our elected officials, which I do see coming, and I really want to applaud it. And we really need a culture of caring. That's all I have. Thank you so much.
Thank you, Commissioner. Shane?
Good afternoon. My name is Shane Sullivan, and I'm the harm reduction coordinator at HIPS. It's really hard for me to be here right now because there has been so much loss that I'm going to try to speak to from a detached point of view, and I'm not very good at that. So I'll do my best, but I've worked within HIPS's outreach department for 4 years and for a decade as a volunteer. During one of my first shifts on HIPS's mobile van, I remember us distributing a pamphlet about a series of bad batches of heroin that had made their way along the East Coast, killing over 40 people across multiple states. It was my first time learning about fentanyl. And because that was nearly a decade ago, the pamphlet was essentially a do a test shot, use slow, and with somebody present, like good luck kind of safety tip, because it wasn't until 2016 that DC piloted its first naloxone distribution program, permitting CBOs like HIPS to actually distribute Narcan, and fentanyl test strips were criminalized until December 2017. I'm sharing both those examples and that anecdote because it highlights a pattern endemic to this government's response to DC's overdose crisis of stalled reactionary responses that are perpetually years behind what is needed to prevent further death and promote the health and well-being of people who use drugs in our communities. By the time HIPS have finally had reliable access to funding for fentanyl test strips, the vast majority of our opioid using participants were already dependent on fentanyl because it had replaced the street heroin supply. And so right now they're functionally useless for most people. The toxic drug supply that is killing people I love alongside the HIPS participants I care about deeply is perpetuating the war on drugs, which has always just been a war on people. I also just want to note that we had 604 fatal overdoses last year, if you include OCME's count for stimulant-related deaths. So it's not just 458, it's 604 total. What we're witnessing is mass poisoning parallel to alcohol prohibition in the 1920s that the US government could choose to intervene in tomorrow and prevent mass death via safe supply, exactly as we now have with alcohol. That's not going to happen. So instead, I'm going to try to be quick with the recommendations that I have. Again, repeating the ask to allocate $15 million to establish 2 24-hour harm reduction centers with on-site drug checking and safe consumption services, including one east of the river. I've attached in my written testimony the Live Long DC report recommending that DC establish at minimum 4 fixed sites and 1 mobile site. So 2 is a conservative estimate as it is, given that Live Long DC in collaboration with HIPS, Whitman Walker, and DC Health already recommended 4. Overdose prevention sites are one of the most well-researched public health interventions in existence, and that research overwhelmingly shows how effective they are at preventing death and supporting drug user health. This is, as Peter Wood just testified, in stark contrast to sobering centers, which are not a harm reduction model, do not have the same proven track record, and should not be prioritized by an administration that brought in an Arizona-based conglomerate that is notorious within its own state for providing poor care to its patients. My second recommendation, outreach investment. We talk a lot about it. I rely on volunteers for the shifts that I lead on our outreach van. Pretty much every shift that I lead is alongside 2 or 3 other volunteers with food and water that is donated from them and other supplies like care supplies that are donated from them. We need to invest in programs like HIPS, Family Medical, Us Helping Us, Miriam's Kitchen, and we are also traumatized. We're trying to engage with people who are criminalized and facing other forms of marginalization, including recent reentry, unstable housing, lack of housing, disability, medical vulnerability, engagement in street economies, despite.
Shane, if you could wrap up you're over your time.
Oh, sorry. My last recommendation is really just repeating the call for decriminalization and also to actively incorporate the voices, not just of people with lived experience in recovery, but people in active use as well.
Thank you, Shane. I don't see Victor Battle, but I do see Dr. Muller. Dr. Muller?
Yes, good. Thank you for Chairpersons Henderson and Gray and the rest of the members of the committee. My name is Joseph Mueller. I'm an internal medicine pediatrics physician at Unity Healthcare and an addiction medicine specialist. And I'm really glad that this roundtable is occurring. I'll give some brief background on our organization and then have some specific requests from the committee. So Unity Healthcare is the largest network of community health centers in DC, serving about 100,000 patients each year. And of our patients, 90% are people of color, and more than half have incomes below the federal poverty level. Nearly 70% of our patients are either on the district's Medicaid or Alliance programs, and we serve them in a number of different settings. We have 9 community health centers, 11 sites located within shelters and other organizations serving patients experiencing homelessness, 2 school-based health centers, as well as our mobile unit. And in addition, we are the medical contractors in the DC jail. And throughout the overdose crisis and the opioid crisis before it, we've been trying to provide marginalized and under-resourced communities in DC with high-quality addiction care integrated into comprehensive primary care to address a lot of the comorbid conditions, medical and social, that a lot of the other speakers have spoken to. And last year, Unity served about 1,200 DC residents with opioid addiction. And our full continuum of care, from pediatrics to geriatrics and from our case management team to our pharmacies, is engaged to help our patients prevent developing addiction. If they do use substances, to prevent progression to addiction or other negative health consequences, and to help anyone regardless achieve their goals of long and healthy lives. Our primary care providers work to address pain while minimizing exposure to chronic opioids. Our pediatricians help educate adolescents about the benefits of avoiding or delaying use and using safely if they are going to use. Our mental health clinicians help develop alternate coping mechanisms for many people experiencing traumas or other mental health challenges. And our case managers help connect people to the disparate services and benefits that can help them, as Rhonda Hamilton alluded to earlier. And our peer support specialists help engender hope that people suffering from addiction can come to feel better. So there are many patients who have benefited from our convenient access, especially east of the river, but throughout the city, including patient Daryl, who had been using intermittently before his mother passed. And then after she did, saw a progression of his use and finally a loss of control. And after he was hospitalized, he identified his addiction to the medical team there and worked with them to connect with us after his release. And he told us, you aren't going to stop in one day or 1 week, but again, you have to start somewhere. And that was his goal of stopping entirely. So with that as background, there are 2 specific areas that we feel that the committee can enhance our work. One is by addressing staffing shortages. There is a critical shortage of substance use treatment programs for adolescents, especially residential programs. I know another speaker spoke to residential programs for adults, which we haven't seen any challenges of patients getting into, but residential programs, as other speakers have alluded to, are not a panacea by any means. And actually, outpatient programs that can be more flexible for people to engage in while continuing with their other obligations of life are actually the greater shortage. We are seeing a really difficult time finding behavioral health and mental health providers to work in primary care and outpatient settings and addiction treatment settings. And programs that will help enhance education and training with that focus and that cultural experience to work with us in Ward 7 and Ward 8 are critical. The other area that Shane had alluded to with reentry, Unity is under the supervision and partnership of the Department of Corrections, provides medical care as well as behavioral health care to adults who are incarcerated in DC. And with their support and the support of the Department of Behavioral Health, we've implemented universal screening for substance use disorders and evidence-based treatment for opioid use disorder that starts at intake. We've also created residential treatment programs in the jail, which incorporates group-based therapy, medication, and individual counseling, as well as trauma forward care. But expensive but effective medications like long-acting opioid agonists and hepatitis C medications are really valuable to offer in the jail, and we're currently limited by funding. And our patients who leave often face huge barriers to meeting their custodial needs with CSOSA, as well as continuing with their medical care and their other daily needs of life. So more funding to expand and enhance those services can better support returning citizens. Thank you very much for your time.
Thank you so much for your time as well. I don't think we have a copy of your testimony. Is that something you could provide to the committee?
Definitely.
Okay, great. I don't see Ami or Jamila, but Dr. Canavan is here. And then Councilmember Nadeau will call the next panel or call the next witness after he's done. Dr. Canavan? Dr. Canavan, if you're speaking, you're still on mute.
How's that?
There we go. There you go.
Great. Thanks so much. Good afternoon, Chairperson Henderson, Chairperson Gray, Councilmember Nadeau, members of the committee, Dr. Bazran, and behavioral health leaders, and all those very, very interesting and engaged witnesses who spoke today. I'm Patrick Canavan. I'm a Ward 1 resident, a clinical psychologist, a former DC government employee, and now I'm working to ensure behavioral health and primary care are fully integrated in the district. I really appreciate the tenor of today's conversation and really focusing the opioid and fentanyl crisis in the district through the lens of public health crisis. It's pervasive, it's impacting everyone. The prevention measures, outreach, education, harm reduction strategies, and peer specialist workforce development are all issues that have been well described already, and I endorse these streams of work that are necessary to address this crisis. Today, I'd like to focus a little bit on access to substance abuse and mental health care in the district. As you heard earlier, Dr. Goldman mentioned the district emergency departments at the front line of reacting to this crisis. EDs across the district are overwhelmed with individuals who seek mental health and substance abuse treatment because it's one place where they know they will get care. But the emergency department is very expensive and among the worst places to get behavioral health care that is trauma informed. Trauma is something that goes hand in hand with addiction, and a person who experiences trauma does better in a calm environment with specific focus on their recovery plan, not a noisy, overcrowded, and high pressure ED. The ED may be a place to get medical care, but for treatment that addresses behavioral health emergencies, I suggest we consider creating alternative behavioral health urgent care centers across the district. It's the right place, available at the right time to offer evidence-based trauma-informed care, including effective medication. It's for individuals who have a behavioral health crisis related to substance use disorder, mental health disorder, or intellectual or developmental disabilities diagnosis, or any combination of those. And peer specialists are embedded members of the treatment plan, the treatment team, and help with both education and engagement. And that's both with the individual seeking care and with the team. The Behavioral Health Urgent Care Center can provide triage, crisis risk assessment, evaluation, and intervention to individuals whose crisis response needs are deemed to be urgent or emergent. It's an alternative, not a replacement for the emergency department. Individuals receiving this service will be evaluated and stabilized and referred to the most appropriate level of care. It can be 12 or 24 hours a day, 7 days a week, 365 days a year. And it'll provide a number of different interventions, including assessment, de-escalation of crisis using proven interventions, overdose reversal, medication management, medical treatment, psychoeducational activities, and also start to look at putting in place a plan to manage modifiable risk factors. Dr. Goldman spoke earlier about contingency management, and this is a necessary and I think effective, research-wise, effective opportunity for us to start to look at post institutional care in an important way. So if an individual needs to go to a community hospital, they can be transferred there. And if there's no bed immediately available, the individual can be placed in an observation bed for up to 23 hours. I think these are behavioral health urgent care centers in the district can be a major positive entry point during urgent or emergent behavioral health situations. I also think it would allow the district to consider how to redistribute funds that are not well spent with emergency department treatment that is suboptimal in most cases, and certainly one that doesn't further the restoration of person's high-level functioning and living a long, healthy life. I want to thank you for holding this very important hearing, and I can be available to answer any questions you have. Thank you.
Thank you so much for your testimony. Our final witness today will be Anna Jones.
Thank you. Thank you, Councilmember Christina Henderson, Councilmember Gray, Dr. Bazran, and Councilmember Nida. I'm pronouncing it wrong. I apologize. It's an honor to be here. My name is Anna, and I'm a woman in long-term recovery. And what that means for me is I haven't picked up a drug or a drink since August the 30th, 1999. And through God's grace and mercy, on this year, I'll be celebrating 24 years without any mind-altering substances. I'm also a peer. I'm a family member who has had 2 brothers overdose. I'm an advocate now who's advocated in DC for us to get the Good Samaritan law, which we now have, but we need to do some work on it because we are not getting it out. And there's still a lot of stigma around it. And a lot of people are still dying because people are not giving them Narcan to save their life. So I am here to talk about the opioid crisis, but I get really emotional because this hits home for me as a family member and as a woman in recovery and as a woman who gets an opportunity to work in the field and see people who are recovering. So I know we do recover because I know me as a Washingtonian, if my life was saved, other lives can be saved too. According to the Center for Disease Control, Washington, DC is now #1 in the nation for all drug-related overdoses and is second in opioid overdose deaths behind West Virginia. The chief medical examiner stated that last year alone, 458 DC residents died of overdoses. This is an average of 37 people each month. Washington, DC has even experienced 24 overdoses within a single 24-hour span last year. Overdoses are rising in almost every age range, including under 16, 20, 29, 30, 39, 40, 49, 50, and 59 age groups. The opioid deaths total over 6 years through 2017 through 2022 have even doubled homicides. This impacts every ward and every neighborhood in the District of Columbia. Now is the time to declare the opioid crisis a public health crisis like Virginia, Maryland, Pennsylvania, and other surrounding states around DC have already done. Overdoses are preventable when the crisis is prioritized. This is urgent, and as a decision maker in Washington, DC, you can help save lives. So I just wanted to state that. I'm also a member of the DC Recovery Community Project, and we promote a lot of advocacy around the overdoses in the District of Columbia. So I'm just asking that we declare DC an opioid crisis because it is a public health emergency. Thanks for letting me share.
Thank you so much for your testimony. I want to thank everybody. I don't have any particular questions for this panel. I do want to check with Councilmember Gray to see if he has any that he wants to offer. Okay, well then I will thank this panel. Truly appreciate your testimony today. I want to express, in closing, I want to express my appreciation to each of you and on behalf of Councilmember Henderson for your invaluable contributions and commitment to addressing the opioid fentanyl crisis in the district. Our discussions today have been enlightening, thought-provoking, and full of promise for the future. And I want to express my gratitude for Councilmember Gray for co-chairing the roundtable and for his dedication to addressing the opioid crisis in the district. Today, we have delved into the challenges posed by the opioid fentanyl crisis, examining its far-reaching impact on our communities. Prevention remains paramount in our fight against this epidemic. We must intensify our efforts to educate and empower our youth, equip healthcare professionals with the necessary tools and resources, and raise awareness about the dangers of opioid misuse and fentanyl contamination. Equally vital is our commitment to expanding access to treatment, recovery, harm reduction, and support services. It's incumbent upon us to ensure that individuals struggling with addiction can access the care and resources they need, free from barriers and stigma. For anyone who was not able to attend and speak at today's hearing, we'll accept public testimony until July 12th at 5 p.m. You may submit written statements to Ashley Strange at astrange@dccouncil.gov, or you may leave a voicemail at 202-430-6046. If you leave a voicemail, remember to speak slowly and spell your name for the record. There being no further business before the committee, this roundtable is adjourned. The time is now 5:04 p.m. Thank you.